Okay, so good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. It is 1:05. We try to start on time. I want to thank our committee for always being on time and all the work that you're doing. We really appreciate it. And staff, they're working really hard. We have 34 more days. Okay, 34 more days. Who's counting? We are. So I want to go through some of the rules on this committee today. I am your chairman, Jocelyn Peña-Melnick, joined by my vice chair to my left, Delegate Bonnie Collison. I kindly ask for your patience if we encounter any technical or streaming issues. They'll happen where the Zoom doesn't work or we can't hear the person. Just relax. We're going to make it work. I promise you. I know there are a lot of people today. Last night, we were in hearings very late, but we do listen, okay? These proceedings are recorded and we also go through the files, before we come here. So know that we're paying attention. Please set your devices to vibrate. I'm going to do that because sometimes you get embarrassed when it rings. Hint, hint for someone to my left. He knows who he is and we love him anyway. We love him anyway. As a reminder, there's no food or drink in the gallery, and that's because our staff will have to clean after you, and it's not right. They have so much work. And then you will see us drinking, and that's because we sit here for hours without standing up, and we need to hydrate. For each bill, this is what I decided in this committee. I do not time the sponsor. However, do not abuse that, please, that courtesy. Don't make me have to stop you. For everyone else, your testimony is limited to 2 minutes, and you're gonna see that there is a timer displayed on the screen and a sound will play when your time has expired. I'm not rude. I'm going to give you time to wrap it up, but wrap it up with 1 sentence, not 10. All right? Because we have a lot of witnesses. Please adhere to our wonderful committee, and you've been doing great. And we have been allowing more follow-ups just to understand the bills fully, but also try to be brief. Members of the public, you'll be able to view these proceedings on live stream on the Maryland General Assembly website and on YouTube. I'm going to give the order of the bill hearings now. However, I have a caveat. I may need to change it because our members have bill hearings in other committees. So you'll see them get up and come back, or the witnesses are not here. For example, the first bill that I have, I'm going to call it second now because we're still waiting for a wheelchair transport, okay? And we want people to be here. So we're going to start with House Bill 1149, Hospitals and Related Institutions, Outpatient Facility Fees. If I may have the Attorney General, and will you be so kind, Mr. Attorney General Brown, and bring your panel. I believe you have Marceline White, Matthew Celentano, Catherine Ross, Rachel Swindle, and you have Heather Forsyth. And if there's someone else that wants to join, just bring some chairs. Meanwhile, number 2 is going to be House Bill 822. Then number 3, House Bill 1333. Number 4 will be 1051, followed by 1293, followed by 1036, followed by 1048, followed by 1304, 1078, 1040, 986, and the last bill 1006. However, that order may change, so I need you to pay attention to the screen out there so that if your bill is called, you're here and you don't miss it. I want to thank you all for coming. I know it's not easy to drive to Annapolis, find parking, come through security. So your voice is important and we care. So let's get started with House Bill 1149. Attorney General Brown, how are you?
I'm doing well. Thank you, Madam Chair, for asking. I want to thank the members of the Health and Government Operations Committee. My second appearance before you this session. And for the record, I'm Attorney General Anthony Brown here, testifying in support of HB 1149. If enacted into law, HB 1149 would provide patients with the information they need to make informed decisions about where to obtain affordable health care. HB 1149 expands the existing statutory notice requirement, and it requires the health services Cost Review Commission to lead a study of the impact of facility fees on the healthcare system in Maryland. HB 1149 will align Maryland with current best practices around the nation in the crucial areas of consumer choice and healthcare affordability. Under current law, hospitals can charge patients a facility fee for services provided by any healthcare provider it employs and at any facility it owns, even if the patient never sets foot in the hospital. It is important to note that HB 1149 does not prohibit those outpatient facility fees. I think that's important to note. As we consider this bill, do we come in and prohibit it, or do we simply say, hey, you know what? Just let's make sure consumers and patients have more information. Make an informed choice. You want to pay the extra fee? Pay the extra fee. You don't want to pay the extra fee? Talk to your provider and say, hey, there's got to be alternatives here. Let's talk about them. It is a consumer notice bill. In 2020, the General Assembly passed the Facility Fee Right to Know Act. I'm going to refer to that as the Right to Know Act. After hearing from and about countless consumers who were surprised to receive large hospital bills for services like routine eye examinations, EKGs, and MRIs. The Right to Know Act requires hospitals that charge outpatient facility fees to provide patients with a written notice containing specified information, including if a facility charges a facility fee. During deliberations on the 2020 bill, now here, listen closely here, because you may hear contrasting interpretations of what you did in 2020. In 2020, the OAG, this was before I was here, okay, but the OAG, the Office of the Attorney General, proposed that the notice requirement should apply to all outpatient services. That was in the bill. It was moving through the legislature. And as things came to pass at the very final few minutes, if not moments, of the General Assembly, the bill was amended. And that's what happens. We get it. The notice requirement that was included in the final statute was limited only to clinic services, not what we introduced or proposed. It leaves consumers in the dark with relation to a wide variety of other outpatient services. So HB 1149 would change that. I'd like to say it's just a curative bill or corrective bill. That would be oversimplifying. It is a substantive change. I'll acknowledge that. Since you passed the Right to Know Act, the Office of the Attorney General, my Health Education Advocacy Unit, continues to receive complaints from consumers. You've heard me say this to you before. We don't come to Annapolis in this day and age as the Office of Attorney General just with good ideas, just with things so sort of like in the abstract. Let's protect consumers. I come to you because I get complaints. I get complaints from your constituents that say, hey, I got another surprise bill. I didn't know about this. And if anyone wants to tell you that, well, they do get notice, well, guess what? It's just not good enough because they're still being surprised and they're still reaching out to our office, which you created in the Office of the Attorney General to look out for the interests of consumers. So the fact that the Health Advocacy Unit continues to receive these types of complaints illustrates the need to expand the Right to Know Act to better protect patients. Too often patients are unaware that a regular doctor visit that takes place in a place other than the regular doctor's office is in fact taking place at what is considered a hospital, and that they may be billed by both the provider and the hospital for the services rendered. Patients consistently complain that they should be given information when they make their appointments, not when they show up, but when they make their appointments, so that they can decide for themselves whether to see the provider at the hospital or at another location where facility fee is not charged. In addition to expand the provisions of the Right to Know Act, and I'm going to summarize here so I can go through this quickly, we want this to apply to out-of-state facilities. Some out-of-state facilities are telling us, hey, Maryland law doesn't apply. So when you look at the bill, if you look at my written testimony, we're correcting that as well. If you're an out-of-state actor, you too are subject to this notice requirement. There's also a piece in there I already mentioned about the Maryland Health Services Cost Review Commission. I don't think there's any dispute about that. Looking to a study to look at outpatient facility fees, sort of its impact on the industry, on hospital care and quality of care. It's an important study. It's going to take probably several years to do. So when someone comes and testifies and say, hey, we're supporting with amendment, okay, let's just keep the study but take out the notification, that's not really what's going on. They're supporting the study, which we do. But if you take out the notification provision, then we're going back to 2020. We're limiting the notice to patients Health Education and Advocacy Unit continues to get the complaints from your constituents. Okay, they continue to see triple, quadruple what they expected to see in a bill because they're seeing stuff that was not clearly explained to them that HB 1149 would correct. So as Maryland's Chief Legal Officer, I ask for a favorable report on HB 1149.
That was quite clear. I have to say that your office is amazing. I am a little partial to the Health Education Advocacy Unit. They're really great. And their materials they give us, the letters, when they take a position is very thoughtful. So very proud of them.
Thank you. And
And I'm
share
not
that with
saying
all
that
of them.
because they're sitting there. Because those that know me know that I say exactly what I feel. But anyway, go ahead.
And I have felt that.
Good afternoon, Madam Chair and members of the committee. I'm Heather Forsyth, Deputy Director of the Health Education and Advocacy Unit at the Attorney General's Office. And thank you very much, Madam Chair, for the opportunity to provide additional comments in support of this bill. As the Attorney General indicated, since the 2020 Right to Know bill became law, HGO, our office has continued to receive consumer complaints, such as those who filed testimony on this bill and in our own written testimony, which I hope you'll review. There's multiple consumer stories in that testimony about consumers who are confused and outraged by unexpected fees across multiple outpatient settings. Now, opponents will argue that the administrative burden on hospitals is too high or that patient confusion may cause patients to decide not to receive care or that Maryland should wait to see how the No Surprises Act is fully implemented. But to those arguments, we ask you please to consider, should the burden of disclosing costs to patients outweigh the burden to patients of undisclosed and unaffordable costs? Should hospitals or should patients decide whether or not patients decide to receive care based on cost, particularly since hospitals have a financial interest in the decision? And should Marylanders have to rely on the if and when of federal regulations that may take years to promulgate to receive the protections the General Assembly can provide for them today under state law? Recognizing Maryland's unique hospital rate setting model, this bill does recommend an extensive study. And some might suggest to you that you should wait until the study concludes before tackling the notice protections that we're offering. But if we do not provide at a minimum the disclosures patients need to make informed choices, then for too long, consumers will continue to be blindsided by unexpected and unaffordable bills. They simply can't wait. So we please ask for your support in all the provisions of this bill and for a favorable report. Thank you.
Thank you. Next, please.
Yes. Hi, Madam Chairwoman, members of the committee. Good afternoon. My name is Rachel Swindle. I'm a researcher at the Georgetown University McCourt School of Public Policy's Center for Health Insurance Reforms, and I'm honored to be here today. The stories shared by the Attorney General's office highlight how persistent the issue of unexpected facility fee charges is for consumers. This proposed bill's provisions expanding the scope of the pretreatment notice requirements would certainly bolster the existing consumer protections and align Maryland with other states with similar reforms. This bill is also important in the broader context of healthcare costs. Increasingly consolidated healthcare provider markets, complex billing systems, and inadequate insurance coverage, such as high deductibles and separate cost sharing for provider versus institutional bills, all play a role in consumers' increasing financial exposure to these charges and in the growth of outpatient facility fees. This increase in facility fees drives up overall healthcare costs, as facility fees are a key component of hospital outpatient spending, which is one of the most rapidly rising components of healthcare spending. And ultimately, this results in higher premiums. In response to this trend, a growing number of states are implementing several types of reforms, often with the goal of informing and protecting consumers. Further, in the last year alone, other states grappling with this issue have newly required studies exploring the impact of facility fees on consumers and healthcare costs. These studies have been mandated to provide state policymakers with recommendations for further reforms, reflecting the reality that provider consolidation and escalating healthcare costs continue to put pressure on consumers and challenge policymakers. The study required by this bill would shed much needed light on the scope and impact of facility fee billing in Maryland, and critically outline potential policy solutions that are tailored to the unique characteristics of the state, such as the all-payer rate setting system. Thank you for your time.
Thank you for your testimony. We appreciate it. Next, please.
My name is Catherine Ross. I live in Baltimore. I'm presenting information in favor of House Bill 1149. My 6-year-old daughter needed an outpatient service at Mount Washington Pediatric Hospital just a few months ago. I tried to do my due diligence. I made sure our private health insurance was accepted. I asked questions about the forms that I was signing, trying to make sure we wouldn't have any unexpected fees. When I got the bills afterwards, it turned out that the facility fee alone was nearly $4,000. With our insurance, we were responsible for 20% of that, and we ended up paying nearly $800 for the facility fee. My issue in part was with the high amount of the facility fee. It certainly was hard to swallow, but also that I felt I had no way of knowing this information ahead of time so that I could make informed decisions about my daughter's care. After doing some research, I learned about facility fee disclosures, and as near as I could tell, this was something that I should be able to obtain. So when my 3-year-old son needed a brain MRI at University of Maryland Medical Center just last month, I tried to do things a little bit differently. A few days ahead of his appointment, I was going through forms for the online check-in process, and I read, "You have the right to request and receive a written estimate of the total charges for hospital non-emergency services." So I started making phone calls. Looking back at my call history, I think I made a dozen phone calls over a period of several days. I was bounced around to multiple departments at UMMC, most people telling me either they had no idea what I was talking about, or someone else could help me, or actually I needed to call the office of the doctor who ordered the scan, get the procedure codes, and then talk to someone else. Finally, the day before the scan, by the end of the day, I had an email with the information I had requested. In practice, the information I was told I had a right to felt nearly impossible to obtain. I share my experience because I believe that having a clear sense of anticipated fees ahead of time is a vital part of accessible healthcare. Thank you.
Thank you. And I'm sorry that you went through that, okay? And I hope your baby recovers.
Thank you.
You're welcome. We're gonna open it up for questions now, and then we'll go some other panels. I see Delegate Lewis, followed by Delegate Vice Chair Collison.
Thank you, Madam Chair. Thank you, Mr. Attorney General, and to your panel. The 2020 facility fee bill, that was one of the first bills I ever did here in HGO. And I remember how difficult it was to reach the negotiated settlement on the terms of notice and everything else. So I'm really pleased to see you bring this back. I have a question for the young lady who just testified about a $4,000 bill. I'm curious, does your, if I may, and if this is too intrusive, don't answer. But I'm curious, does your health provider use a mobile app to allow you to schedule appointments, to give you notifications, something like the My Chart app, if that's familiar to you?
Yeah, we have a lot of, I have 4 kids. We see a lot of different providers, and we have a lot of My Chart patient portal kind of systems. Yeah.
But you did not see a facility fee notice in your My Chart?
No, but I didn't look for one in there. I didn't use the app for that appointment.
Okay, that's okay. That's very helpful. I do know that I have seen the facility fee notice in my Chart app, but not every app may use it, and not every appointment would have it show up. Thank you for explaining. Thank you, Madam Chair.
You're welcome. Vice Chair Collison.
Thank you, Madam Chair, and thank you, Mr. Attorney General, for this bill. I just need clarification, and where it says if located, a hospital is an institution that if located outside the state provides outpatient services to patients in facilities in Maryland. Does that mean that we are charging a hospital that is outside the state? I mean, we have the ability to regulate that. I'm just asking for clarification.
Yeah, there are some hospital systems that are regulated outside the state who have an office in the state or a facility in the state. Children's Medical Center, and I think it's called Children's National Medical Center, might be one example of that. So they're not regulated as a hospital because they don't fit our hospital definition, but they have a location in Maryland. I think they even have a couple where they offer outpatient services. And currently they do not provide any notice for any sort of service because they think that we're not the boss of them. So.
Yes, thank you, Madam Chair. Thank you, Heather. So what we're requiring of them by virtue of the fact that they have a facility here in the state to follow the notice rules that we have.
That's right.
Okay, all right. Thank you very much for the
Thank
clarity.
you.
Thanks.
Any other questions? Who will be the best person to address the concerns of the hospital association a little more in detail? Because they're gonna come up favorable with amendment and you're not in agreement with the amendment because they don't want to, basically they just want the study, correct?
That's my understanding, is that they are suggesting that we just do the study and that we wait until the study concludes and recommendations are made and legislation is offered in order to do anything about the facility fees. And we respectfully, Madam Chair, we would oppose that amendment because in the meantime, in the long interims, consumers are going to continue to be harmed by these very large and unexpected and unaffordable bills. And as the Attorney General said, we're not recommending in this bill to do away with facility fees altogether. What we're asking for is transparency. Please just give the notice so that the patient has all the information that they need to make an informed choice about where to get their healthcare services.
So can you answer this for the committee since you won't have an opportunity to respond to their concerns? On page 2 for the committee of their position, paragraph 3, actually page 1, paragraph 3, it says implementing the current notice requirement was a very large undertaking for the Maryland hospital, right? We know they did that. The definition proposed under House Bill 1149, which is the bill we have here, is extremely broad and would include any regulated outpatient facility fee charged by a hospital. This would include observation, outpatient surgery, imaging, laboratory, and a host of other services. Not only would hospitals be unable to comply with the law's notice requirement in many instances, such as when the services are on schedule, it will likely further confuse patients and may unintentionally encourage people to not seek essential medical care. Can you address that, please?
So I think there's 2 or 3 different things to unpack there. There are certainly instances, for example, patients who have ongoing courses of treatment, walk-in patients, patients who are just there for observation. And we can entertain amendment language that addresses those certain situations, but those should be the exception, not the rule, right? That there are some situations that we recognize that this may not be completely amenable to. But the issue of suggesting that notice should not be provided to patients because they might decide not to seek medical care is really disenfranchising the patient from making their own decisions about care, particularly if you're then going to give them a large, unexpected, and undisclosed bill for that care. I think that's part of the equation that the patient needs, part of the information that the patient needs to decide. And there's also an assumption there, which may or may not be true, and certainly is not true in all cases, that the patient can't get the treatment somewhere else without a facility fee. And so that, again, should be part of the disclosure. I'm not sure, did you want to add anything else? Okay, or did you? Yeah.
I think you answered well.
Okay,
There are
thank you.
instances
Thank you.
that the amendment that should be thought of, and I know the Hospital Association is gonna testify next, should be one that would exclude those instances where they think it may not apply.
Right.
Right. Any
We
other
can
questions?
certainly work with them on that.
Thank you, and we would need you to do that. Thank you for volunteering. I don't see any other questions for this panel, so thank you so much for being with us today. You have a
Thank you.
blessed day. Really
Thank you.
appreciate
Thank
you.
you
so
members.
much.
Thank you.
Thank you.
You're welcome. Next, we have Marceline White, Matthew Chantilano, and Actually, you know what? Can you hold on before you come? Let me be balanced. Let me bring a favorable with amendment panel, okay? Peggy Townsend. What is it? I know, but I'm calling a favorable with amendment because they were favorable and I don't want us, you know, like call all the favorable and then the rest, okay? Trust us, our madness makes sense sometimes. Good afternoon, Peggy.
Good afternoon, Madam Chairman, members of the committee, Peggy Townsend, on behalf of the Maryland Hospital Association.
Were you here last night, late last
I
night?
was here for a good bit last night,
You
and
slept
I'm
over
back
here, right?
again.
You slept over there. Go ahead.
And we are here favorable with amendments, and I think, well, you've heard a lot of my testimony because the chairman read it, so that's good. But I think as she was reading those situations where they're unscheduled and you're going from your doctor's office down to the lab, down to the MRI machine, it's really unworkable to expect that in that situation. But having said that, what the proponents just said, well, yeah, there's some situations that aren't amenable to this notice. Do we know what those are? That's why I think there are so many tentacles associated with the broadening of this definition that we better figure out, and my suggestion is to figure out what exactly fits into this category for appropriate disclosure and what does not. Because this is like everything that goes on in a hospital that on an outpatient basis, you'd have to give a notice for. The last point I want to make before the questions is the purpose of facility fees. It's not a bad thing. It recognizes that hospitals have to be open 24/7, 365 days a year. There is overhead associated with that. That's what the facility fees recognize, is that we're not just a physician office. We have all this other stuff we have to do to keep the lights on and provide care 24/7. So that's the purpose. It's not any nefarious thing. It has a legitimate purpose. So with those comments, I would ask for a favorable report, but let's figure out what the impact is with this definition before we move forward in a very substantial way.
And thank you. I see Delegate Johnson, followed by Delegate Lewis.
Thank you, Madam Chair, and thank you, Peggy, for coming, explaining things to us. Now, you said if they have an appointment at the doctor's, then go down for an MRI or X-ray. So that would all be in the same facility or same campus. So don't they get one facility fee for all that, or do they get a facility fee for each item?
Well, they may not know they need an MRI or an X-ray. They come in for an appointment and the doctor says, oh, you better go get an X-ray for this and go down the hall. And that they didn't know they were going to need the X-ray when they made the appointment.
But if they come to the campus, don't they get charged a facility fee?
They do for the appointment.
Okay,
But they may get another facility fee for the lab
so they get additional facility fees for each
because
area?
it's the overall overhead associated with that service.
That would seem like they would, to me, more of a need for notice than to know what it's going to cost them.
But how would you know that the patient you haven't seen yet needs an X-ray?
No, I agree with that,
That's-
yeah.
And if I may, just for clarification, were you done? Go ahead, you finish. Usually I wait till my members ask their questions, but you just, you forget sometimes. So I'm gonna go ahead and say it and thank you. I owe you one. Most of the times, unless you go to Kaiser, you don't get the procedure done the same day. Like it's hard to get an MRI schedule. It is really difficult to schedule anything. So you just for clarification, usually it's very tough to get a procedure done the same day. You usually have to go home, call, and it takes a while, Anyway, thank you. You have any questions? Okay, it was Delegate Lewis followed by Shalega.
Delegate Johnson,
I can see how our day is going to go today.
Thank you, Madam Chair. Thank you, Ms. Townsend, for your testimony. So I was just recalling that I've introduced the facility fee bill that is now law. First introduced that in 2019, and it took 2 years to pass. We finally got it over the finish line with the help and expertise and hard work of the Hospital Association, HEAU, other consumer protection advocates. We worked really hard for 2 years to get the bill that we have now. And it's good, but it could be better. And I think that's, right and proper, that we should improve, existing law to serve the people of Maryland. But I remember hearing an argument like yours, Ms. Townsend, 4 years ago when we were all young and free. And I remember hearing that good old days. I remember hearing how that from the hospital association, that would be really difficult and complicated to anticipate the various pathways that a patient might take in a facility, across facilities, across time. And that was 4 years ago. And in the 4 years since, the world has evolved, healthcare has certainly evolved, and hospitals are amazingly good at figuring out problems and building new solutions. So I wonder, from your perspective, 2024 perspective, do you think that hospitals might be in a better position today to help anticipate, predict, recommend how we might identify possible facility fee transactions in advance? Because when I heard that 4 years ago, it took us 2 years to get the bill over the line. And when I hear it now, it makes it, I just wonder if we haven't come further and if we can't figure that out now.
I'm certainly willing to work, but for example, an observation patient, how do you tell them while they're in the bed that there's a facility fee? I mean, it's logistically, it's a logistics problem. And I would suggest that the change in this definition makes it exponentially more broader than it was as the current law is. I think it's an exponential broadening.
Sure.
I'll take Delegate Johnson's follow-up question. Is it, so one of the, I remember that debate, and I wonder if it might be worth considering, in your view, to provide a menu of potential fee impacts for clinic visits. For example, would it be so difficult to tell a patient going, to the internal medicine clinic, your visit will have X dollar facility, may have an X dollar amount facility fee. In addition, you should anticipate, if you are referred for laboratory or other medical services, you may also have another facility fee. Please expect that this may happen and call your insurance provider to find out what this might look like. Is that something that might be considered?
I would certainly like to think about that and chew on it, but it's really an interesting approach.
It's one we talked about 5 years ago, actually. Now 2019 was 5 years ago. So I look forward to further conversation. Thank you, Madam Chair.
You're welcome. Delegate Shalega, thank you for being patient.
Thank you, Madam Chair. Good to see you again. It's only been not that many hours ago that we were all here together. So remind us, what is the facility fee paying for?
It's for the additional overhead associated with hospitals. It's not, so you're providing a surgery, right? The surgery center isn't open 24/7. The hospital is. There's overhead, substantial overhead associated with having to be open 24/7, 365. That's what it's for.
Okay, yes, which makes sense. But when a person visits a physician's office in the hospital, that physician's office is not open 24/7.
And we took care of that the last time.
Okay, so when
And
you were
for that
saying
reason,
that a person visits a physician and then the physician sends them down the hall for an X-ray. We're not talking about the O'Day Medical Arts Building connected to the hospital, or are we? There's a, St. Joe's
Oh,
has
okay.
a, sorry, you knew what I meant.
Yeah.
St. Joe's has a physician's building attached to the hospital. So when I visit my family practice doctor there and she sends me, am I getting a facility fee in her office and then at the X-ray office?
Well, it depends. I don't know if that office building is considered at the hospital. Do you know?
Yes, but if the fee, yes, I appreciate that. So, we had a discussion on the floor today about how fees should pay for the services, that they provide. So if it, makes sense, 24 hours, 365 to have to pay for all of that. But can we not bifurcate and say a physician's office in that building isn't open 24 hours a day, so it does not need all that. So the facility fee would not apply to that.
I don't know that we can do that under federal law. Facility fees are under Medicare reimbursement. I don't know if you could just say you can't charge a facility fee.
Yeah, so maybe the key there is to look at the definition from the feds to say if what can and can't be, just because the building's attached. If the rationale is it's 24/7, that doesn't fit with my PA, office next in that building.
Right.
Okay, thank you.
You're welcome. Actually, that's an interesting Attorney General letter to request. The AG is here, so can you get back to us and tell us whether we could get rid of it? Not that we're gonna do it, but if you could.
So, Madam Chair, we'll work with any member on framing up the right question for us to answer.
Yeah. So my team is here. My team is here and we're gonna make the request, okay? Thank you. Delegate Gazzoni.
Thank you, Madam Chair. It's sort of funny because we did not chat about this on the side over here, but my question is sort of in a similar place. And it sort of blends a couple things. My mom is in Massachusetts, and a couple of years ago, she had some hard things going on. And so we went to her cardiologist and he immediately sent her downstairs for blood work and an X-ray. I have no idea what kind of relationship his office had. The building we were not at the hospital, but I don't know whether or not that building is considered anything. So I'll tie it to sort of Howard County where I live now, where around the hospital, there's lots of buildings. I routinely see a doctor in the Charter building, which is seemingly full of people that are associated with Hopkins, but I don't know if that's considered, I don't know how that works. So I guess my question is, how would people know whether or not they're in a place that's going to have this fee?
And that's when you have to look at whether the building is considered at the hospital. It's unique to Maryland. In other states, there's facility fees in all kinds of places. In Maryland, it's only when it's at the hospital. And how is that defined? If it's at the hospital, then it's rate regulated, then you get the facility fee. It's unique and it depends on the configuration.
Okay. Any other Delegate Bagno? Oh, let me go to Johnson for a second. I've been going to the left a lot. You go to the right.
Well, thank you, Madam Chair.
Okay. Not literally, but just thought I would correct that. Like, go ahead.
Okay. All right, thank you. Begin what I was dwelling down to before. Are there standard facility fees for an MRI, an X-ray? Are those set fees? Are they standard fees, or how does that work?
It's even more complicated in Maryland because we're under global budgets. So hospitals have to adjust their rates constantly to be able to stay under that global budget cap. So it's hard to say with precision what the charge is going to be on March 8th because they have to adjust.
You're really done now. Okay. Delegate Bagno.
Thank you, Madam Chair. And I think I have more questions than answers. But something you said before, when you said that this is unique to Maryland. So we only, charge facility fees for associated buildings to the hospitals. So does that mean we know where these facilities are? We already have an inventory as we're looking at this legislation.
I'm assuming we do. I would think the HSCRC would have to know what is considered at the hospital for Hospital A.
Okay, thank you.
And you're right. Who is next? All right, that's it. Thank you, Peggy, for being with us, and I'm sure we'll see you again. Great seeing you. The last two witnesses are Marceline White and Matthew Celentano, and they're actually favorable. Yeah, take that picture.
Who is that masked man?
Yeah, take the picture.
I know.
Go ahead. This is becoming a regular thing. Go ahead. Go ahead, Marceline.
Great. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Marceline White. I'm the Executive Director of Economic Action Maryland. Economic Action Maryland works on economic rights, equity, and housing justice through research, education, and direct service work. We're here in strong support of House Bill 1149. I just want to make a couple points. As the sponsor panel clearly articulated, this bill builds on the good work of this committee by expanding this transparency to extend to outpatient services and outpatient facilities. As I've talked about before this session, we did research in 2023. We did a Gonzalez poll. And in that poll, we found that in Maryland today, 23% of Marylanders are suffering from medical debt. There is a stronger and higher impact on households of color, of Black and brown households. But importantly for this conversation, 40% of the medical debt is from outpatient services. So what I would say is that we can't afford to wait for a study. A study is important and data is important. We want to get the information and refine it and make sure it's precise. But 40% of medical debt coming from outpatient means the time to act is now. Transparency is a cornerstone of consumer protection. All we're doing is letting people know what these fees are so they can make informed decisions. And for these reasons, we're in strong support of House Bill 1149 and urge a favorable report.
Thank you, and thank you for your work.
Thank you.
Madam Chair, members of the HGO Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP in support of House Bill 1149. We want to thank Attorney General Brown for bringing this bill and this important discussion forward. Carriers over the last few years have been hearing more and more complaints from beneficiaries that providers are charging them fees, sometimes small, sometimes very large, on top of their insurance premiums, their negotiated insurance premiums, and their cost sharing. Frankly, this issue to me is the new balance billing. It is an unreasonable potential revenue source that is being created on the backs of unknowledgeable consumers. You're all aware that we've heard before that the MGA worked on this issue a couple of years ago, but you're also aware from all the testimony you hear in this committee that folks are overwhelmed by the healthcare system. They go into facilities, they go into their doctor's office, they talk to their insurance provider. There are reams of pieces of paper that get put in front of them, all kinds of paperwork. And to add an additional facility fee in that stack of paper, we think is unreasonable. And we'd like to continue the discussion forward about how we could potentially, I think, eliminate facility fees. Like I said, I think it is the new surprise billing. We believe that they should be outright prohibited, but I understand that's not going to happen. And I know there's a bigger universe and regulated spaces in the HSCRC and the waiver, the third rail of Maryland politics in this committee. All right. But I want to see this bill move forward because I think this is an important discussion for consumer protections, and we urge a favorable report.
Thank you. Any questions for this panel? Seeing none, thank you very much for being here today. And we love the combination. It's great.
See you tomorrow.
Yes, I would like to ask, if I may, for a second, is Peggy still here? Peggy and Heather, And Delegate Shalega and Delegate Lewis, will you please meet and discuss that list that Peggy had in her testimony of things that it may not apply to? And see if you can come up with something that it will. All right, will you do that for me, please? Would someone please take the lead in scheduling that meeting? Okay, thank you so much. I appreciate you. This actually concludes the bill hearing on House Bill 1149. We are going on to House Bill 822. Delegate Collison, your sponsor panel is Joshua, Janice, and Chiffon Gray. If you can come up, please. And I know I want to thank everyone for being patient. Can you remove, the chairs? Thank you. And I want to thank everyone that's waiting for their bill to be called. Thank you for your patience. Yes.
I'm not, there we go. I wasn't gonna touch it.
Thank you. That will set a bad example, Vice
Yes,
Chair.
indeed. Madam Chair, first of all, I want to thank you and the HGO team for the amazing accommodations that were made for my panel today. You all have been very supportive and I truly appreciate it on their behalf. And I want to say, I am probably more humbled than I've ever been in front of with a panel in front of you before. And I am so honored to be sitting with these individuals in front of you. You know, we all experience hardships and challenges in our lives. And sometimes we get through them, or most of the time we get through them. Think about this morning when you were coming to work here. You got in your car, drove here, may not have even thought about where you were going and missed your turn. I didn't do that, but walked here from the hotel where you're staying without a thought about how you were going to get in the building or how you were going to navigate the building once you got in it. But today I'm sitting with folks who face those challenges every single day. Everything they do, they have to think about in advance. They have to plan. The reason we are second instead of first is because the transportation was late for one of my panelists. So I want you to think about that context as we talk about this bill with a significant fiscal note. I just ask you to hear me out. And we can talk about it. We can see what we can do. But think about the folks who are here today. It is because of their absolute resilience and unwillingness to give up. And all they ask from us is the opportunity to live full lives as active participants in the communities in which they live. Thank you for the opportunity to present this bill to you today. What it does is it provides the opportunities and a predictability for a full life for our residents who have significant challenges and face more barriers than most of us will ever imagine. This bill adjusts the financial eligibility for those in the employed individual and Employed Individual with Disabilities Program, EID, in a way that will remove two of the barriers that currently exist in the program itself. Now, I've been here 14 years. I've sat in front of this committee many times talking about the challenges and accommodations and the barriers and the services that folks need in order to stay in their homes. And I just learned about the EID program. And I have to tell you, when I learned about it, I was extremely excited because the program, I'm proud that Maryland offers it. And I am, so excited that folks can take advantage of it. So I'm thinking that some of you may be in the same place that I was. So I want to tell you a little bit about what the program is. And I didn't even know this existed, but it is a buy-in program to Medicaid. And it's for individuals with disabilities who are currently working and paying taxes. And because they are currently working and paying taxes, they don't meet the financial eligibility for Medicaid services. When they buy into Medicaid, when they qualify for the program, it covers medical services that other insurances do not cover, or it can supplement services that a private insurer doesn't cover. Those who to participate and who have the Social Security insurance income, they can save with this program. By being in this program, they can save up to $12,000 a year. So here's who can be in this program. You have to be between 16 and 65. You have to be working and paying Maryland taxes and federal taxes, but Maryland taxes. You have to have a disability that meets the Social Security medical criteria. And I want to tell you what that is. It's the disability as the inability to engage in any substantial gainful activity by reason of any medically determinable physical or mental impairment, which can be expected to result in death, or which has lasted or can be expected to be a part of a continuous period of not less than 12 months. That's right out of Social Security. You have to be a citizen of the United States or a non-citizen who meets the immigration status requirements. There are different levels of immigration status. We've talked a little bit about them. You have to live in Maryland. You have to have less than $10,000 in resources available at hand, and you have to be employed and have evidence of paying taxes. However, under the current policies and the way it is now, enrollees who are married, who marry, they are penalized because their joint income is used to calculate monthly premiums. This strongly discourages marriage. And it sometimes leaves people alone or just living together as an unmarried couple. And then the big one is that once they turn 65, they're no longer eligible. So this bill seeks to remove those restrictions and to assure that these individuals can live their full lives as long as physically possible. They're getting these services in their homes. The alternative is for them to stop working, give up all their assets, and be covered by the state in a long-term care institution. That's the alternative to allowing them to staying on this program. This bill will be heavily amended. We have already been working closely with the Department of Health, and I think you'll hear from Mr. Moran in a little while. It was intended to be a cross-file with Senator Klausmeyer's bill, but they made a change in the LRE when they submitted it that they didn't tell me about. So they got, as my staff said, the bills got divorced. However, we are working them out so that the final bill will be a cross-file.
And they're going to reconcile without counseling.
That's right. They will reconcile without counseling. And we'll be sure to conform the bills, and the fiscal note would change as well. I'm not going to tell you that the fiscal note will go away, but I will tell you that it will be decreased. So once again, I'm here before you asking for your support for some of our most vulnerable, perhaps some of our most courageous residents. Listen to the stories who live this every day, and with an open mind and an open heart, honor their courage, their resilience, and their determination to be full participants in our communities. I humbly, most humbly, ask for a favorable report. And I'm going to turn you over to Josh Basil, who was the leader of this little gang up here and has made real pathways and making the challenges that he and his friends are facing known so that we raise awareness. So Josh, I'm going to turn it over to you.
Thank you, Delegate Colson. Esteemed members of the HGO Committee, my name is Josh Basil. I wheel before you urging the passage of HB 822. At the age of 18, a beach accident left me paralyzed below my shoulders, but it did not break my spirit. I returned to school. I went on to graduate from undergrad and law school with honors. After passing the bar and becoming employed, I enrolled in the Employed Individuals with Disabilities EID program to maintain Medicaid. This program is vital to accessing long-term care supports like attendant care and nursing care. Since then, I've faced challenges due to strict EID rules, limiting earnings and savings, and punitive measures around marriage. Progress has been made. As of January 1, 2024, a state plan amendment went into effect, removing income limits and creating independence accounts for savings. HB 822 represents an opportunity to further dismantle existing barriers, especially those Marylanders wishing to marry and for those who wish to work over the age of 65. My love story began in 2019 on a Match.com date. I quickly fell in love with Katie and her beautiful daughter, Fable. They welcomed me into their lives and loved me unconditionally for all of my abilities. After getting engaged with Katie, she underwent IVF, and we welcomed Calder into the world. Unfortunately, those in the EID program who are married are punished by rules requiring spousal income within the monthly EID premium calculations. If Katie and I were to marry, just based on her salary as a school employee, my monthly premium would immediately jump from $55 per month to $500 per month. Even with this premium jump, Katie would not receive any health benefits from the EID program. A total of 22 other states do not include income for a spouse within premiums. I do support the policy that the more I earn as an EID recipient, the more I should pay, or my premium should increase. HB 822 is not just good public policy. It's about love, family, and the right to pursue work without constraints. I urge you to support HB 822. Thank you for your time and consideration. Thank you, everyone.
Thank you for your testimony. How's that baby boy? I know I saw him on the Zoom meeting.
Just turned 2. He's now in preschool. He's growing up too fast.
Well, he has a great role model. Next, please.
Good afternoon,
Good afternoon.
Chair, Vice Chair, and Committee. My name is Janice Jackson, and I am a resident of Baltimore City. I support House Bill 822. I have taken this position because in 9 months, my life will take a very devastating turn unless this bill is passed. In 1984, at the age of 24, I was a pedestrian and I was hit by a car. 1 minute, a very successful woman. The next minute, a woman living with a disability. My whole life changed, and I had to make a decision on whether my disability would define me or I would define my disability. My number one goal was to get back into the workforce. I was very successful, and I love just being a taxpayer and being out in the community. Through schooling and the EID program, this was made possible. I joined the EID program, which allowed me to work, and that work included teaching as an adjunct professor at the University of Baltimore, teaching business ethics, as well as now I am a community liaison still at the University of Baltimore with the Hofberger Center for Ethical Engagement. While I was teaching, there was one course I taught on the isms. Sexism, I could check. Racism, I could check. I really would not like to check ageism. When I turn 65 this December, under current rules for the EID program, I would lose EID eligibility and the Medicaid it provides. I would not qualify for community-based Medicaid in any other way. Medicaid is the only form. Okay. I guess
You
I'm
can
talking-
take your time. Go ahead.
Okay, I'm sorry. Medicaid is the only form of health insurance that covers the intensive attendant care I need to survive and to live and work in my community. I also have Medicare, but Medicare does not cover these services. There is one other way I would qualify, and as the vice chair stated, is to enter a nursing home. I would receive enough care to survive, but would lose my home, my job, my community, and my quality of life. To top it off, keeping me in a nursing home would cost Medicaid over $130,000 a year, much more than it costs to provide services within my home. It will be far more expensive that will confine me to a substandard existence than to let me continue to lead my rewarding life. Please be in favor of House Bill 822. Thank you.
And thank you for sharing your story with us. And
You're
so sorry that happened. And I'm so glad you're here. And I
Thank
love
you.
your spirit.
Thank you so much.
You're welcome. Next, please.
Okay. Good afternoon, Chairwoman and committee and panel. My name is Chiffon Gray. I'm from Baltimore City. And I'm going to share my story. First of all, I do back this House Bill 822 and it extending further past 65. I'm going to share my experience. I am a blind individual with very little vision. I was born blind, premature. And so I had to navigate the world. This is all I know. I went to the School for the Blind, got all my, techniques and assistive technologies, but I'm always going to be needing assistive technology. I'm always going to be needing medical assistance just because I have some other medical issues. Now, if it weren't for this EID, quite honestly, I wouldn't be sitting here. I would either be in a nursing facility or dead because the life-giving medication that the professionals are administering to me are helping my body be in balance. And as a blind individual, it is very dangerous to try to, administer medicine to myself. This is a lifelong thing. And also the opportunity to work. Every disabled person wants to work. It makes them feel a part of the community. It helps the economy, in my opinion. And without this bill, I would not be able to work. I'd have to make a choice between work, no insurance, or be in a nursing facility just to have medication administered to me every day. So I back this bill. I hope you really consider, what the disability community has to go through just to even get here, let alone live a normal life. Thank you.
And thank you for sharing your story. And I'm so glad you're here. Thank you very much.
Thank you.
I'm going to open it up for questions now. Are there questions for this panel? Delegate, I saw Delegate Kaiser first, followed by Chisholm.
I just lost my notes. Thank you, Madam Chair. To the Vice Chair, I do have a question, but I first want to say, as I'm looking at my notes from February 12th, when I met with Joshua and Janice, like you describing learning about this issue, I got off of that meeting, that Zoom, and had to call my wife and say, oh my God, I just had a meeting. I don't know in 22 years if I've ever had one like this. And how touched I was. But I would ask you, and I want to reference the fiscal note, Madam Vice Chair. I want to live in a state that does exactly what they're asking for. I mean, that's where I want to call home. So I want to ask you, the fiscal note always looks at direct costs and benefits. In terms of the indirect costs and benefits and some of the issues being brought up, how can you address what some of those are and how this in the end might even be a cost saver?
Well, I think one of the most powerful indirect costs is in the human aspect of it, in terms of folks being able to, as they've just explained, being active partners and participants in the community and in the economy of Maryland, because they are all working and paying taxes. So that, I think is something that a fiscal note is never going to speak to. But the economic part, the fiscal part is, as I alluded to, and as Janice said as well, the alternative is, if you cannot live by yourself without support, you will end up being paid for by the state. And as Janet said, it's about it. And I think the $130,000 a year is a little low for the cost of a nursing home. And imagine, my heart breaks just thinking about them being in an institutionalized setting when they are able to be active and participate and be thoughtful and to work in being a lawyer, being a teacher. And so those are things that I think are the most beneficial to the program. And I appreciate your comment, Delegate Kaiser, because like I said, I was very excited to learn about this program.
And many of the workers who enroll in this program end up getting thank you, buddy. End up getting private health insurance through their employment. So that private health insurance helps save money on their, like you said, paying taxes, paying a higher premium now that the income limits have gone up. There's just so many, and many of the people that enroll in this program rely on Medicaid. So they're going to be on Medicaid regardless of the fact. So taking away employment, it's cost neutral in my opinion at that point. It's just really good public policy, and we support so many programs in Maryland through DOORS, Department of Rehabilitative Services, spending millions upon millions of dollars to getting people with disabilities to become employed. And then right when they become employed, you rip out the rug from underneath them. If we're going to do it from the beginning, let's meet them at the end as well.
Thank you. Delegate Chisholm.
Thank you, Madam Chair.
You're welcome.
This is probably going to be, isn't that so? But thank you for bringing this bill. As you know, my wife, Aunt Brenda, lived with us for 8 to 10 years. And she worked at OBI, and it used to drive me nuts that at OBI, they had one person who was dedicated to making sure they didn't make over an income threshold. Because if you went over that income threshold, it eliminated you from all of these services, nor could she ever have more than X amount in a bank account. So I was very happy last year because it did come out of this committee, the independent accounts, which encouraged them to start to save money rather than punish them. And, when I thought about it, I was like, so essentially we are trying to discourage upward mobility. We're trying to discourage investment. And when you think about investment, the way I think about investment, and with the, when you talk about compounding interest, and you start working young and you start to put money away and you have the compounding interest, no longer are you dependent on the state. You become financially independent. And it bothered me terribly because we had people, and we've always had this push, or we've had this push in the last few years of, we want our disabled citizens out in the community and working out in the public. And now we still didn't take apart the aspect of we're punishing them by earning more income and punishing them by saving. So, and I'm always adverse to fiscal notes. So, but I understand, and I really do appreciate the bill. I think it's an outstanding bill. Hopefully, you can find some magic pebbles to figure out the fiscal note and make this work. But thank you for bringing it. Thank the panel for being here. Isn't that so?
Delegate, I would say that is so. Thank you very much for your comments. But I would add that the Department of Health is willing to work with us. They've sat down with me a couple of times, and with Josh and Janice. We're not there yet, but they're talking to us.
And the fiscal note should be, because of the amendment that was made by Delegate Colson, the fiscal note for SB 790 should be a little bit more reflective. So it should be better there as well. But also one of the other indirect cost savings that I would bring up is by letting someone going above the age of 65, and now that we've created independence accounts, after the age of 50, anything that remains in an independence account, actually there's a Medicaid payback provision. So if that person were to die, any money left over in their savings would go back to the state.
Thank you. Delegate Hutchinson.
Thank you, Madam Chair. Delegate Kaiser, I did the exact same thing, if she's still down there. I remember when I met your panelists on the Zoom call, I called Beth up immediately and said, I just cannot believe what I just heard. And so Delegate Cullison, thanks for bringing this bill forward. This is my favorite bill of the 2024 season, even more than rad techs are. So
Madam Chair, I think that makes it bipartisan.
You know what? A lot of our bills here, which is why, this is a really unique committee. Like, we do a lot of it bipartisan, and because health doesn't care who you are, right? Whether if you have cancer, it doesn't matter what party you belong to. It's the human aspect of it that matters. And I'm not saying this because you all are here, but you all are really wonderful human beings and you get it. So anyway, go ahead.
Josh, it was great to meet you on the Zoom, but it was 10 times better to meet you in person today and have a conversation with you and seeing the pictures that you brought to share with us. I just want to make sure I heard you correctly in your testimony, though. If you were to marry that beautiful woman in that picture, who's the mother of your child, your premiums would go from 55 to 500. Is that what you said?
Yes. So currently, and then as my income increases, my premiums will go up, and I'm proud to pay more money in my premiums. So like it's one of those incentives. The more you earn, the more you can give back to the system. But when it comes to Katie's income, it's so expensive living with a spinal cord injury. Like, just to buy a vehicle is almost $100,000. The wheelchair is $50,000+. I have over 30 to 40 grand a year just in out-of-pocket expenses. So where you can save money as a family, you try to. So that premium penalty is pretty big. Thank you.
I don't see any other questions. I just want to thank you for being here and for taking the time. It's stressful even, under normal circumstances to come to this building and go through security and all of that. And it's so tough when you're not able to. So the committee, we want to thank you for making the time, okay? And I have a good feeling that the fourth year, this is the charmer, that this might be it, okay? The Department of Health, the secretary is wonderful, she gets it. And Dr. Moran as well, and they're at the table. So I'm sure they will come up with some compromise. I want to ask one thing that the fiscal note should note, and I really hope that we can change this, is that in instances like this, for example, you are working, right? Some people have insurance. We're not paying for that, right? Like that saving should be reflected in that fiscal note. The fact that you're able to get out and you're not in a nursing home, that should be reflected in the fiscal note. And in addition to that, the fact that you have a life to the extent you can, right? And have a family, and the happiness should be reflected in that fiscal note as well. It should be the whole picture. And maybe we can do something about that in the future, in the interim, and talk about that. You have a blessed day, okay? Thank you for coming.
Thank you, Madam Chair.
And just a shout out to everyone in the audience. We've got anybody with behind the disability community that's here. They came a long way as well. And just thank you for coming.
So we have a few more people we're gonna call, but I do want to give a shout out to my team, Andrea, who's standing in the back. Andrea, raise your arm, your hand. You know, she's been standing there the whole time because she opened the door, closed it. Michelle Furman and Andrea, who took care, who's right there. Michelle, raise your hand, who really go the extra mile every day for everyone. And they made these accommodation, and, you know, we could not do the work without them. I just want to acknowledge them because they work really hard and put up with a lot. So thank you, everyone, okay?
Can I acknowledge one person, please?
Sure.
We have Miss Wheelchair America 2024, Miss Chandra Smith, who was Miss Wheelchair Maryland 2023.
Oh, congratulations to you. Congratulations. Very proud of you.
Yes.
You have a blessed day, okay?
too,
Next,
ma'am.
we have Matt Rice. And is the last favorable, and then we're gonna have favorable with amendment from the Department of Health. Mr. Rice? And thank you, everyone, for being patient. Really appreciate you. See you.
Thank you, Madam Chair. Thank you, Madam Vice Chair, members of the committee. My name is Matt Rice. I am the Executive Director of People on the Go Maryland, which is Maryland's statewide self-advocacy organization for people with disabilities. We are here in strong support of House Bill 822 because this, to our mind, is the way that we encourage people to be involved in the workforce. I myself utilize the EID program, without which I would not qualify for the waiver supports that I need in order to live independently in my own home in Woodlawn with my 2 cats that rule my life, but I wouldn't have it. I wouldn't have it any other way. I'm also here because I want to support my fellow advocates, people that inspired me to get it into this field in the first place. People like Janice Jackson, people like my friend and mentor, Ken Capone, who now runs his own ice cream business. So we talk about people who want to be tax-paying citizens. This is a great piece of legislation in order to do that. And we know the fiscal note is high, but what will be the ultimate cost to the state if we do not allow people to work? We have to create a culture of work for people with disabilities. I myself have a brother that's on the autism spectrum. Right now, he's taking care of my mom, but eventually I want him to be able to enter the workforce. And whatever he decides to do, I don't want him to be punished because so please support this legislation. Thank you very much.
Matt, I have a dog named Mango who rules my life. It was great hearing your testimony, and I'm so glad you're doing well, okay? Other questions for Matt? Seeing none, you take good care.
Thank you, Madam Chair.
Bye-bye. Thank you.
Know where to find Ken Capone's ice cream.
So we can buy ice cream. Go ahead.
Oh, I'm sorry. He has a shop in Elk Ridge, but I don't have the exact address, but I will make sure I get that and pass it along to the committee.
You know what? I miss him because he will come for every single bill hearing that dealt with the disability community. And I would love to, in the interim, for the HGO committee to visit his shop. So can you give us his address, please, when you get it?
It's a Cold Stone in Elk Ridge.
In Elk Ridge? All right, we'll look for it. We'll have staff look for it. And
Okay.
committee, we're eating ice cream in the interim, okay? We're gonna do that. Thank you. Have a blessed day.
Thank you.
Thank you. So we have our last witness of the day for this bill. It is the favorable with amendment, the Maryland Department of Health. How are you?
I'm good. Good to see you, Chair.
Nice to see you.
I think you all made this Medicaid day in HGO. There's a number of different, so you made my scheduling very easy. First, I just want to extend gratitude to Josh and Janice and their team. We have been working very closely with them over the course of the past year under the new administration, as well as on this particular piece of legislation. So I want to say that the department is supportive with amendments on House Bill 822, and specifically, I want to highlight how over the past a couple of years, the department, but specifically over the past year, we have worked very hard to expand the program of individuals who are eligible as part of the Employed Individuals with Disability program. Specifically, we have budget authority and we updated our state plan amendment accordingly. Prior to January 1, there were about 1,000 individuals enrolled as the program. But for 5 different expansion opportunities in the current piece of legislation, we expanded that with more than 1,200 individuals who would potentially qualify. This bill takes those 5 things and it puts them directly into statute. And that is what that's what the department is favorable and in support of as part of this. I'll just highlight quickly those 5 changes: lowering the eligibility age of the program from 16 to 18, eliminating the income requirement and disregarding all retirement accounts for participants, creating the flexibility for independence accounts for participants, disregarding spousal income and assets as part of applicant eligibility, and setting new premium levels for higher income eligibilities. These particular changes, and I know that there's some additional expansions related to the premiums, but they do eliminate the biggest hurdle of the previous barrier that prevented individuals from getting married by eliminating spousal income and asset tests for eligibility purposes into the program. There are 2 components of the bill. That part of this bill includes that we set up 2 work groups per year with the department that we were continuing to work on. And in fact, we scheduled those meetings just over the weekend. The first one's on May the 6th. And those 2 components are looking at the spousal income and how that is calculating premiums and the age cap of 65. So the department has continued to have conversations with advocates, including Secretary Beatty and the Department of Disabilities, as we navigate both the fiscal impacts of those, which is driven largely within the particular piece of legislation, as well as other equity considerations when we think about eligibility for other Medicaid programs, particularly when we hit the age of 65. So with that, Chair, the department supports with amendments, and I'm happy to answer any questions you may have.
Thank you. And I want to thank you because the department has been great to work with. I mean, as a chair, I can tell you, all of you, yourself, the secretary, I shouldn't start naming names because I'm going to leave someone out. Marie Grant and June and Aaron, all of you have been great. So we thank you on behalf of the committee. I know that the sort of sticky point here is the premium and the age of 65. And, to hear that it goes up from 55 to 500, that's pretty steep. And if they're working and they're 65, if they could stay on, I hope that the department, that you're able to come to some compromise on those issues that are outstanding. Because this is the 4th year we have this bill and it really will make a difference in their lives. So I hope that I know you will continue. I don't have to hope because I know you and you always make yourself available. If you both can continue those conversations, that would be wonderful.
Great. Thank you, Chair.
Thank you. Any questions? And thank you so much for being at the table and for everything that you're doing, because God knows you hear from all of us. So thank you. This actually concludes the bill hearing on House Bill 822. Next, we have House Bill 1333, and it's Maryland Commission on Health Equity Membership and Statewide Health Equity Plan. And it's actually, if I may have the Secretary of Health, Dr. Laura Herrera Scott, that would be great. Marie Grant, John Crum, and Good afternoon, Madam Secretary. How are you?
Good. How are you, Madam Chair?
Good.
Good afternoon, everyone.
34 more days to go.
I know.
Yeah.
We have our little tear off.
You need one of these too.
Oh, we don't have that.
We need to take a chill pill and keep cool in the next 34 days. Go ahead.
Good afternoon, Chair Pena Melnick, Vice Chair Collison, and members of the committee, Laura Herrera Scott, Secretary of Health, for the record. Thank you for the opportunity to testify today in support of House Bill 1333. As I have testified before in this committee, the Department and the Health Services Cost Review Commission are applying for the all-payer health equity approaches and development model, otherwise known as AHEAD, as the continuation of our unique total cost of care model. One of the requirements of this application is to establish or designate a statewide model governance structure. The federal government specifies membership for the governance structure, including state agencies with impacts on health, as well as health stakeholders such as payers, providers, local health departments, and community-based organizations. The primary role of the governance structure is to develop a statewide health equity plan. As we review current state entities that could serve this important role, we identified the Maryland Commission on Health Equity as its duties are already closely aligned, and it includes multiple state agencies that have roles and impacts that impact health equity and health outcomes. However, some modifications on membership are needed to meet the federal requirements. Under AHEAD, the State Health Equity Plan will identify health disparities and population health focus areas. The Maryland Commission on Health Equity will identify resources and strategies for state and local governments to improve health by considering health-related social needs, including housing, education, employment, economic stability, environmental factors, public safety, and food security. The commission will define parameters of a state health equity data set based on required reporting from hospitals and all payers. This will facilitate setting goals and measuring progress to reduce disparities and improve population health across Maryland. Federal requirements for the governance structure specify that membership must include a local health department, healthcare provider representatives, including hospitals, hospital-based population health experts, federally qualified health centers, and multiple independent clinical providers. A commercial insurer and managed care organization will offer payer perspectives. Other members include multiple community-based organizations, multiple patients from underserved communities, and a tribal community. HB 1333 intentionally restructures the Maryland Commission on Health Equity to amplify community voice in developing the state health equity plan. This is consistent with feedback from the Population Health Transformation Advisory Committee, one of Maryland's 3 transformation advisory committees providing counsel on the AHEAD development model. The committee emphasized the need for community members to have greater decision-making power regarding population health investment and accountability for outcomes. The state will continue to provide opportunities for community input during the pre-implementation period and throughout the implementation of AHEAD. Thank you for your consideration of this important legislation, and we urge a favorable report on House Bill 1333.
Thank you. Next, please. How are you?
I'm doing great. Thank you, Madam Chair. Madam Chair, Vice Chair, and members of the committee, thank you for the opportunity to testify in support of House Bill 1333. My name is John Crom. I'm the Executive Director of the HSCRC, and I'll be brief. As the Secretary mentioned, this legislation is critical for our readiness for the AHEAD model, which presents a number of opportunities to advance our collective work to improve the health of Marylanders. And one of the key opportunities represented by the AHEAD model is that it puts health equity at the center of that work, right? I would also add that one of the critical aspects of this legislation is that it would really strengthen the alignment of the healthcare delivery system, inclusive of hospitals, with the efforts of the broader range of partners working to advance health equity goals. So for those reasons, we would urge a favorable report on this bill. Thank you so much for your time.
Thank you. Next.
Madam Chair, Marie Grant, just here to say me too and be available for any questions that you ask.
Thank you. Thank you for all your work with the committee. So I'm going to open it up for questions now. Are there any questions for this panel? Delegate Rosenberg.
I'm going to jointly try and ask 2 questions.
You can ask
try
separately. Go ahead.
Okay. Why are we I think this is correct, the only state that has an all-payer plan. And what difference does it make to the citizens of this state that we have an all-payer plan?
Want me to start or you want to take it?
I think we have to choose
Okay.
one person.
Oh.
Thanks, Delegate Rosenberg. That is a fantastic big question. So there are currently, in addition to Maryland, 2 other states that have some form of model payment under CMS, but none is quite like Maryland's, right? So the first state is Vermont. They have a really unique payment structure. They started with a primary care program and sort of built up from there. And then Pennsylvania has approval from the federal government for global budgets in rural health settings. And so there are hospital global budgets in part of Pennsylvania. As the AHEAD model is really intended to be the next phase, but CMMI, I think to your point, Maryland's been incredibly successful in our cost savings and outcomes in our model. And so much of that AHEAD model is based on Maryland. And so the AHEAD model is a great opportunity for us, but yeah, no, it's okay. Thank you. So the AHEAD model is a federal health payment model that offers global hospital global budgets on an all-payer basis, and a real focus on health equity and population health outcomes, and also advanced primary care. All of those things we have to some degree under our current model. I think where the opportunity really is with AHEAD for Maryland is actually this health equity piece, really leaning in to this statewide health equity plan and population health outcomes outside of the hospital walls and across different settings.
Delegate Alston.
Thank you. Since you brought up global budget and our single payer system, I do have a question. I'm not sure how much it relates to this bill, but I just met with a hospital from my district that's having some issues with the global payment system, the single payer and global payment. Basically, they're having to cut costs at the end of the year in order to stay under budget, even though they're profitable. And I'm just not sure how that makes sense for the overall system of healthcare, and they aren't big enough. So it's creating a lot of different problems. So if you could speak to that, that would be great.
So I'm happy to meet with you to talk through the specific concerns of that hospital. I will say that managing hospital operations under a global budget is something that we've had pretty good success and a number of and all the hospitals within Maryland have had pretty good success managing under that for the last decade. So I can definitely meet with you to talk through any specific concerns. Yeah.
Okay. Any other questions? Oh, Vice Chair Collison.
Thank you, Madam Chair. Thank you all for the work that you do. It is really impressive. And it's when I first saw the information from CMS about, I don't know, 6 or 7 months ago about the AHEAD program, I immediately said, oh, they're finally catching on. And so my question is, because what this particular article I was reading was saying that there was grant funding associated with it. Are we eligible for the grant funding in that program?
So yes, as part of the cooperative agreement, this $12 million, so it's $2 million a year over 6 years. And much of that money will be used for infrastructure, especially locally, as we think about partnering with community-based organizations that can help us meet health-related social needs locally. So yes, there's 12 million, 2 million over 6 years.
Any other questions? Yes, Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
Thank you, Madam Secretary, and all your panelists. Good to see all of you. I'd like to follow up on that question about grant funding. Madam Secretary, you mentioned health-related social services. Would that include transportation, like transportation for folks getting to the dialysis appointments?
So health-related social needs is the same thing as social determinants of health, that we're evolving the language. So transportation, food, housing. So yes, many of the things that impact people outside of the delivery system that impact their healthcare. We would be looking for partners to address those needs locally.
You're welcome. All right. Seeing no other questions, I want to thank you and thank you, Madam Secretary, for working with the committee on all these bills. We're really grateful, okay? And
Thank
if you
you.
need us, you know we're here.
Thank you.
Thank you. Next, we have Joseph Nguyen, Kathleen Laurent, Dr. Daryl Gray II. And will you be so kind and bring up the virtual witness, please? Sarah Stowens. Good afternoon, everyone.
Good afternoon.
Nice to see you, Joe.
Nice to see you. Here we go?
Yes.
Good afternoon, members of the committee, Madam Chair. My name is Joe Nguyen. I'm the Executive Director of the Maryland MCO Association. On behalf of the association, we are here to support very brief comments for House Bill 1333. As the Secretary just shared, this is a critical bill for the state's progress towards the application for the AHEAD model. Additionally, the changes in the bill, or the bill outlines a very inclusive process for participation and the work that's going to be done, and that includes the MCOs, and we're grateful for that. And I have very brief comments just to say that we're supportive of it. We urge a favorable report, and I'm here on behalf of the association to answer any questions. And like to be able to yield my time to our MCO friends who would join me at the table, if that's possible, Madam Chair.
I'll do it. There's 1 minute and 12 seconds, so do 3 minutes and 12 seconds.
Thank
Okay.
you, Madam Chair. It's very generous, and I'm going to try to be brief so I can allow our expert, Dr. Gray, to speak more directly to this issue and why it's so important. But for the record, I am Kathleen Laurent. I represent WellPoint, Maryland. We are one of the largest MCOs in the state of Maryland, and we operate statewide. So we are serving constituents in each of your districts, and it is a privilege that we take seriously. And we believe this bill is going to improve our ability to serve them more fully and more equitably. We applaud the Secretary and her team for the efforts that they are making in health equity and their drive and attention to these issues. And we certainly applaud the chair for her interest in this issue, as well as the members of this committee. I have with me today, Dr. Daryl Gray. He is the plan president of WellPoint, Maryland. He is an experienced physician, and he is leading our team based out of Hanover, Maryland, in our efforts to serve you and serve your constituents. So at this time, let me turn it over to him, please.
Thank you. And thank you, Madam Chair, Madam Vice Chair, members of the committee. Good afternoon. I'm Dr. Daryl Gray. I get to not only serve as a physician, I get to serve as president of WellPoint, Maryland. WellPoint, as Kathleen said, we get to serve people across all the state. We have 300,000 members. So members who touch all your constituencies. And WellPoint is distinguished amongst the MCOs in that we are the only MCO that has National Committee for Quality Assurance, Health Equity Accreditation, and Health Equity Plus accreditation. This is something that is near and dear to each of us within WellPoint. But I also come to you as a Maryland native, someone who is committed to advancing health equity. And I also come to you as a husband and a father. And when we talk about health equity, we're talking about families. Health equity is something I'll also point out that really resonated from the Moore-Miller administration 2024 state plan. You'll recall that there were 10 priorities that were listed in that plan, one of which was to have a world-class health system. That cannot happen without having health equity, advancing health equity at the core of what we do. House Bill 1333 is key to us being able to do that and to do that successfully, because it will take rigor, it will take intentionality. And I can speak to that from experience, not only in my current role, but previously serving as Chief Health Equity Officer, one of the largest health insurers in the nation, Elevance Health. But it also will require us to be very proximal to those who experience the inequities. And that's what this House bill also does, ensures that, as the secretary mentioned, we include community stakeholders in this work. I'll close and I think thanks for yielding the time, because I want to give you a very brief story. And it's a story of my paternal grandfather, who was one of the first photographers for the Social Security Administration, who was a Navy serviceman, Maryland native, who died at the age of 48 from a stroke. This was someone with means. This was someone with family. This was someone who did not have to die as early from a stroke, but someone who was not engaged in the health system in a meaningful way. We can make a difference to that, so that his story is not many of our children's stories, certainly not mine, who are between the ages of 2 and 9. But it's going to take dedication, it's going to take rigor, and it's going to take what this House bill is going to allow us to do together. So on behalf of WellPoint, on behalf of those we get to serve all across the state, we unequivocally support this bill.
You didn't even use all the time. Go ahead. And thank you for sharing your family story and for being here with us today. We really appreciate it. Are there any questions? Delegate Rosenberg, followed by Martinez.
Dr. Ray, you mentioned your paternal grandfather. Did your father graduate from the Baltimore City College in the class of 1968?
You know my father?
Yes, you were a classmate.
Yes, yes.
Wow.
So my father, for those of, thanks for giving the opportunity and him a shout out. My father served as an internal medicine physician in inner city Baltimore for many years. It's why I went into the career of medicine. He is why. He's why I've dedicated my life to advancing health equity and why I'm here today. He is. He is.
Well, he's very proud.
Thank you.
Thank you. Delegate Martinez.
Thank you so much, Madam Chair. And in the same vein, Dr. Gray, can you tell us where you went to medical school?
Went to the Howard University College of Medicine.
Thank you so much.
Okay. And where did Delegate Martinez go to school? Delegate Woods, there you go.
You had gone to City College.
I went to the rival Baltimore Polytechnic Institute.
I love it. Are there any other questions? Seeing none, thank you so much for being today and for doing what you do and for collaborating with us in the department. All right, you have a blessed day.
You too.
We have my friend Sarah. How are you?
Hello, it's so good to see you.
Nice to see you as well. Go ahead, you can give us.
Fantastic. Thank you so much for the opportunity to offer comments. My name is Sarah Stones, giving comments in support of HB 1333 today on behalf of Christiana Care. We at Christiana Care have a long-standing commitment to advancing health equity. Our commitment to health equity shows in so much of the work that we do, from point of admission social drivers of health screenings to addressing the barriers identified through strategic programs, to our investment in community health workers, the investment of resources in community projects. We believe that to truly end health disparities, which is our ultimate goal, it will take the hard work of all invested stakeholders. And without that work, we cannot achieve the outcomes we desire in clinical care, quality and safety, nor improve the health of the communities we serve. This collaborative approach ensures that the policies and programs are culturally sensitive, responsive, and effective in reducing health disparities. In that pursuit, the establishment of a statewide health equity commission is crucial. Such a commission serves as a dedicated body to address those disparities in healthcare access, outcomes, and resources among different populations. And that statewide health equity commission plays a pivotal role in advancing health equity by analyzing data, identifying disparities, and developing policies and strategies to address them. By focusing on the social drivers of health, such as socioeconomic status, education, and access to healthcare, the Commission can work towards creating a more equitable healthcare system for all Marylanders. Of course, including a diverse set of stakeholders, including healthcare providers, community leaders, advocacy groups, researchers, and representatives from both marginalized and regionally diverse perspectives is essential for ensuring the Commission's work is inclusive and representative of the state's population. We are so excited about the introduction of this legislation, the work that lies ahead, and hope for a favorable report. Thank you.
Excellent time. Are there any questions? Seeing none, thank you for being with us today. Great seeing you.
Thank you so much. It was so great.
Thank you. All right, this actually concludes the bill hearing on House Bill 1333. We're now going to move on to House Bill 1051, Delegate White Holland, Maternal Health Assessment Referrals and Reporting, Maryland Maternal Health Act of 2024. And we have the following first panel: Dr. Larry Polsky, Secretary Herrera Scott, Dr. Carrie Wilson, and Teresa Lee. Will you please be so kind and come up with a delegate? Good afternoon, delegate.
Good afternoon. All right, again, good afternoon, Madam Chair, Madam Vice Chair, and members of the House Health and Government Operations Committee. For the record, I'm Delegate Jennifer White Holland and have the distinct honor to present HB 1051 for your consideration. I would also like to thank Madam Chair of the Legislative Black Caucus of Maryland, Delegate Janelle Wilkins, as we have partnered together on this bill, and as it is a Legislative Black Caucus of Maryland priority, but also for those on this panel and those who you will hear from for working together collaboratively to really work to strengthen this bill. And so I'm very grateful. And it just simply warms my heart for everyone to provide their input in really moving this bill forward. And thank you to this committee for their commitment to improve maternal and child health in Maryland. And so I invite you to review my written testimony for further details. And I will outline for you just briefly what this bill does and elevate the sponsor amendments that will speak directly to the fiscal note, which I am sure you have already seen. So maternal deaths and serious postpartum health incidents is a public health crisis, and that continues to disproportionately affect women of color, especially Black women, statewide and nationally. And so to better position our state to address this crisis, HB 1051 has 4 central components. It streamlines and updates the Maryland Prenatal Risk Assessment Form and Postpartum Infant and Maternal Referral Form, known as the PEMR, making it electronic. And within the context of these forms, we will understand the number and types of referrals made at the local level. Secondly, upon discharge, follow-up will be conducted to patients paired with the necessary resources provided to them. It creates a report card for birthing facilities with key quantitative and qualitative measures by race and age. It also requires, as a final component, all birthing hospitals in the state of Maryland to participate in the surveillance of severe maternal morbidity. This bill presents an opportunity for the legislature to bolster existing efforts within the Maryland Department of Health, which you'll hear more about, strengthen care coordination in the community, and equip our communities with the information they need during pregnancy and postpartum periods. In true and in the spirit of our committee, I convened a work group that continued to grow with a diverse range of stakeholders, all committed to ensure the success of this bill. And they put forth a series of recommendations that I submitted as sponsor amendments. And so these amendments have not been prepared yet or ready for from the amendments office. And so at your desk, you will see a document outlining the various amendments more specifically that were submitted to the amendments office. But just for your hearing, I'll briefly review them. And so again, these amendments will speak to and address the fiscal note. It removes a second completion of the PRA form. It creates a work group to determine workflows for referrals. It updates the language related to the resources provided upon discharge to the patient. and updates the timing of when a birthing parent is contacted after discharge. It removes the reimbursement requirements. It ensures that there are updates on types of numbers of referrals are shared on or before October 1st annually. It includes rates and disaggregated data by race and age for the report card. It updates the timing of enactment for forms and reporting, giving our health department enough time to ensure that these forms can be made electronic. And it also requires that hospitals participate in the surveillance of severe maternal morbidity through the MD Mom program, which you will hear about as well. All of these amendments address the fiscal note, and the panel will expound upon this further in their testimony. I anticipate additional amendments that seek to include other potential technical changes, additional organizations, or perspectives to be included in the work group related to workflows, as well as referrals. And so I am open to further conversations ahead of subcommittee and in subcommittee regarding these and other amendments. Overall, the primary aspects of the bill have been resolved as a result of collaboration. Maternal deaths and severe maternal morbidity events continue to pose a serious threat to women in our state. The Maryland Maternal Health Act will build upon existing resources, better connect moms to care during pregnancy and postpartum, and position our state to take further action in the future. Colleagues, I humbly and respectfully request a favorable report as amended. Thank you for your consideration. I'll now turn it over to Madam Secretary.
Before the secretary testifies, and thank you all for being here, I want to thank you. I got really positive feedback about how you went and met with everyone and worked the bill so hard and brought everyone together. And I want to thank you for doing that.
Thank you, Madam Chair.
Thank you. Madam Secretary, welcome again.
Thank you. Thank you. Good afternoon, Madam Chair, members of the committee, Laura Herrera Scott, Secretary of Health for the record. Department is in support of HB 1051 with several amendments. I just want to echo, Madam Chair, what you just said, and certainly the partnership that we've appreciated with the delegate. It really, really has been a collaborative process. But just to echo some of the facts again that she briefly mentioned, Black non-Hispanic birthing people experience a maternal mortality rate that's 4 times that of white non-Hispanic Marylanders. And similarly, when we look at severe maternal morbidity, which is a statistic that measures health-related events that may not have killed a pregnant person, but almost certainly impacted their health, well-being, and relationship to the healthcare system. The state of Maryland has made it a strategic priority to reduce maternal morbidity and mortality and to eliminate the racial disparities in those 2 outcomes. There are many current initiatives in this space, including expansion of maternal postpartum coverage in Maryland Medicaid and the Healthy Babies Equity Act. For years, the local health departments have served as a care coordination hub. They receive referrals from clinical providers via the PRAM and postpartum infant and mortality referral forum, which is the PMR, and connected the birthing person with a variety of community-based services. Medicaid's managed care organizations have also provided essential case management services and received some of these risk assessment forms. The provisions of the bill are an opportunity to strengthen the system to form a greater connection between the birthing hospitals, prenatal practices, local health departments, managed care organizations, and community-based organizations so that the care experience for birthing people is supportive, tailored to their needs, and coordinated between the inpatient and outpatient environments. And again, we have really, really appreciated the collaboration. And I thank you for the opportunity to testify before you. Happy to answer any questions, and we certainly urge a favorable report. Thank you.
And again, thank you for being at the table on many of these policies. We really appreciate you and your office. Yeah. Next, please.
My name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in strong support of this bill. This bill is not only a priority for the Legislative Black Caucus, it's a priority for the local health departments around the state. HB 1051 lays a foundation for earlier identification of pregnant and postpartum women at higher risk for potentially life-threatening health problems. It also connects obstetric providers, hospitals and birthing centers, and local health departments so available resources can be used more effectively and more efficiently. As a board-certified OBGYN who practiced for almost 2 decades in St. Mary's County before shifting to public health, I can understand the value of more effective public-private partnerships that this bill will provide. HB 1051 will also allow nursing and social support staff at each of your local health departments to more effectively address domestic violence, substance misuse, postpartum depression, and a host of other health and social factors that currently lead to unnecessary tragedy. Improved prenatal outcomes are also a major cost saver for the state of Maryland. 40% of pregnancies are covered by Medicaid. Adverse maternal outcomes correlate with preterm births. A single premature baby can cost well over $100,000 in neonatal intensive care unit expenses alone, and medical bills continue for a lifetime for the most severely impacted newborns. HB 1051 is a vital step as we work cooperatively to improve preventive measures and decrease adverse maternal and newborn outcomes. The Maryland Association of County Health Officers asks for your support of this bill. Thank you very much.
And I want to say, Dr. Polsky, that you're one of my favorite people here. I know you for all the years I've been here, 18 years, and I just love your advocacy and your work. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Teresa Lee, and I am the Director for the Center for Quality Measurement and Reporting at the Maryland Healthcare Commission. On behalf of the Maryland Healthcare Commission, I appreciate the opportunity to speak with you today in support of House Bill 1051. The Commission maintains a consumer website that provides quality and performance information for a variety of healthcare provider settings, such as nursing homes, assisted living programs, hospitals, and more. The information available on our website varies by provider setting. For some settings, such as urgent care or adult medical daycare, we include basic information to enable consumers to identify providers within their zip code. For other settings, such as hospitals, nursing homes, and home health, we report on a more robust set of measures and performance data to give consumers an opportunity to compare providers when making healthcare decisions. In addition to clinical measures, users can determine how patients or families rate their hospital or nursing home and whether they would recommend the facility to others. The hospital component of the quality reporting website displays information on services provided by all Maryland acute general hospitals, including maternity services. Users of the site can identify hospitals that provide birthing services, review the volume of vaginal and C-section deliveries performed by each hospital, as well as the average hospital charge per case for these services. This information is important to share with consumers, but we recognize we need to do more. The Commission supports House Bill 1051 and believes our quality reporting website can serve as a platform for establishing a report card on the performance of facilities that provide critical maternal health services to women across the state. We believe the report card can be developed with the Commission's existing resources and with our continued collaboration with experts at the Health Department. And I will conclude there in the interest of time. Thank you.
And thank you for being in the Health and Government Operations Committee.
Thank you.
You're welcome. Next, please.
Good afternoon. My name is Carrie Wolfson, and I'm speaking on behalf of the Maryland Maternal Health Innovation Program, which is a collaboration between the Johns Hopkins University, the Maryland Department of Health, and the Maryland Patient Safety Center. Our team strongly supports HB 1051 because it provides a critical accountability mechanism for maternal health initiatives in the state, including our ongoing severe maternal morbidity surveillance and review. As you've heard, the numbers are harrowing. Every year in Maryland, around 1,500 women experience severe life-threatening pregnancy complications, and 40 women die from these conditions. These numbers are increasing, and the risks are particularly high among Black women in the state. Our findings suggest that 1 in 3 of these events could be avoided. To improve maternal health in Maryland, we must understand the main drivers, risk factors, and causes of adverse outcomes in the state, which will allow us to better address them in a timely fashion. Since 2020, MD Mom has been conducting hospital-based SMM surveillance and review following guidance from national professional organizations And today, 22 of Maryland's 32 birthing hospitals participate in the program, with 5 additional hospitals being trained to enroll. Detailed hospital-specific results are shared with each hospital, and as a result, they implement changes to prevent future SMM from occurring. Aggregate data from all hospitals are used to develop annual briefs to highlight the most prevalent causes and risk factors of SMM in the state. This work is funded by the Health Resources and Services Administration until 2028, and we're eager and well-positioned to assist in carrying out activities proposed in Section 2 of HB 1051 in partnership with MDH and MHA. We look forward to sharing our results with the Health and Government Operations Committee. Thank you for the opportunity. I respectfully request a favorable committee report on HB 1051.
And thank you for being here. And thank you for the work you do. Appreciate you. So we're going to open it up now for questions. Are there questions for the delegate and her panel? Delegate Hill.
Thank you very much. And thank
Oh, I
you,
didn't
Delegate,
see
for
that.
all of your work and for bringing this really important bill. I have a couple of questions related to the amendments, and I know we could ask offline, but while these health professionals are here, I want to ask. So on page 2, actually on page 3, you talk about if a newborn provide to the birthing parents or resource. I'm sorry. We're talking about children who are born from high risk pregnancies, and then we have all these things that have to be done. And I wanted to know, is that deliberate that we're only talking about high risk pregnancies and we're not saying that the same thing should be done? The report should be given for complicated babies born of complicated labor or complicated births, or kids born with abnormalities that are not identified until birth. Should not that same report card be issued for them so that they can be tracked and make sure that they're not going to be part of the high risk for the next year or so?
Delegate, can you clarify, because you mentioned.
Yeah, I went all over the place. Let me back up.
On the bill, and then in
Let
the
me
bill,
go
you
back.
mentioned 2 places, the
Okay.
report card and then the.
Right. Page 3. Okay. Let me see something here. Okay, on line 9.
Okay.
If a newborn is delivered in a hospital following a high risk pregnancy, the hospital shall complete a postpartum referral form. Okay. There are other kids who I believe, but the health department may feel differently, should also be considered for reporting. Kids, they can have a non-high risk pregnancy and have a complicated labor, or a non-high risk pregnancy and have a challenging delivery with complications, cords wrapped around the neck, all kinds of things. And I'm wondering whether those children, and possibly even some born with some congenital abnormalities, should also have the delivering practitioner fill out a infant and maternal referral form. That's what I'm asking.
So the thought of the PEMR form, again, is really addressing maternal morbidity and mortality. I've said before, we can't have healthy babies without healthy moms. And so really understanding the conditions that impacted the delivery, whether it was before, during, or after, and then what that impact is on the baby. There are other ways that we capture data on the baby that may or may not be with this form, but we agree, we are certainly monitoring complications related to delivery that impact the baby. But for at least what we discussed as it relates to this bill was really, really focused on the mom and trying to address the risk factors or learn what the risk factors are so we could mitigate them moving forward.
Separating the child, then, and thank you for that clarification, a complication of labor, placenta abruption, other kinds of things, they don't put the mother at more risk, even though she may not have had a high risk pregnancy?
Yes, so the PEMR, the form would be completed in those, absolutely would be completed in those scenarios that you just stated.
So even though it doesn't say that, it just says high risk pregnancies?
All the conditions you mentioned would make the pregnancy high risk.
Okay, so, okay, thank you.
Thank you.
We also talk about calling the birthing parent. And this is silly, but it's the text or call or contact them some way, because people don't pick up phones anymore. That's all. Just throwing it out. Go ahead.
I'll take that question. So you're absolutely right that for a lot of our nursing staff, when they communicate, it is initially by text because people don't answer the phone. And we do actually have extremely good response rates when we do text across.
Also prohibitive and they say something like call them. We want to say connect with them, communicate with them by whatever call or text or whatever. Okay, thank you.
Delegate Hill.
Okay.
Okay. Okay, gave you the mom look. Delegate Kaiser.
Thank you, Madam Chair. Thank you, Delegate White Holland. I really like this bill. My question, and I probably missed it while you were speaking, so I apologize if you have to repeat or reiterate, but I wanted to specifically understand, you mentioned you had been working on it and you have different amendments. Given the fiscal note, and I actually don't think it's really that high, given what we all know are the cost savings of all the challenges that what might otherwise be. But the amendments that you're still working on with MDH and others, how will they impact the fiscal note? What are those specific points that you've been talking about that should reduce those costs?
So thank you for that question. As I appreciate you elevating this. I think in our conversations in the work group, and it was brought to my attention by by Macho, right, that the completion of a second PRA or prenatal risk assessment form would certainly drive up the cost. And it is stated here in the fiscal note that that again, the increase would be $965,000 more in FY 25 to reimburse for additional prenatal risk assessment forms. So our amendment that removes that second completion, given that sometimes the timing when it comes to the first initial visit or whenever the mom is seen when the PRA is completed, then going right into the PEMR, it may be duplicitous. So the thought was to remove the completion, the second completion of the PRA form, given that these things are happening in sequential order. And that way the necessary care coordination could still be provided. And so that alone, that First Amendment alone, really significantly and substantially addresses the fiscal note that you see before you. And that was agreed upon by all of the stakeholders.
Thank you. Any questions? Delegate White Holland, you will defend this bill on the floor.
Okay. Thank you.
You're welcome. Thank you so much, everyone, for working together. So next we have, if I may, since I call a favorable, let me call a favorable with amendment to be balanced. May I please have Pam Casemeyer and Allison Taylor, Tracy Laval, Joseph Nguyen, and Dr. Darrell Gray II. You could just pull up a chair to the right. You got it? Okay. Who would like to get started? Pam, why don't you go?
Okay.
Just because I know you.
Yeah, I've been around for
The longest.
long time.
Yes. I didn't want to date us, but you know you the longest.
Oh, you're really young compared to me. Anyway. Madam Chair, members of the committee, I'm Pam Casemeyer, and I'm actually here on behalf of not only the College of Obstetricians and Gynecologists, but the Academy of Pediatrics, MedChi, and I know the federally qualified health centers have been interested in this as well. And I'm going to be very short because I don't know that I could say much more than me too to everything you heard before. The biggest me too goes to Delegate White and for all the time and attention she took pulling us all together to work through the details. And so as amended, we're supportive of it. We know there may be some conversation about some additional tweaks and things like that, but maternal health, maternal child health has been a priority for this General Assembly and for this committee, particularly for a number of years. And this is really a comprehensive set of additional initiatives to further advance our efforts to
protect and enhance both maternal and child health, and we'd recommend a favorable report with the amendments.
And I want to thank you. Over the years, we have had many bills on this subject matter, and you have been the person that I always go to. So thank you.
Thank you.
Go ahead. Next, please.
Okay. Hi, good afternoon. I'm Tracy Laval, the Senior Vice President of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of Maryland's hospitals, I'm here to support House Bill 1051 with the sponsors' amendments. I want to speak to just a few of the elements. The independent reviews of a representative sample of cases of maternal morbidity will bring additional clarity to the drivers of maternal morbidity and mortality, and they'll add to the understanding that we have and that's needed to reduce the disparities in maternal health and to foster good outcomes for all birthing parents. What we know now is that many factors influence maternal health outcomes, including the age, health, and environment of the mother before pregnancy. Postpartum support is also important, and the trust and relationship with doctors and caregivers throughout the perinatal period. The requirements of the bill build on existing programs and upgrade existing processes. We're fortunate that the MD Mom program has created the infrastructure to do the severe maternal morbidity reviews, and MHA is pleased to support and amplify that work. The bill mentions specific forms, we talked about them a little bit, completed by hospitals and physicians in the prenatal and postpartum period that refer high-risk patients to local health departments to connect families to local resources specific to the family's needs. We really appreciate the planning that is underway to simplify and modernize that process. And as the state plans for the next Maryland model, this approach is really a great way to strengthen the ties between hospitals, local health departments, and community organizations so that we can work together in a way that supports all Marylanders. I appreciate the opportunity to share our views today. Thank you.
Is this your first time in HGO?
It's the first time here. I testified a little bit on something else a couple of years ago.
All right. Well, I want to welcome you.
Thank you.
Thank you. We work closely with MHAs and we appreciate the partnership. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here from Kaiser Permanente and also as the Government Relations Chair for the MCO Association. The MCOs will play an important role in this, and we very much appreciate being at the table. We appreciate that this process will be electronic and looking forward to working with stakeholders on the appropriate workflow for this information. So thank you very much.
Thank you, Allison, for all your work. Next, please.
Madam Chair, members of the committee, it's Joe Wynn with the Maryland MCO Association. We're here favorable with amendments, and those are the sponsors' amendments. The sponsors held an excellent set of collaborative meetings, really driving these results. This is an important bill to the MCOs as well. About 40% of births in Maryland are paid for by Medicaid, and our MCOs do a lot of work in this space, but this bill really builds a lot around the great work that the local health departments, the systems, MDH, and other stakeholders are doing. So really brief comments to just say we're favorable with amendments, and thank you to the sponsor for the collaborative process in getting to where we are.
And thank you, Joe, for being at the table. Next, please.
Madam Chair, Madam Vice Chair, committee members, Dr. Darrell Gray, I get to serve as Chief Executive Officer of WellPoint, Maryland, one of the largest Medicaid managed care organizations in the state. And we have over 300,000 people across the state, many of whom are birthing parents and children. And particularly as we think about maternal health inequities, it is one of the most pressing health challenges of our time and across our nation, but certainly here in Maryland. And the opportunity in front of us allows us to not only think about the change, but to be able to measure the change that we hope to have and see the impact. One of the critical things that's important for everyone to recall or remember is that as we think about preterm births, severe maternal mortality, C-section rates, infant mortality, those are highest amongst people who look like me. And if we look at the disparities, a Black mom is more likely to die in childbirth. Their child is more likely to die as a result of childbirth as compared to any other racial or ethnic group. These are things that we can measure. These are things that we can impact, and they're critically important for us to do now. And so we unequivocally at WellPoint support the work that's been collaboratively done with Delegate White and the team in support of this bill. So thank you.
And thank you for being here with us. We appreciate it. I'm going to open it up for questions now. Are there questions for this panel? Seeing none, thank you so much for your
Thank you.
expertise and for your work. And Delegate White Holland, you did such a great job that we're quiet. And that is unusual for us to be quiet. So let's go on to Kathleen and Robin Elliott. Robin Elliott, are you here? Go ahead.
Thank you, Madam Chair, committee members, Kathleen Lochran with WellPoint for the record. I can't say anything more than those before me, but I do want to echo the sentiments that have been expressed with respect to Delegate White Holland's commitment to this issue and the manner in which she has conducted herself with all the stakeholders. Last month, she took time early in the morning to spend time talking with the MCOs in the association about this bill to understand our need and the reason why this is a big priority for the MCO Association and individual MCOs, in particular for WellPoint, Maryland. And I also appreciate her willingness to hear WellPoint on some suggested language and take that language and incorporate it into her efforts. So we wholeheartedly support this bill and we support the delegates' efforts on this as well. Thank you.
And thank you for your partnership again today and over the years. We appreciate it. There is a witness virtual. Her name is Ashley Black. And I heard she's not here. Okay, so Ashley Black, for the record, we called and not on the screen. We are gonna go back to the last few witnesses that we have on the bill that are favorable. We're going to call Kyra Washi, Lisa Colt, Erica Blake, Carla Nelson. Those are the last witnesses. Is there anyone here that is supposed to testify in this bill and was not called? Can you let me know? All right, we got everyone. Good afternoon and welcome to the Health and Government Operations Committee.
Thank you.
And thank you for your patience. Everyone else is waiting for their bills to be called. Okay, we'll get back with you in a minute. Go ahead.
Thank you. Good afternoon, Madam Chair, committee members. I'm here to urge you to vote in favor of the Maryland Maternal Health Act of 2024. My name is Kyra Colby Vachi, and I am a concerned Maryland resident and suicide survivor. My sister, Andrea Colby, gave birth to a beautiful baby boy on August 24th, 2023. She had a normal and healthy pregnancy, not high risk. But 15 weeks later, on December 11th, one day after her 35th birthday, we lost her. She took her own life because of the devastating effects of postpartum depression and psychosis. The current lack of maternal health care, support, and resources available to new mothers is bleak and hopeless. The current healthcare system is not structured well enough to support new moms during this most vulnerable time. This bill is extremely necessary to provide new mothers and their partners with required assessments, referrals, information, and care that is now so insufficient. Without these provisions in place, new mothers and their families are at risk of a devastating loss, like what my family and I have endured. The pain, the sadness, and the complicated grief has been unbearable, and there are no words that could possibly convey the emotions we feel that surround this catastrophic event. With the passage of this bill, women will leave the hospital with the information that can assist them through the postpartum depression phase, get referrals and assessments so desperately needed, and thus reduce the maternal mortality rate in Maryland. 1 in 4 women die by suicide because of postpartum depression. That is staggering, and it should be considered a national emergency. On behalf of my sister, Andrea, who leaves a sweet baby boy, her husband, and the rest of her beloved family and friends in shock and grief, I thank you for giving full consideration to this essential legislation. And thank you, Delegate White Holland.
And I want to say on behalf of the committee, Kyra, that I'm really sorry about Andrea's passing.
Thank you.
You're making a difference being here today.
Thank you.
And thank you for sharing your personal story. And how's the baby doing?
He's amazing. He's 6 months old now and beautiful, thriving. He has a wonderful father.
Blessed to have you and the father. Next, please.
And this is my mom.
Hi, how are you?
Good afternoon, everybody.
I'm Lisa Colby. I urge you to vote for this Mental Maternal Health Act of 2024. As Kyra said, my daughter Andrea Colby gave birth to a beautiful baby boy on August 24th, 2023, having a normal and healthy pregnancy. On December 11th, 2023, we lost her to postpartum depression and psychosis due to the lack of maternal health care available to new mothers. This bill is necessary to provide new mothers and their partners with the information and care that is now so insufficient and tragically can culminate in the devastating loss that me and my family have endured. With the passage of this bill, women will leave the hospital with the information and knowledge that can assist them through the postpartum depression phase, get referrals and assessments so desperately needed, and thus reduce the maternal mortality rate in Maryland. On behalf of my daughter, Andrea, who leaves a baby boy, her husband, and the rest of our beloved family in shock and grief, I thank you for your full consideration to this essential legislation.
And thank you for being here. I know must be very hard, and I just want to say I'm so sorry. And
Thank you.
And this bill will pass.
Good.
Okay. Next, please.
Good afternoon. My name is Erica Blake. I'm here today speaking in favor of House Bill 1051. The assessments required by this bill should be offered multiple times to all women postpartum, regardless of whether they've had a high-risk pregnancy or not. We need to do more than this bill to improve maternal health. In May of last year, I was sent to the hospital for a C-section because of a sudden change. Before I left the hospital, I was screened for perinatal mood disorders. It was negative. Then 12 days later, my son developed respiratory distress from a cold, and we were sent to the ER where he had multiple tests, including EKG, chest x-ray, and multiple blood tests. The test came back normal. About a week later, I had a nurse visit me from Family Connects, an evidence-based home visiting program offered by Frederick Health Hospital to all Frederick County families at no charge through a grant from Frederick County's American Rescue Plan Act. During the visit, she conducted a health assessment for my son and screened me for perinatal mood disorders, which was negative for a second time. And she left me with flyers on PMADs and told me how to let her know if my mood changed. In late June, my anxiety over my son's health began to spiral out of control. I found myself constantly crying, unable to sleep. I started experiencing bouts of dizziness. And at one point, I remember staring at my son and wishing he was not here and had never been born. I picked up a flyer the nurse gave me and immediately realized I was experiencing postpartum anxiety. I texted her, and she told me that if I was in crisis to call 211. She offered me additional resources, including online support groups through Postpartum Support International, and I also contacted a therapist who I continue to meet with monthly. I'm so thankful that I had access to the multiple screenings as well as the Family Connects program so that I could pinpoint the source of my symptoms and quickly find support. I'm here with Andrea, in memory of Andrea, with Lisa and Kyra, because moms like me are facing a mental health crisis. Andrea was my husband's best friend, and I believe that she would have gotten the help she needed if she had the resources offered through this bill. Thank you.
Thank you for being here, and you're honoring her by being here. And we're gonna get the bill through. Okay,
thank you.
Next, please.
Madam Chair, esteemed members of the committee, for the record, my name is Carla S. Nelson, and I'm a member of a Divine Nine organization with 25 chapters in this state. While I speak for myself as an individual, I carry their concerns on my shoulders. And my concern is for the urgent need to address racial and ethnic disparities in the maternal health space. In 2018, Black mothers in Maryland passed away due to childbirth-related complications at a rate of 44 deaths per 100,000, 3.7 times higher than white mothers. The most common pregnancy complication for Black women is bleeding, hemorrhaging, and blood pressure disorders, including preeclampsia and eclampsia. A study of postpartum readmission in Maryland against the race and ethnicity showed prevalence of readmission was 1.2% for white and Hispanic women and 2.3% for Black women. The study also concluded that the majority of maternal deaths occur in the postpartum period. The national data also shows that blood pressure disorders, preeclampsia and eclampsia, are the leading causes of death for Black women. I am a two-time survivor of preeclampsia and a one-time survivor of postpartum preeclampsia. In 2017, I delivered my second child at Howard County Hospital under the care of Johns Hopkins. In my first pregnancy, I was never informed that I had preeclampsia, but during my second pregnancy, we ensured that we followed all precautions to make sure that I would have a positive outcome. After discharge, I developed an excruciating headache and elevated blood pressure, and around day 6, I saw a story on Facebook about a mother who had passed away from postpartum preeclampsia. I did not know that such a condition existed. I immediately called my care team and they told me to return to the hospital. I was suffering from postpartum preeclampsia. My blood pressure was 215 over 118. This bill requires a call 12 hours after discharge. If that bill had been around during my time, I'm sure they would have recognized my symptoms earlier. I urge you to pass this bill and return a favorable report on House Bill 1051. Thank you.
And thank you for sharing your story, and I'm so glad you're here. You're making a difference. I'm going to open it up for questions now. Are there questions for this panel? Seeing none, thank you. And not asking questions doesn't mean we don't care. It just means that, you know, we're going to do this, okay?
Yeah,
Thank you.
Thank you.
Okay. And that's right, Delegate Shalega, they did an excellent job. Is there someone here that did not get called? I did not see it. I got up and asked if Ashley Black was virtual and she's not there. So this actually concludes the bill hearing on House Bill 1051. Delegate White Holland, excellent job. All right. Next we have, if I may, Delegate Woods, you're next. House Bill 1293. Maryland Department of Health Public Education Campaign on Prostate, Lung, and Breast Cancer Prevention. And if you can come up with your panel, I think I have Nashona Kess, Eric Morrow, and I think you have the Secretary of Health, Dr. Laura Herrera Scott. Is there
Ms. Kess here?
Ms. Kess? Thank you. Good afternoon, Delegate.
Wait a minute. Good afternoon, Madam Chair and members of this esteemed Health and Government Operations Committee, a committee that I am humbly honored to serve with. For the record, I'm Delegate Jamila Woods, District 26, and I'm here to request a favorable response for HB 1293, Maryland Department of Health Public Education Campaign on Prostate, Lung, and Breast Cancer Prevention. I would add this is also a legislative priority of the Legislative Black Caucus of Maryland. An estimated 3,500 Marylanders die from prostate, lung, and breast cancer each year, despite the fact there are screening and imaging options available to identify these cancers in their earliest stages. When detected early, various treatment options and improved outcomes significantly benefit individuals who receive one of these cancer diagnoses. In Maryland in 2017, the last year when the full data was available, breast cancer was among the most diagnosed cancer, with prostate cancer second, followed by lung cancer, which is actually the most common cause of cancer death in Maryland. Breast cancer is the third leading cause of death in the state. HB 1293 will develop and implement a public education campaign addressing prostate, lung, and breast cancer, as well as factors related to persistent health disparities impacting communities disproportionately impacted by these cancers in Maryland. These factors include poverty, socioeconomic status, cultural beliefs, social injustice, and racial bias. A public education campaign will be instrumental in ameliorating the myths impacting knowledge and understanding and promote information, fostering alignment with more positive outcomes. A public education campaign would provide improved opportunities for access to the comprehensive evaluations and consultations that have historically proven advantageous to disproportionately impacted populations. According to the American Lung Association in Maryland, the lung cancer survival rate has improved because of increased awareness, improved access to healthcare, and cutting-edge research into new treatments for the disease. This information and access to it must be both equally and equitably distributed. Additionally, the American Lung Association's 2023 State of Lung Cancer Report highlights that Maryland must do more to reduce the burden of lung cancer and encourages everyone to help end lung cancer. The 2023 State of Lung Cancer Report also reveals that Maryland ranks 36th in the nation for lung cancer screening. This means that Maryland is below the average in the nation for lung cancer screening, and more work is needed to reduce the burden of lung cancer. Regarding breast cancer, the second leading cause of cancer for African-American women, a public education campaign will improve the overall access to information related to breast cancer, as well as the various types of breast cancer and the multifactorial issues related to them. Research shows young Black women have doubled the mortality rate of young white women. Research also reflects, despite a reduced breast cancer mortality in general, the benefits are not equally shared among race or other disproportionately impacted groups. Black women who have higher incidences of life stressors, diabetes, obesity, heart disease, and who are reportedly less likely to breastfeed have higher risk for breast cancer. A public campaign about cancer is a key step in furthering Maryland's goals of reducing healthcare disparities. Such a campaign allows for a strong collaboration between multiple agencies, including health providers, social service organizations, community organizations, and more. A public education campaign would make information available along with potentially vital programs, providing helpful resources otherwise frequently inaccessible to underserved populations. This provides beneficial advantages for persons being treated during the various complexities related to prostate, lung, and breast cancer. It would also be valuable through the distribution of information related to clinical trials, as well as available new treatments vital to survival. Finally, this education campaign would play a vital role in addressing the psychological experiences and supports to provide better coping skills, impacting the behavioral health of persons, primarily minority and low-income sufferers, disproportionately impacted by prostate, lung, and breast cancer. And for this reason, I'm requesting a favorable response to House Bill 1293. Thank you so much.
Thank you, Delegate, for your testimony today. Who would like to go next?
I can go next. Good afternoon, Madam Chair, members of the committee. My name is Nashana Kess, and I am the Executive Director of the Maryland NAACP, and we are in favor of this bill. This legislation recognizes the urgent need to address the significant health disparities that persist within communities of color, disparities that are often exacerbated by systemic barriers to healthcare access, lower rates of early detection, and limited awareness of prevention measures. Education is a powerful tool in combating these disparities. By focusing on prevention and early detection and tailoring the campaign to reach the most affected communities has a potential to make a transformative impact. Prostate, lung, and breast cancers are among the leading causes of cancer-related deaths, and communities of color bear a disproportionate burden of morbidity and mortality from these diseases. I wanted to add that just the other day, I was logging in on Facebook, and a college friend of mine who was younger than I was ringing a bell in this video. And on the video, I said, wait a minute, that bell is usually for those who have cancer. So I continued to read, and he posted that he was just found free of cancer. And he had been burdened with prostate cancer for some time, did not tell anyone. But that was surprising to me, as he is younger than I, and he was diagnosed with cancer and was dealing with that for some time. And part of this public education campaign we hope that it would get rid of some of those misnomers, that it doesn't only affect those in the older community, but it also affects those who are younger. Really quickly, I also wanted to tell you a story about a young woman who I had to participate in burying. She was a member of my organization. I'm the president of that organization, Sigma Gamma Rho, and I had to bury her in August. She died from breast cancer, and she was preceded in death her mother, who also died from breast cancer.
Thank you for being here and for the work you do. Next, we're gonna have, go ahead, sir.
Good afternoon, Madam Chair and members of the HGO Committee. My name is Eric Morrow and I live in Bowie, Maryland. I'm a 20-year Air Force veteran and was diagnosed with stage 3B prostate cancer in 2021 at the age of 49. Had either my primary care physician or I been better informed about prostate cancer during my 40s, it's likely I would have received timely PSA screening and my disease would have been caught before spreading to my lymph nodes. I'm here on behalf of Zero Prostate Cancer to testify in support of HB 1293. After decades of decline, prostate cancer deaths are on the rise. Maryland has the 4th highest incidence rate for prostate cancer in the country. In our state this year, the American Cancer Society estimates 6,150 men will be diagnosed with prostate cancer and 660 will die from it. African-American men, male veterans, and men with a family history are classified as high-risk groups for prostate cancer. 1 in 6 Black men will be diagnosed with prostate cancer in their lifetime, compared with 1 in 8 men in the general population, and they are more than twice as likely to die from it. They are also more likely to be diagnosed at a younger age and with more aggressive disease, like I was. Veterans are 1.5 times more likely to be diagnosed than the general population, with 1 in 5 veterans developing prostate cancer in their lifetimes. They are also more likely to have an aggressive form of the disease. HB 1293 requires MDH to work with prostate cancer-focused organizations, including Zero Prostate Cancer, to develop and implement a public education campaign for prostate, lung, and breast cancer. A 2019 study from the American Journal of Men's Health found that the majority of men are not completely informed about the PSA test from their physicians. It is critical that clear and communication tools are provided to both patients and providers. HB 1293 would give the Department of Health the ability to use communication tools and messaging to implement the public education campaign and improve prostate cancer awareness and outreach. Again, on behalf of prostate cancer, we request a favorable report, and I thank Delegate Woods for her sponsorship.
And thank you for sharing your story today. We appreciate it. Okay.
Oh,
I said thank you for sharing your story today. We appreciate it. Okay.
Thank you very much.
And for being here. Secretary.
I promise it's the last time today.
It's okay.
You're welcome here.
You're welcome anytime.
Absolutely. Thank you for your service. Chairwoman Pena Melnick, Vice Chair Collison, members of the committee, Laura Herrera Scott, again, Secretary of Health. For the record, on behalf of the department, I'm here to support, here in support of HB 1293, as well as briefly mention some of our proposed amendments. You've heard some of the statistics and why this is important, and we certainly recognize that increased public education efforts and using evidence-based interventions will help reduce these disparities. The department does propose the following amendments. The first is to remove the 30-day feedback, public feedback and comment period, as the department prefers to actively engage with stakeholders, including the public, during the development of the campaign rather than after the completion of a development phase. The second is to include specific reporting on this campaign in the department's existing cigarette restitution fund expenditures and accomplishments report, which goes to the General Assembly annually. The third is remove the requirement to promote participation in clinical trials and studies, as these are outside the scope of the department and best handled by healthcare systems that provide cancer treatment. The fourth is to reduce the maximum allowable appropriation, as the department is able to leverage current efforts to accomplish some of what is required by the bill. And lastly, to change the effective date to allow for ample time to accomplish this initiative. This change will impact other timelines within the bill, so we wanted to call that out. Again, we wholeheartedly agree, and we respectfully request a favorable report with our proposed amendments. Thank you for your time and consideration.
And thank you. Thank you very much for working with the delegate on this matter. Your amendments, do they address the fiscal note a little bit? Okay. Yes. Great. Vice Chair Collison.
Thank you, Madam Chair, and thank you all.
Thank you, Delegate, for the bill and for all of you to be here and inform us. Madam Secretary, I was just wondering, what do you envision in terms of working with the communities during the campaign? Are you looking at like town hall kinds of meetings, or what's the plan
So we
there?
can do it a variety of ways. I mean, we can do it at town hall, we can meet in person. Because of the timing of when the bill, we would want to get started, and we fear that if we did it by public comment, the campaign would be developed already. We would be putting something out for people to react to instead of getting that feedback on the front end and then developing in partnership with the stakeholders that we got the feedback from in the beginning.
And just to follow up, so how do you so like town halls would be one way. That are there other ways you might get feedback? I mean, I think it's a great idea. Just trying to, I'll do some outreach to inform people of how they can contribute.
Well, we would certainly work with the delegate and certainly members on this panel right here who have you certainly identified stakeholders. I think you've identified your own organization as one potential stakeholder. So we would work with everyone here and certainly with the Black Caucus or whoever else we need to work with to identify who should have a say in what the campaign says or doesn't say.
Great. Thank you very much.
Sure.
I think that that's a great idea, Madam Secretary, especially the NAACP, his organization and the Black Caucus with all the members. Thank you. Delegate Rosenberg followed by Shalega. That's how I saw it. Go ahead.
Thank you, Madam Chair. Since the cigarette restitution fund would be the funding source, what's the relationship between smoking and these cancers?
Well, so it impacts all of the cancers. And so we also, as part of the cigarette restitution fund, promote smoking cessation as often as it takes for someone to stop smoking, and certainly have done educational campaigns in middle school and high school to prevent people from starting smoking. So smoking impacts all the cancers that I mentioned. A lot of people think it's just lung cancer, but it's all of them.
That's right. Okay, Delegate Shalega.
Thank you, Madam Chair. Thank you for bringing the bill. So I'm reading the fiscal note about prostate cancer, and I note that it says carriers must provide coverage for a medically recognized diagnostic exam that must include a digital rectal exam and a prostate-specific antigen blood test for men between 40 and 75. So I guess, is 40 young enough? And why would it stop at 75? Are these medical? And I guess this would be for the secretary. Is this some medical determination?
So the different cancer societies have different screening recommendations, but that's generally the window. Generally at 75 is because the risk benefit of screening. Prostate cancer, you heard from testimony about in certain populations how it's more aggressive cancer, but in older individuals, when it is identified, it's a more slow growing cancer. And so as we think about life expectancy, sometimes they will determine screening on the upper end based on life expectancy and based on the aggressiveness of the cancer at that age. So screening recommendations often have windows attached to them, such as cervical cancer, breast cancer, and others.
So you think that 40 is too old? I mean, it's just a blood test, right? So when a person, I'm asking, you're the physician, not me. So
but I'm not a cancer expert, so I just want to put that out there.
But I Googled it and the Google machine told me, Dr. Google told me it's a blood test. My father had prostate cancer and my uncle, and my father told my sons that prostate cancer goes through the mom. I don't know if that's true or not, but because I'm the daughter, my sons would be more susceptible.
I don't think there's anything that suggests that it is genetic. As was already shared, there are certain people at higher risk, either from exposure or because of a family history. So maybe your dad, uncle had prostate cancer, in which case there are recommendations to screen earlier, but that's on a case-by-case basis. But for the general population, it's the range that you mentioned, although it depends on which screening guidelines, the American Cancer Society, the American Urological Society, their guidelines are, and the United States Preventive Services Task Force, all their screening guidelines are a little bit different in the window of a few years.
It just seems like it's a blood test, so it would be important to screen that. But
Well,
I
the-
guess part of the challenge here is making sure that men and women go and get their checkup and
Screenings.
have a screening and have a blood test so that,
So prostate is
you.
specific for men. I just want to make that clear. And the only reason why I would say there is a risk to screening with false positives. So then which require other testing and which in some cases can be very traumatic because of concerns about cancer and or the exams and the follow-ups that are needed to rule out the cancer. So we don't want to overscreen certain populations because there are impacts from false positive results. So so for instance, and this is way more clinical information that you want, but a digital rectal exam and then a PSA that follows can falsely elevate the PSA because the PSA should have been done before the digital rectal exam, as an example.
That's interesting. Thank you for our.
That's more clinical information.
And then if we require testing of the, more labs, we will have to get our friend Matt Chantilano to come on board. Cause I'm sure they don't want to pay anyway, but we love him anyway. So any other questions? All right, seeing none, thank you so much, Delegate. Thank you, Madam Secretary, and thank you everyone for testifying. We're going to ask Mr. Lance Kilpatrick to come forward, please. And he is the last witness for this bill. Is there someone here else that signed up? All right.
I'm
How are
sorry I
you?
don't have my panel with me today, but
Oh, you're just enough, as we like to say here. Go ahead.
thank you, Madam Chair, Madam Vice Chair, committee members. For the record, my name is Lance Kilpatrick. I'm the Maryland Government Relations Director for the American Cancer Society Cancer Action Network. I have a much longer written testimony, but let me be succinct as much as possible. First of all, strongly support the legislative intent behind this bill, okay? And I congratulate the Legislative Black Caucus for bringing us to the fore and making it a priority, because it should be a priority going forward. My one concern that I have with this legislation is how it is funded. The Cigarette Restitution Fund already is less than half of what the CDC recommends as a best practice amount of money going forward. And so when we talk about basically adding responsibilities to the funding of that, my concern is that something may have to give somewhere else. And maybe the secretary has been able to figure that out. And if so, that would be fantastic. I would actually argue that we should probably be spending more money on this to reach out to disproportionately affected populations, to give them that education, to do something about this. That is my concern. I recognize we are in a physical situation, shall we say, this year. Maybe raising tobacco taxes to help fund some of this outreach would be more than appropriate. But I just wanted to raise that concern. But otherwise, incredibly strongly support the legislative intent behind it. Thank you.
No, thank you for your testimony. We appreciate it. I have to say though, cigarette companies, like liquor companies, they target Black and brown communities like
That they do.
crazy. So I think that it's appropriate for the health of those communities, but I do respect your position, and you know that because we know each other.
Yep.
And these are tough times fiscally as well. Any questions? Seeing none, and thank you for lending your voice. Appreciate you. Have a blessed day. This actually concludes the bill hearing on House Bill 1293. We're gonna go to House Bill 1036. Delegate Smith, who's been waiting patiently, Maryland Medical Assistance Program, Maternal Fetal Medicine Service Reimbursement. Delegate Smith, will you come forward? And you have, I believe, Daniel Shattuck, Barbara Brocato on your panel.
Yes, ma'am.
How are you?
I'm wonderful. I actually enjoyed listening to the testimony. It's very different than what we get to hear in appropriation. So thank you for having me
Oh,
today.
you're most welcome.
Thank you, Madam Chair, Madam Vice Chair, distinguished members of the HGO Committee. For the record, I'm Delegate Stephanie Smith, here to present House Bill 1036. As someone said earlier today, there's a little bit of a focus on Medicaid today and also a focus on maternal health. And so this bill seeks to improve the compensation for those specialized physicians that are providing maternal fetal medicine services. And so we've identified 15 bill codes that we thought could use some attention. One we found out later was actually compensating in excess of the Medicare rate, but the other 14 were compensating at roughly 85% of the Medicare rate. And so we really want to ensure that those physicians that are really looking at some of the most high-risk pregnancies to diagnose before birth and during birth abnormalities and other challenges around, diabetes, especially if someone has multiple miscarriages that they've experienced, is really using their specialized care to promote positive outcomes for those that are those birthing persons and mothers. And so this bill initially sought to just increase that compensation rate. But after careful conversations across the professional field and with our partners at the Maryland Department of Health, we decided the best step forward, and I have an amendment to make it a study around what it would take to ensure that Maryland's rates of compensation were appropriate. And so there have been additional conversations related to that. And so the amendment initially requires the Maryland Department of Health to do a range of things to assess what would be the best path forward around reimbursement and provide a report to the General Assembly, I think by December 15th. But I think we might even further tighten up and reduce kind of the scope of what we might be asking the Maryland Department of Health to do, because we do see the agency as a partner in addressing this issue. And we know that they're deeply committed to addressing issues of maternal health and particularly ensuring that those most high risk are able to successfully and safely bring forth healthy babies into our state. And so I just wanted to kind of give you that update that this bill has now been transformed into a study bill. And we definitely do hope that as we continue our conversations offline to eventually receive a favorable report from this committee on House Bill 1036. And I do thank you for your time.
And will you be so kind when you settle on the amendments, make sure that Council,
Yes,
Ms. Erin Hopwood and the whole committee gets it? And then once you settle on the amendments, I can assign it to subcommittee.
Absolutely.
Okay, and thank you for your leadership.
Thank you.
Next, please.
Thank you, Madam Chair, members of the committee, and I'm Barbara Brocato, and I'm here on behalf of pediatrics in support of House Bill 1036. And just because people say, well, who is pediatrics? Well, pediatrics has a strong presence in Maryland. They staff the maternal fetal programs in 11 hospitals, and they do a whole continuum of care across the state in outpatient centers. They are neonatologists, maternal fetal medicine specialists, pediatric cardiologists, pediatric intensivists. They are working with the most vulnerable mothers and babies in the state. And more than 70% of the individuals that they serve, mom and babies, are Medicaid. So I come before you on their behalf to thank this General Assembly in the state of Maryland for working toward the E&M codes being Medicare. And I know we're looking at hopefully trying to see if we can find that 3% that the incoming budget cut from those codes. But I can just tell you how important those codes being at 100% of Medicare is for these, the E&M codes. But there are procedural codes that are imperative, that are often very complicated imaging and other things, that when a high-risk pregnancy is identified, can help the intervention to assure that mom and baby are as healthy as possible, so that there is a 4-pound baby or a 5-pound baby, not a 1-pound baby. And this study. And I spoke to the department outside in the hallway and others. We will work with them on language on this study, but we are really looking toward these procedural codes being paid fairly so we have that access. Thank you.
Great. Thank you very much. Let me open it up for questions. Questions for this panel. He thinks he's living in the Senate, I guess. And we're glad he's not. We're glad he's here. Seeing no questions, you covered everybody's needs very well. Thank you very much. Thank you, Delegate, for
Thank you
bringing
so
us
much,
the
Madam
bill.
Chair.
Thank you, Barbara, for being here. Now we have a favorable with amendment, and that's PM Casemeyer. Hi again.
Hello again. Pam Casemeyer here on behalf of the Maryland section of the American College of Obstetricians and Gynecologists. And I can be pretty brief because I think Delegate Smith and Barbara talked a little bit about there are maternal fetal medicine codes. Even before these conversations happened, when the bill was first introduced, we were a bit concerned about putting actual codes in statute, and we were a bit concerned about putting it in statute tied to Medicare. So really, the reason you hear us collectively talking about some kind of analysis by the department is just that they haven't looked at these codes in a while, and that they do some analysis as to how Medicaid's reimbursement rates kind of line up with Medicare, but also line up with private insurance and other things to be sure that Medicaid's reimbursement rates are reasonably equivalent to the rest of the marketplace for maternal fetal medicine services, which obviously ties into all the maternal health care issues you've been talking about. So we're working through all that language, and we'll hopefully have something for you. And with that, I'll close.
Thank you very much. Questions for Ms. Casemeyer? Oh, over there, Delegate Shalega.
Thank you. Just to prove to you we're listening. I'm a little confused when you say neonatal codes compared to Medicare. Isn't Medicare for old people and they're not having neonatal care?
These are maternal fetal medicine codes. They're
Okay.
kind of a wide range of services. And so, yeah, some of the codes may not even apply in Medicare, but others might. I mean, they're broad codes for certain kinds of visits and procedures. It's not, I know that Barbara said many of her clients her practice that she represents, one practice that's large, does their neonatologists and stuff, but I'm here on behalf of ACOG, which is a broader range of obstetrical and gynecological services, some of which you would call maternal medicine codes.
Even though, because Medicare is for people in their 60s, I don't think you get a lot of
understand, and
maternal.
that's the other reason we don't like it tied to one particular. Some of those codes are covered by Medicare, some of them aren't. Some of them are, all of them are by commercial insurance, which is really why we wanted to go back to have the department kind of look at what the marketplace looks like for maternal fetal medicine codes, not say that they should be equivalent or tied to any given payer, but just see how Medicaid rates are now kind of comparable within the marketplace.
So more of a comparing commercial rates
kind of
to
payers.
Medicaid in
Right.
this specific.
Right. And some of it may be Medicare tied as well, but they'll take the codes, there's a range of codes, and do some evaluation and report back. I mean, we're working on what they have to do, but that's, I think, kind of theoretically what we're saying is they'll come back and say, we've looked at all these codes, we sort of fall here, and here's kind of our plan to make sure we are adequately reimbursing for these services.
Thank you.
Thank you. Any other questions? Seeing none? Thank you so much for being with us today, okay?
Thank you.
And this concludes this bill hearing. House Bill number 1036. Next, we have House Bill 1304, Delegate Kaiser. Thank you, Delegate Smith, for being with us. And Delegate Kaiser's bill is Maryland Department of Health and Department of Human Services Earned Income Tax Credit Distribution of Information. Good afternoon.
Madam Chair, thank you so much for accommodating my schedule, and let me introduce my intern to you, Reba Ahmed. She is a criminology and criminal justice major at the University of Maryland. She's a senior looking to go to law school after a gap year. And she was also in one of my ethics classes last semester and earned an A, of course. So I'm so proud to have her here, and she's been working on this legislation. So I'm certainly can answer some questions at the end.
Thank you and good afternoon. Welcome to the Health and Government Operations Committee.
Thank you. Good afternoon, Madam Chair and esteemed members of the Health and Government Operations Committee. It is my pleasure to come before you and offer testimony in favor of House Bill 1304. This bill is meant to require state agencies administering public assistance program to inform individuals about the state earned income tax credit. The language of the bill as it stands does not convey our original intentions. We intend to propose an amendment to ensure that the bill's purpose is clear. We want customer service representative at specific agencies to inform individuals interacting with other public assistance programs about the earned income tax credit, regardless of whether they reach out by phone, by email, or in person. The earned income tax credit is a valuable resource for many individuals working with low and moderate income, yet there is no valuable resource to inform them about this. Despite its potential to offer significant financial relief, earned income tax credit is underutilized because many eligible individuals either don't know that it exists or they don't know that they qualify for it. Earned income tax credit is not a mere line on tax return. It is a tool for economic empowerment and social mobility. Maryland agencies serve the exact demographics that tend to benefit the most from this bill. But there's no systematic approach to ensure that people are getting this information. This lack of information leads people to not get the benefits that can make a substantial difference in their life. For example, consider a family that is applying for a supplemental nutrition assistance program, and then they find out that they can apply for earned income tax credit too. It could be a game changer for them. It could lead to a trip getting paid or a car getting repaired or something like that. So I urge all of you to please support this bill. Thank you.
I have to tell you, you did excellent. Great job. And you know what? I love the bill because, and I usually don't say this, but it's important because it's a credit that goes to the very poor, right?
Yeah.
People that are very poor, they usually are not aware that they have this credit. Like, what an amazing, tell me how this bill came about.
Well, it's a combination of a few things, Madam Chair. Realizing over the years that we don't do enough for their earned income tax credit, and there are some other bills this year that are trying to address that population. But really, it goes to, as I've shared with you before, my love for the information technology legislation that we have, that we provide a lot of great services here in the state of Maryland, and we don't always connect the dots. And so there's ways that we can do that through different legislation that's been offered and really large computer systems, and what we could do with the one stop and what we could do with the permit bill. And then here's a place where we can do it one-on-one when people are seeking help. So it's really just part of that broader, we make great programs in the state. Let's actually make sure that people who need it and deserve it can actually find out about it.
Thank you. And you know, you did really well. You
Thank
should
you.
take this video and send it with your law school application.
Thank you.
You should. You should.
Any Delegate Woods?
Madam Chair, if I may, I just want to join you and say, Ms. Ahmed, that was an amazing presentation. I watched you look down only one or two times at your notes. And so I just want to congratulate you and say, wish you the very best
Thank
in
you.
your endeavors. Isn't that so, Delegate Kaiser?
That is so.
Thank you.
Thank you. Is there, I don't see anyone else. All right. Oh, Delegate Lewis.
Thank you so much,
Okay.
Madam Chair. Thank you for the bill, Delegate Kaiser. Ms. Ahmed, are you planning to go to law school in the state of Maryland?
I'll be applying to different states, so let's see where
Okay.
I get.
And
Yeah.
with a quick follow-up, are you
Yes.
aware of the Senate and Delegate Scholarship Program?
Yes, I'm aware of it through
Okay.
Delegate Kaiser.
Okay, so I'll be happy to support. Thank you, Madam Chair.
Thank you.
The love fest.
Wonderful. We're very, very proud of you, and I hope your parents get to watch this.
Thank you.
All right, Delegate Rosenberg.
Are you also aware that there's a loan assistance repayment program that if you graduate and go to work for the government or a nonprofit, you get assistance in the repaying of your debt?
Okay, thank you so much.
Thank you for introducing and passing those bills, Delegate Rosenberg. Thank you,
And-
everyone.
Well, thank you for being with us, okay? This actually concludes the bill hearing on House Bill 1384. We're gonna move next to House Bill. Give me 1 second. Where's my list? I just lost my list, but we're gonna do, we're gonna do 1048. Behavioral Health Advisory Council on Commission and Commission on Behavioral Health Care Treatment and Access Alterations. And for that bill, may I have Alisa Lore, please, who's gonna present the bill? May I have Allison Taylor? And Ashley Toller, will you please come up and be part of this panel? Thank you, and you can get started, Alisa.
Thank you, Chair.
You're welcome.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and committee members. For the record, my name is Alyssa Lord, and I have the privilege of serving as the Deputy Secretary for Behavioral Health. Thank you for the opportunity to testify today on this important departmental legislation, HB 1048, which is aimed at aligning the work of a federally mandated behavioral health advisory committee with the work of the legislatively mandated Commission on Behavioral Health Treatment and Access. This bill would also require the commission to conduct a critical study on behavioral health financing and report back findings by January 1st, 2025. Last session, the General Assembly passed legislation establishing the commission. Once appointments were made, the commission quickly got to work and had work group meetings. The commission has completed an initial report to the legislature. 11 department employees provide day-to-day staffing for the commission, and the commission also has the commitment of leadership dedicated to this work. In parallel, federal law requires the department to maintain a behavioral health advisory council. The council is required in order to receive block grant funding from SAMHSA. The goal of this legislation is to streamline efforts in order to maximize the effectiveness of stakeholder input. Many members of the commission also sit on the council. This bill would allow for joint meetings and reporting and extends commission reporting deadlines to reflect when the commission was able to start meeting. Of note, SAMHSA is also in support of realigning these efforts. The bill also requires the commission to research and make recommendations to the governor and General Assembly regarding integrating behavioral health services into Maryland's Medicaid program. Maryland currently separates or carves out Medicaid financing of the behavioral health services from its Medicaid managed care organizations. This carve-out, established in 1997 for mental health services, aligned with a national trend at the time that saw carving out behavioral health services as a promising approach to protecting funding for behavioral health, establishing specialty provider networks who could provide specialty behavioral health services, and mitigating insurance plans from limiting their behavioral health benefits. In recent years, there has been a national growing discussion to shift or carve in and integrate behavioral health to Medicaid MCO financing. A key driver of this trend is the evidence that's shown that strategies to enhance clinical integration of behavioral health and physical health can improve patient care outcomes. Studies have shown that carve-in states outperform carve-out states by a wide margin, saving Medicaid $2 billion in state and federal expenditures, with notable changes, including an overall decrease of 6% in Medicaid costs per prescriptions and a 14.6% lower net cost for the MCO paid prescriptions than the average in the fee-for-service states. Similarly, a study done by the National Institutes of Health found that the financial integration of physical and behavioral health in Medicaid managed care was also associated with greater access to behavioral health services, particularly for individuals with mild or moderate mental health conditions, and for Black enrollees, which can help advance the fight for health equity. The current carve-out and separate financing of care may inhibit reimbursement for services, create challenges, and in referring patients from primary care to behavioral health care specialists and impede communications, which altogether can have a detrimental impact on patient health outcomes. Given the potential benefits and risks, it is important for Maryland to assess next steps on behavioral health integration through research and stakeholder engagement. The recently established Commission on Behavioral Health Care Treatment and Access is tasked with reviewing research and making recommendations to guide the state on providing appropriate, accessible, and comprehensive behavioral health services. Adding the task of researching and making recommendations on integrating behavioral health services versus the current carve-out system is an important next step to determine the next steps for Maryland. We request a favorable report on this legislation, and I'm happy to answer any questions.
Thank you. You are a pro now.
Trying, although I should have had that student who just testify on my behalf.
You did well. You did really
Very
well.
impressive.
It was very clear. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente. A little known fact that you all may know, I think MDH convenes something like 300 groups. And these two groups have like 20 overlapping members. So it really does make sense that they do their work jointly. And Kaiser Permanente also supports the study of the carve-in, thinks it's high time for that. So we urge a favorable report.
Wonderful. And thank you for being a partner. You know, you really always are.
Thank you.
Next, please.
Hello, my name is Ashley Tollett, and I am representing Maryland Coalition of Families in support of House Bill 1048. Last year, we served 4,603 families, and nearly 70% of those families were families with children. We are here to ensure that these caregivers and their families' voices are heard, ensuring that the commission and the council meet jointly and that they submit joint annual reports is imperative for our systems of care. Also, recommendations from the commission regarding the financing structure and quality oversight are necessary. We sit on the Behavioral Health Council, and ensuring that our family voice is heard in both the council and the commission is imperative to our family voices being heard where decisions are made at every single table. And we thank you, and we urge a favorable report on House Bill 1048. And real quick, I wanted to let you know, if you're not familiar with Maryland Coalition of Families, we're a statewide nonprofit organization, and we provide free family peer support to the loved one or to the caregiver of a loved one with mental health, substance use, or problem gambling disorder.
Thank you. Thank you for your work and for being here. We appreciate it. I'm going to open it up for questions now. Are there questions for this panel? Seeing none, thank you so much for being with us. We appreciate it. Next, we have Lori Doyle and Sika, Dan Martin, Ellen Weber. And will you please bring the two favorable with amendment virtual witnesses, please? Kashina Cross and Stephen Kroll. Lori, will you get started, please?
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. Our provider organizations greatly support integration of somatic and behavioral health care. That's why we came to you last year with a package of bills, and thank you for passing those to achieve that goal. But while we support integration of care, we do not support a carve-in of behavioral health into managed care companies. It creates grave concerns for persons served, for providers, for family members. I've attached to the CBH testimony a history of the carve-in, carve-out decision points that the legislature has been involved in. I ask you to take a look at it. For those of you who were on this committee in 2019, you may recall a carve-in bill that was introduced. The opposition was so overwhelming that the bill was subsequently withdrawn in the House and was withdrawn in the Senate before it was even heard. Luckily, we can improve integration and avoid the carve-in, carve-out discussion, at least for now, by looking at an innovative model that CMS just announced. It's intended to promote greater integration, and it's called the Innovation in Behavioral Health Model, or IBH. 8 states will be chosen to participate. The feds will provide implementation support and funding for care integration and care management reform. They'll also provide behavioral health practitioners in the model with funding to support health IT and electronic health records and practice transformation. So to our amendments, we ask first that you change the date for the integrated care recommendations from January 1 of 25, which would only allow 6 months of time for a very complex decision, and move that to July 1 of 2025, giving it a full year. We also ask that you consider language urging the department to apply for the IBH model when it becomes available this spring. The Senate passed the bill with those 2 amendments in it. It's heading your way, Senate Bill 212. We urge a favorable report with those amendments, and thank you.
And if I may, thank you, Lori, for being here and working with us. When I spoke with you, I told you that I agree with the July date. So that's why the Senate did it. And we were planning on doing the same. Have you spoken to the department? Are they in support of applying for that model?
In the testimony in the Senate, it sounded like they were going to be taking a look at it. I don't know how much detail has yet come out on the model. I think they're probably conceptually in support because that's exactly what it's focused on is greater integration. Hopefully, the Senate language is basically just urging them as sort of legislative intent that they take a look at that model.
I'll talk to them, but thank you so much. I
Thank you.
appreciate it. And
Thank you, Madam Chair. Members of the committee, I'm Ann Seacott, representing the National Council on Alcoholism and Drug Dependence, the Maryland chapter. We are also in support of the bill with amendments and not to oversimplify, but we like the amendments that the Senate did put on the bill related to the delay of date that you just heard Ms. Doyle talk about. And also including an assurance that any different model of financing absolutely ensures parity compliance just in terms of the existing federal law. I do also want to say that the substance use disorder treatment provider community's position overall on the carve-in, carve-out issue has not changed. We just don't believe we should be having this conversation of a debate between carve-in and carve-out. Everybody wants to make sure there's sufficient and efficient integration of care. There are innovative things that we can be doing and things that you all have passed, things that SAMHSA's come out, the federal government's come out with. So, we just want to make sure that we don't get stuck in that binary discussion about carve in or carve out, that there are other things that we can be doing. So with that, we ask for those amendments and a favorable report.
thank you for your testimony. Next, please.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland, here in support of the bill with amendments as well. Obviously, we support integration of care, one body, one mind. And we really applaud this committee for spearheading a package of bills last year that is helping to integrate behavioral health and somatic care at the clinical level, both in primary care offices and in specialty behavioral health clinics. When it comes to integration, the devil's really in the details. There are nearly 320,000 children and adults served by the public behavioral health system in Maryland. And whatever we do needs to be done with an eye towards preventing a disruption of care for those individuals. We also need to, any reforms also need to be done with an eye towards maintaining the positive elements of Maryland's public behavioral health system that have made it one of the best in the nation. Those things include, in addition to the Medicaid population, Maryland's system covers uninsured and underinsured individuals, Marylanders 65 and older, and those are duly insured. It provides a single point of contact for community mental health and substance use treatment providers so that they can reduce administrative burden, focus really on providing services to folks in need. And it has strong local management component to address different needs in different communities. And so, we echo the request for an amendment to push the date back from January 1st, 2025 to July 1st, 2025, just to make sure that the commission has the time to consider all these complexities. And we also are requesting one additional amendment to add a member to the commission. Older adults have very unique behavioral health needs. It's something that the General Assembly recognized when establishing this commission by establishing that one of the 4 standing work groups is a geriatric behavioral health work group. But unfortunately, through oversight or some other reason, the Maryland Department of Aging is not represented on the commission. They are a really, really important partner in our efforts to improve access to mental health and substance use care for all Marylanders. And so we would ask that the Secretary of the Department of Aging or the Secretary's designee be added as a member to the commission. And with those amendments, we urge a favorable report.
Next, please.
Thank you, Madam Chair and members of the committee. I'm Ellen Weber with the Legal Action Center, testifying in favor of 1048 with amendments, and the center in Maryland convenes the Maryland Parity Coalition. We support 1048 with an amendment that would require the commission in issuing its recommendations to ensure compliance with the Mental Health Parity and Addiction Equity Act. The Senate has adopted this amendment in SB 212. The department had no objections, and we are working with Delegate Lewis, who we thank, for submitting an amendment on this for this bill. Compliance with the Parity Act is it's a foundational requirement, regardless of the financing and service delivery model. Non-discrimination standards have to be baked in at the beginning, not evaluated on the back end. And these protections are at the heart of access to care. They regulate network composition, utilization review, authorization standards, and benefit coverage. State law also requires that Maryland Medicaid comply with the Parity Act, specifically with regard to scope of benefits, billing limitations, and reimbursement rates. We believe that it's very important for this legislation to reinforce the department's legal obligation to demonstrate parity compliance. The department has unfortunately failed to demonstrate that over the last 4 or 5 years. It has never conducted a compliance analysis with regard to reimbursement rate setting. Over the past 4 years, the federal regulators have identified compliance problems. In 2023, the department fixed several service limitation requirements that prevented individuals from getting services on the same day for different purposes, even though those have been in place for many, many years. And then most recently, the report has a lot of analytical problems that just prevent us from really determining whether there's parity compliance. And so, again, as we've mentioned, parity compliance has to be addressed on the front end and on an ongoing basis. For that reason, we respectfully request a favorable report with amendments. Thank you very much.
Thank you. I'm going to open it up for questions now, okay? And thank you all for your work that you do with this committee and our members. We appreciate the partnership. Are there any questions? Seeing none, thank you so much. Next, we have, there's a Kashnia Cross who's not here virtually for the record, but we do have a Stephen Kroll.
Yes, Madam Chair. I'm trying to log on. Hopefully you can hear me. I have very brief.
We can hear you. Why don't you give us your testimony?
Very good. Good afternoon, everyone, members of the committee. I'm Stephen Kroll, the State's Attorney Coordinator for Maryland and the Executive Director of the Maryland State's Attorneys Association, here in support of HB 1048 with one very simple amendment. Among other things, the bill requires establishment of a number of work groups, including criminal justice and involved behavioral health, but it did not include the Maryland State's Attorneys Association. We want to be included. We want our voice to be heard. In number 9, 10, and 11 of the bill, all these issues are items the state's attorneys have valuable input on, particularly given the specialty courts we participate in dealing with forensic and court order populations. We are in support of this bill 1048 with, again, one simple amendment: include the Maryland State's Attorneys Association, whose voice wants to be heard. Thank you very much.
And thank you very much for being with us, and thank you for the work you do, okay?
Thank you very much.
Let me open it up and see if anyone has a question for you. Are there any questions for this witness? Seeing none, thank you, sir, for making the time to be with us. We really appreciate each and every one of you in this committee. Thank you for those that are waiting to be called. This actually concludes this bill hearing on House Bill 1048. And next, we're going to House Bill 1078, Delegate Woods, Maryland Medical Assistance Program, remote ultrasound procedures, and remote fetal non-stress test. Delegate Woods, you have your panel, which is Dr. Moran, Pam Casemeyer, and there's a virtual witness. Will you please bring that witness up? And that's it for this bill. Those are the only witnesses. So if you can come up, please come up with a delegate. And delegate, I am stepping away because I have a meeting with this Do It secretary at 4:30, but I'll be back. Delegate Collison will be sharing your bill, okay?
Would it be inappropriate, Madam Chair, for me to have a temper tantrum?
As long as you're sitting by me.
Go ahead. You can get started.
Excuse me.
I'm gonna try not to take that personal.
Oh, you know you're my second best favorite. And when she walks out the door, you'll be my favorite.
Go ahead.
Good afternoon again, Madam Chair, Madam Vice Chair, and members of this Health and Government Operations Committee. For the record, I'm Delegate Jamila Woods, District 26, and I'm here to request your favorable response for House Bill 1078, Maryland Medical Assistance Program, Remote Ultrasound Procedures and Remote Fetal Non-Stress Tests. Remote ultrasound procedures and remote fetal non-stress tests provide vital supports resulting from technological advances designed to improve access to maternal health care. Many women who struggle to obtain appropriate prenatal care experience numerous barriers, including difficulty obtaining time off from work, lack of reliable transportation, inability to obtain childcare for other children, and or an existing medically challenging pregnancy where increased movement can adversely impact the mother and or the child. This bill provides doctors with more options to ensure prenatal care for those who are unable to make routine ultrasound and or non-stress test appointments in person. Teleobstetric technologies approved by the FDA have enabled new and innovative technologies to improve access to maternal health care, including teleultrasound and remote fetal non-stress tests, and ultimately expanding access to these pertinent service provisions. Madam Chair and fellow committee members, the reality is this: Maryland has room to improve maternal health outcomes. According to the March of Dimes Maryland Facts page, in 2023, 10.3% of babies are born preterm compared to US average of 10.4%. Several counties in Maryland have even worse preterm births. They include Cecil County with a 12.4%, Calvert County with an 11.3%, and Baltimore City with a 12.9%. Additionally, the preterm birth rate among African Americans is 1.4 times higher than others. The infant mortality rate is 6%, which is higher than the national average of 5.4%. Finally, in Maryland, 17.3% of moms don't receive any prenatal care until the 5th month or later, or attend less than 50% of the appropriate number of visits for the infant's gestational age. This compares to the national average of 15.5%. So how do we pay for this advanced technology in Maryland? I'm glad you asked. Current procedural terminology, or CPT codes, represent the system doctors utilize to bill insurance companies. The CPT code tells how much an insurance company should pay the doctor for the service offered to the patient. For example, anytime a doctor performs a fetal non-stress test, they bill insurance with a specific CPT code that's 59025. I told you the actual code. This legislation allows that same doctor to bill using the same CPT code when the person is remote with all of the requirements met. Since Maryland Medicaid already covers CPT code 59025, this bill does not create any new coverage requirements. It simply clarifies how physicians can bill. The same would hold true for the variety of ultrasound CPT codes. House Bill 1078 allows current CPT codes for both ultrasound and non-stress tests to be billed when the patient is remote. This provides the same standard of care, making this advanced technology and crucial monitoring service more accessible and more convenient for expecting mothers with high-risk pregnancies. Remote ultrasound and non-stress tests will also improve care compliance. This bill does not create new services, but it increases care compliance for prescribed ultrasounds and fetal non-stress tests. This bill clarifies that providers can offer patients remote evaluations through teleobstetrics technology. I said that right. I won't say it 3 times. As long as the same standard of care is met. Other states like Pennsylvania, Ohio, and Missouri have recently clarified that fetal non-stress tests and ultrasounds are billable when the patient is remote. The Virginia legislature just passed similar legislation unanimously through the House and Senate over the last few weeks. And for this reason, my fellow colleagues, I am requesting a favorable response for House Bill 1078. Thank you.
Thank you, Delegate.
Yeah.
Dr. Moran.
Yep, thank you, Presiding Chair Collison and members of the committee. For the record, Ryan Moran, Deputy Secretary of Healthcare Financing and the state's Medicaid Director. The Maryland Medicaid program in the Department of Health supports House Bill 1078. 1078, as reviewed, requires Medicaid to provide remote ultrasound procedures and remote fetal non-stress tests beginning on October the 1st of 2024. I also want to make a note that the Maryland Medicaid program covers 32,000 births annually. That makes up about 47% of all babies in the state of Maryland. And so we know, as just outlined, that effective prenatal care is critical to improving those health outcomes. So we just want to emphasize that this particular bill, we do cover these services in terms of our existing telehealth policies, but to Delegate Woods's point, this is clarification of that particular coverage and services that's provided today. The last thing that I would say is, from a remote perspective, we know that this bill has the opportunity for individuals who lack transportation or those that live in rural areas, that when frequent visits are required by a specialist, that these could become less burdensome in terms of this particular coverage. So department is in support and looks forward to working with Delegate Woods and the rest of the committee in terms of the passage of the bill, and we request a favorable report.
Thank you. Thank you, Ryan. Questions for the delegate or her panel?
Actually, there's one person who's
I'm sorry.
That's okay, who's participating virtually.
Mr. Hoffman. Go ahead, please.
Yes, hi, everybody. Thank you, Madam Chair. My name is Evan Hoffman. I'm the Director of State Government Affairs for Phillips, and we're here to support House Bill 1078. Sorry I can't be there with you all, but appreciate the opportunity to say a few minutes of remarks. Just real quickly, Phillips, we're a healthcare tech company. We employ 700 people in Maryland. We make everything from Sonicare electric toothbrushes to AEDs to medical imaging to patient monitoring machines. Most of the hospitals in your districts are likely Philips customers. We also have a deep legacy in maternal and infant health. For over 30 years, we're one of the leading manufacturers of both ultrasound and obstetrics, labor and delivery monitoring equipment. And we're here to be a resource given on this bill, given the impact that it has on technology. So definitely appreciate all the focus on maternal health today by this committee. These same conversations drive our innovation here at Philips every single day. How can we tackle today's challenges by leveraging technology and digital tools? And now through innovation, as Delegate Woods conveyed, we can offer some of the most common prenatal care procedures that we know work. We've been taking care of women with high-risk pregnancies for decades successfully. The issue is about ensuring that women comply with prenatal care plans, and that's what this bill does and will enable. Just add a few more points. When we talk to our customers, hospitals and OB departments, we hear from them that clarity here is very important. The current CPT codes could be ambiguous when it comes to offering some of these care procedures remotely. And that's why this bill is so critical. And so, of course, we acknowledge that remote prenatal care isn't the right option for all moms. And in-person care, of course, remains vital. But this bill, importantly, puts the decision within the provider. They can use their discretion to offer prenatal care appropriately, especially for those moms who would otherwise struggle to access their care appointments. So for that, we support. Thank you.
Thank you, Mr. Hoffman. Delegate, would you mind if I called Pam Casemeyer up and then
Please.
everybody would have spoken? So go ahead.
We didn't sing, sorry.
And then we'll ask questions after Pam speaks.
One of those days.
We understand.
Hello, everyone. Pam Casemeyer here on behalf of MedChi and the College of Obstetricians and Gynecologists and Academy of Pediatrics. At this juncture, I think I'll largely say me too. And but part of why we're here is a little bit, as Mr. Moran said, even from Medicaid. My folks said most of this is already covered, but the clarification is good, because as we move forward and continue to look how to enhance access and delivery of services in a way that's best for the mom and baby, having this clarification is a very good thing. And with that, I will be quiet and we can take questions.
Thank you. Thank you very much. Questions, Delegate Tiveros?
Thank you. I'm guessing it's for the gentleman in the technology that works in the area of the technology. Thank you, Madam Chair, and thank you to my roommate for putting this bill forward. And I can definitely see the value to the bill. Not my concern, but my question is the science behind it. How does this work? I'm just curious.
Can
sure.
I actually
So,
answer that? I'm so excited to have the answer to that. Do you mind, Mr. Hoffman?
Go ahead.
So what happens is the mother, she could be at work, she could be at home. And I'm so sorry, Mr. Hoffman, I didn't bring my pictures because I actually have pictures of me with the sonogram and the belt that goes around the mother. But she could be at home, she could be at work, and this equipment is put on her and is for the sonogram, there has to be a professional person there to actually do the work. But the belt, she would have a doctor's appointment, just like a regular doctor's appointment. And the doctor would be able to sit there with her and in real time do an assessment on her using that belt that gives all of the information that that doctor needs regarding that child and the progression that that child is making. It happens in real time. She gets the answer. So you actually have to have an appointment time. The doctor is monitoring her in real time, is looking at what's going on in real time. Same thing with the sonogram. So I was so impressed when I saw this and saw how it worked. So if somebody wants to ask Mr. Hoffman a further question, I just wanted to share that because I was so excited to actually see. No, they're not with, they're with them telehealth. Yes.
Delegate Johnson, do you have a question?
Thank you, Madam Chair. Mr. Hoffman, would you have anything to add to that?
I'll just provide an example of how this is being implemented in another state so you can understand the potential here. We have one provider who is based in Albuquerque, New Mexico. He's an MFM provider, and through teleultrasound capabilities that New Mexico has enabled, he has created 7 satellite ultrasound clinics across rural New Mexico. He staffs it with a trained sonographer, but he can be based in Albuquerque and review these ultrasound scans on a real-time basis. So instead of mom having to drive 2 to 4 hours in New Mexico to Albuquerque, now they can drive to a closer clinic. So this legislation just allows providers to kind of get creative in how they will enable access to this technology through remote solutions.
Delegate Tiveros, how can we help?
Thank you. Let me just, for full disclosure, I was studying quantum chemistry. So I'm trying to understand how you're capturing the data. Is it vibrations? Is it like laser analysis? Like I'm trying to figure out what is it in the belt that's capturing that you're able to, so it's like, is it a X-ray? I'm trying to understand how are you capturing the data and how it's being transmitted to the doctor?
Sure.
It's going to a satellite, I get that. And if that is too specific, I get it. I'll try to look it up, but I'm just really curious.
Sure, thank you, Delegate, for that question. So the remote non-stress test belt uses transducers. So they pick up certain types of physiological factors within the mom. So when you're in a hospital and you have a non-stress test, they are measuring fetal heart rate, fetal movement, and uterine contractions. So the FDA has approved that same non-stress test can now happen remotely through a remote belt. So those transducers are measuring those same physiological points. They're looking at fetal heart rate, fetal movement, and uterine contractions. That data that the transducers pick up, it's not through X-ray. This has no harm to baby or mom. That data gets transmitted through like a virtual cloud directly to the provider, who can then interpret that data on a real-time basis. Most of the time, fetal non-stress tests are going to be okay. But in that moment, if the data is presenting a situation where the baby is not responding appropriately, there is no movement, for example, then the provider can call mom in for further testing in person.
Better? Okay. Okay. Thank you, Delegate. Any other questions? So I have a question, and I'm not sure who the best person is. Do Maryland physicians who serve Medicaid patients currently have this technology, or will they be required to purchase it? Or how, I mean, it's great, I want to do it, but I want to know how we implement. So anyone, which of you?
Yes, I think some of them do, and then others may invest a bit. And I think, as I was saying, when I talked with the OBGYN Society, many of them believe this was already covered because some of them are already doing it, but they wanted some clarification so that as it moves forward, it doesn't become a question mark. So if they do invest or set up that kind of framework, that it is continued to be recognized.
Okay, great. Thank you. Any other questions? Seeing none, thank you all very much. Thank you, Delegate, for the bill.
Thank you.
That concludes the hearing on House Bill 10078 or 1078. And we will go now to, you don't have to go anywhere, Delegate Woods. To House Bill 1040. Meryl and Dr. Moran, I think you're probably back up here too. Maryland Medical Assistance Program, Limited Behavioral Health Services. And you have Ann Seacott, Joyce Harrison, Jake Whitaker, Ashley Towler.
All right, well, good afternoon again, Madam Vice Chair Cullison and members of this Health and Government Operations Committee. For the record, I'm Delegate Jamila Woods, District 26, and I'm here to request your favorable response for House Bill 1040, Maryland Medical Assistance Program Limited Behavioral Health Services. House Bill 1040 allows children and adolescents under 18 years covered under Maryland's Children's Health Insurance Program, or CHIP, to access a number of behavioral health services without the need for a diagnosis. Our current billing and payment system requires a diagnosis for behavioral health providers to be paid. For very young children, it can be difficult for providers to make an accurate diagnosis, sometimes, if not often, resulting in a presumptuous diagnosis, resulting from barriers including the minor's limited language articulation, the minor feeling uncomfortable talking with adults, and or the need for the clinician to contextualize issues the minor's parents or caregivers are experiencing, or issues the minor may be reacting to in the school or in the community. Our current system requires, even for the youngest minor, a diagnosis after just 3 visits with a provider. Frankly, it could take longer than that just to establish a rapport with the minor. House Bill 1040 is not increasing benefits. It is broadening eligibility. It does not say or discourage providers from giving a minor a diagnosis when appropriate. Instead, it removes a barrier that allows for earlier intervention services and real prevention to take place. A minor can have symptoms without meeting the criteria for a formal diagnosis. With early support, a minor can obtain needed services before symptoms worsen, resulting with the minor meeting the criteria for a behavioral health disorder. Prevention efforts help to reduce costs and improve outcomes for the minor. Whether we like it or not, there remains a stigma and shame associated with behavioral health and behavioral health care. Many parents don't want their children labeled by a diagnosis. The stigma and shame can show up also in school settings where minors may be treated differently, or expectations for the minors are related to their diagnosis. California enacted this policy in 2022. Colorado followed suit just last year. HB 1040 includes a work group. That group of stakeholders will discuss and make recommendations relating to other suggested services in addition to those named in this bill. And for this reason, I request your favorable response to HB 1040. I have some wonderful panelists here with me, and I'm going to ask if Joyce Harrison, followed by Angela Kimball, Jake Whitaker, Ashley Toller, and Ann Seacott would present.
Fantastic. Yes,
Who's
great.
virtual?
You wanna bring Angela
I'm
up?
sorry, Angela Kimball, who's going to be second, is actually virtual.
Okay.
Okay, thank you so much.
Is this all right?
Yeah, you don't have to touch it.
Okay, thank you so much,
You're
Delegate
quite
Woods, for
welcome.
supporting this bill.
Absolutely.
I'm here in a couple of capacities. I am Joyce Harrison. I am a preschool and early childhood psychiatrist. So I specialize in treating children under the age of 5. But my bigger role in this state is as the president of the Infant Mental Health Association of Maryland and DC. And my mission today is to really get you all to understand very, very early psychiatric mental health intervention for young kids and why the removal of this requirement to have a diagnosis for a child who's under the age of 5, and I do believe it applies to all children, and I'll talk a little bit more about that, really could be life-changing. And we know this administration is all about upstream intervention, and I think that access is a huge problem. I know access is expensive, but I can promise you that early intervention really saves money downstream. And so I think this will improve access. But what the two things that I want to stress is that treating very young children is very different from treating older children in the mental health system. For one, they have a very limited range of what they can express to us, and it's all behavior. But very often what's underlying that behavior is not mental health. It's not emotional. It can be trauma. It can be developmental. It can be communication. It can be a number of things. And I work at Kennedy Krieger. We have assembled a team because very often we see children who are very complex and we can't sort out exactly what's going on with them. And I will tell you that I am one of the few people across the state who will see children under the age of 5. And I will say that probably for every 10 children that I see, 1 or 2 of them, the diagnosis actually lies within the child. It's a mental health diagnosis within the child. More often than not, communication problems, speech problems that are subtle and don't get picked up can lead to these severe behavior problems. So treating the behavior really does not help this child until you treat the speech and do the appropriate intervention. My time's up. Okay, ask me more questions.
Thank you so much.
Thank you. I'm sure that there will be. Thank you very much. Who would you like to go next, Delegate?
I think we want to have our virtual witness, Angela Kimball.
Thanks. Go ahead, Ms. Kimball.
Thank you, Madam Chair, members of the committee. For the record, my name is Angela Kimball. I'm with Inseparable, a national nonprofit focused on closing the treatment gap for the many people who live with mental health needs. I'm testifying in support of HB 1040, which, as you've heard, allows children covered by Medicaid to receive very basic mental health supports, regardless of whether they have a formal diagnosis. We're grateful for Delegate Woods for introducing this bill, which is really a smart approach that breaks down the barriers that both clinicians and families face when a formal diagnosis is required to provide children the help that they need. And we know that every day children are struggling with mental health concerns, whether it's anxiety about going to school or adjusting to a new parent or a new sibling, or coping with the loss of someone that's close to them. Children can struggle and experience stress without meeting the criteria of a formal mental health disorder. And they should be able to access the very mental health supports that could help prevent a diagnosable condition or the need for more intensive or costly services. And I'd like to note that 10 states already cover 6 or more visits for children ages 0 to 6 without a mental health diagnosis. Maryland allows for 3 or under. And as was mentioned by the delegate, California and Colorado have already enacted legislation that does what this bill does. It's really a timely, transformative step that'll promote prevention and support the well-being of children, which is vital to a thriving society. So we respectfully urge a favorable report on HB 1040, and thank you for the opportunity to testify.
Thank you.
Thank you. All right, we'll go back to
Jake Whitaker.
Great. Thank you, Madam Vice Chair, members of the committee. Jake Whitaker on behalf of the Maryland Hospital Association, here to support House Bill 1040. More than 200,000 patients visit Maryland emergency departments seeking behavioral health services each year. As we all know, the behavioral health crisis in Maryland contributes to ED length of stay and hospital discharge challenges here in Maryland. When patients have access to these services in primary care settings, they can get the help that they need at the onset of the behavioral health conditions rather than being in crisis and going to the emergency departments. So House Bill 1040 would require the Medicaid program to provide coverage for critically and much needed services in the community and in primary care settings to help folks avoid unnecessary ED utilizations. I just want to thank Delegate Woods for her leadership on this issue and on other behavioral health bills as well. And so for the aforementioned reasons, we respectfully request a favorable report on House Bill 1040. Thanks.
Thank you, Jake. Who's next?
Next, we have Ashley Toller.
Hello again.
Hi.
I'm Ashley Toller. I'm with Maryland Coalition of Families, and we're testifying in support today of House Bill 1040. And many MCF families are concerned that a premature diagnosis will stick with their child long term. A mental health diagnosis is unique and complicated for all, but particularly for children. This bill gives our families more time to move forward in a healthy and effective manner for their child, for their growing and developing child. And this ensures ethical practices and appropriate payment for the provider. For example, a child who was admitted into inpatient treatment with a plethora of mental health diagnosis, after some time, they decided to assess this child for autism. The child had a history of trauma and indeed tested on the autism spectrum. In conclusion of this child's treatment, it was found that at least 2 of the diagnoses were incorrect. Unfortunately, some of these diagnoses remained on the child's record, leading to frustration for the parent to have to explain and provide more documentation to aftercare providers over and over and over again. Also, trauma can also mimic many mental health diagnoses. And delaying a diagnosis gives the provider and the patient time. And thank you, and we urge a favorable report on HB 1040.
Thank you.
Thank you. And last but certainly not least, we have Ann Seacott.
I'm happy to do this. Good afternoon again, Ann Seacott, representing, I have a number of clients that are supportive of this bill. I'll put on my hat again for the National Council on Alcoholism and Drug Dependence. I want to tell you how much fun I've had learning about this concept. I had not heard of it before, about no diagnosis and what that means. I have talked to dozens and dozens and dozens of providers around the state about this. And with the exception of literally 2, they love this idea. Whether it's because, as you've heard, for very young children, it can be hard when the kids aren't as verbal. They're not being able to maybe express everything for the therapist to be able to provide a diagnosis. We've heard the stories about adolescents that have multiple diagnoses, different diagnoses with different providers, and to find out that none of them were actually accurate. This is not about providers not doing well. This isn't about poor care. This is about kids who, because of verbal limitations, because of behavioral problems, because of family problems, because of puberty, the kinds of things and behaviors that kids go through, to say the only way they can access services is if they get a diagnosis, really is something that prevents the right kind of care and the services that are needed. The diagnosis isn't what's needed. The diagnosis is needed for the system, for the billing system to work. And so I just want to say this has been fun to learn about. We think that we're really onto something here. And based on what you've seen from the department, they acknowledge this is going to increase access to care. That's a good thing if we're increasing access to care, especially if it's early intervention that saves money down the road. So we ask for a favorable report.
Great, thank you. I think that's the sponsors panel. Questions for this panel? Delegate Gazzoni.
Thank you, Madam Chair. So I just want to make sure that I'm clear on this, and I think I'm going to direct the question to Dr. Harrison, but decide among yourselves. My sense from hearing you was that this is important to ruling out mental health challenges, particularly in very young children, which I think is a kind of a great thing. Because certainly as a parent, you certainly would like to have that ruled out and have it be, you know, a speech delay or something like that. So that's the basic question, just so I make sure I'm like clearly on the mark here.
So can I just
Absolutely, please.
like clarify a little bit? So diagnosis is a process, and it is a process of elimination often, if it's done carefully and if it's done well. I think very often we need a diagnosis. Let's snap this one on, and it really is a disservice. And so I think if we view assessment and making a diagnosis as a process, and that process in young kids can take a very long time, because you need, like, you're exactly what you said. It's a rule out. It's make sure there is no other thing accounting for this child's behavior that could be treated in a different way. So yes, thank you for that question.
Opportunity
It
to have that
provides
before
yes, it
putting
provides
any stamp on something.
exactly.
Great, thank you so much.
Thank you for the question.
Thank you. Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Woods, for the bill, and to all your panelists. I want to make sure I understand how a provider makes a treatment plan without a diagnosis. So maybe you could
I can
explain.
happily talk to that. So my treatment plans typically have 5 categories, and they are further assessment, educational needs, psychosocial needs, family needs, social determinants, then medical needs, and then behavioral needs. So that's a typical treatment plan for me. So I have, for the children that I see, I often have multiple things and very few things under the medical, and I'm the medical piece. So that treatment plan is really based on all of the information gathered. And my approach is not, because I will say that more than 80% of the kids I see have more than one potential diagnosis or a known diagnosis. They come to me because they have a handful of diagnoses and nobody can figure out why they're not getting better. And that's what I do. So I really do this deductive, like, let's really dig deep and see what's there. So the way my treatment plan is formulated is I will get information from as many sources as I can and prioritize. First, ask the parent, what are you most worried about? What is the most problematic behavior? Usually in these young kids, it's a behavior, but it can be other things like he's not affectionate with me. I don't have a good relationship with him. Early childhood health is relational health very often. So what are those top 3 priorities? What is the teachers in the classroom or the earlier saying? And together with everybody, we come up with a plan in there, target behaviors or target concerns on the part of the family, the school, or anyone else involved with it. And then we figure out how can we figure out what's behind that particular symptom, or how can we improve that that symptom. It might be behavioral, it might be, kids just acting out in school. Let's figure out if we can make some interventions in the school to help that. So that's the way I do it. And I think it's a good way to do it, because I think when you do that, you actually can get at what it is. So target symptoms, target behaviors, and target concerns. And very often there's huge overlap in all the diagnoses with these concerns. Aggression, we see it in all kinds of mental health diagnoses, developmental diagnoses, neurodevelopmental diagnoses. So that's it.
Thank you. Delegate Alston.
Thank you, Madam Chair, and thank you, Delegate Woods, for this bill. I have 2 questions. One, I wanted to know if the sponsor had an opportunity to look at the note and if you had any ideas on how to reduce it.
You know what? I have to get back to you on that one.
Okay.
Is that okay? Okay.
Yeah, no problem. And then the other question is for the doctor next to you. I was wondering, you wanted us to ask you more questions. So I'll start with one, which is, could you speak to the number of children who are in juvenile detention centers, possibly between the ages of, 10 and 12, that have diagnosed mental health disorders, and how often that's happening and the trauma that they experience when they are detained in those type of situations versus being provided healthcare that they desperately need?
Yeah. So as I said earlier, my area of interest is really under 5, and I honestly lose interest when they get older. They're just not as interesting. But I can tell you that I know this is true, because I've worked in I've been a child psychiatrist in Maryland for 30 years. I've worked in every level of care in many different regions in the state. And I can tell you, part of the reason I gravitated toward the little ones was because I thought if we figure this out early, they won't end up in juvenile detention because that's not where they belong. That treatment is not going to help. But I know there's a huge percentage of the kids like in Rika that have psychiatric diagnoses. And I think that this is a perfect example of why if we could have intervened early and really be clear, because I do think a lot of the trauma related disorders don't get diagnosed, they get missed, and when they don't get addressed, they just worsen and worsen, and then the behavior just levels. But I can tell you there is more than half, I know this for sure, there are more than half the kids in juvenile detention have at least one psychiatric diagnosis, often 2 or 3 psychiatric diagnoses. So thank you for asking that. I wish I had more of the numbers. I know this group likes numbers, but I just have the gestalt and I know this to be true. Oh, wait, Ashley says she knows.
Well, I don't know the numbers, but I was a youth who was in the foster care system and I was in placement with DJS kids. And I would say every single one that I knew had a mental health diagnosis. So.
Good delegate? Okay. Delegate Tavares.
Thank you, Madam Chair. Just looking into thank you for that question, Delegate Austin. With regards to the opposition letter from the Department of Health, I'm assuming that the reason that they're opposing is the issue of the cost. They're saying that they spent last year 551 million and that this would increase the utilization of the services by 20%. And it would be a fiscal impact of 110 million in total funding per year. But my concern is that, I don't know, maybe I'm misreading it, if I'm misunderstanding the letter, but is it that this says that it seems like there's a duplicative service that's being asked to be done, like that whether the individual has a behavioral health diagnosis beginning or not? Am I misunderstanding the letter? I'm sorry, I'm a little lightheaded.
No, if I may, touching the mic, if I may, Delegate Tavares, thank you very much for the question. So I think with the bill very intentionally doesn't increase eligibility. It doesn't increase benefits. These are children who are currently in the Children's Health Insurance Program, CHIP. And what we're saying is for those same children who have access to these services, that the provider doesn't have to give a diagnosis for the child to receive those services. That's what this is about. Other states have figured it out. There's part of the stuff that I learned about are these Z codes that are about social determinants of health. And that's a way that some of this might be able to be done. So I think how I read that letter of opposition is they're saying, because we aren't going to require a diagnosis, that means more children will access services. It's the existing pot of kids, it's the existing pot of services they could get. They're saying without the diagnosis codes, more kids are going to get more behavioral health services. I don't see the problem, but yeah.
Oh,
absolutely.
Dr. Moran is going to be coming up, so he's going to help us understand as well. Any other questions? Okay, seeing none. Thank you all very much for your time and your testimony today. I will now call up an unfavorable panel. That is Ryan Moran and Alyssa Lord. The seat just got a little hotter, Dr. Moran. Right.
Good afternoon again. So thank you for the opportunity to testify today on this important legislation, House Bill 1040. MDH is absolutely dedicated to ensuring that participants in the public behavioral health system have access to the full continuum of behavioral health services, inclusive of the opportunity for prevention, early intervention, increasing access, and continuing to decrease the stigma associated with behavioral health. This is especially important for children under 18. While the MDH recognizes the potential value in the care delivery model proposed by HB 1040, implementing the legislation would require substantial structural changes to allow how the MDH handles mental health and substance use disorder services. Maryland currently operates a bifurcated care delivery system for mental health SUD benefits. Managed care organizations are responsible for delivering the majority of Medicaid covered services, including primary behavioral health care. However, specialty mental health and substance use services are delivered on a fee-for-service basis through the Administrative Services Organization, or the carve-out. Primary care providers can bill Medicaid for up to 3 sessions with a child to assess and evaluate behavioral health needs through evidence-based tools to work with specialists to correctly identify behavioral health diagnosis if warranted. This behavioral health diagnosis code then allows the child to continue their treatment with a specialist in the ACO, as well as for the provider to develop the plan of care or treatment plan to best support the child and their family. There are also no restrictions or preliminary diagnosis needed for a child to access behavioral health services through the ASO. What is required is after 3 visits, providers to provide a diagnostic code, no different than on the somatic side. We support youth access. I'll turn it over.
Go ahead and finish your.
Okay,
your
thank
thoughts.
you. We support youth access to services across the continuum of care through primary and specialty providers, and by no means want to be a stalwart for progress or innovation. Our primary concern is how to operationalize this type of program in our current carve-out model. This is another reason why we need to study the carve-out. Given the need for the study of the public behavioral health system, as well as how this type of program would operationalize within this environment, and our best estimate on the fiscal note, we respectfully request an unfavorable report on this bill, but are fully committed to maintaining the dialogue.
Thank you.
Good. Presiding chair and members of the committee, it's good to be back. And Delegate Woods, thanks for this bill. Also, on behalf of Deputy Secretary Lord and I, we want to thank the sponsor, Delegate Woods, and also speaking with stakeholders and learning more. Certainly learned a lot and much more to learn in terms of our testimony that we're going to provide, both from California's model as well as some of the other models that they brought forward. I want to mostly echo what Alyssa is saying in terms of the department, obviously knowing how critical behavioral health is in terms of servicing populations. The reality is that the brain and the physical portion of the other physical portion of our body are connected, but our healthcare financing system is bifurcated. And the whole premise of the carve-in or the carve-out model that we have is based on diagnosis. And so when we think about these particular models, these novel, innovative models that started here in California, and we think about how those are adopted in Maryland within our particular system, it does give us pause to figure out how we do those particular models within the system that we have. And other states that have been cited who have executed this particular model, I'd remind you that Maryland is one of a handful of states left with a carve-out model that specifically rides on diagnosis. So I think, I'll conclude by saying that we're happy to continue to work with stakeholders and learn more about the model. We have a commitment to talk with our Medicaid colleagues in the state of California to understand how to operationally work through some of these issues. But at this time, we would warrant attention and focus to the bill that was heard previously today around studying the healthcare financing bifurcated system. Our bodies are connected. We want to remove stigma, and we should be looking at that issue very closely. Thank you.
Thank you. Questions for this panel? Delegate Woods?
Thank you so much, and thank you both. My question, as you all know, is when we talk about the carve-out model, I'm having a challenge, and I need you to help me understand the diagnosis, as I understand it, is only because of payment. And so as a primary care physician, you know, I shouldn't be diagnosing somebody with something before they've had the appropriate test done. And so, but they get paid as a general practitioner, is that correct? And if so, can you help me understand? I'm still just trying to really understand that. From what I understand, it's a coding issue more than anything else.
So if we think about the somatic example that you're giving, even when you see your provider, they're still providing a preliminary diagnosis to move forward with tests that you might need, right? So you come in, you present with a specific complaint, that provider is going to attach an E&M code or a diagnosis code to figure out what are the tests that you might need to determine whether or not you have a specific diagnosis. It's no different on the behavioral health side. On the behavioral health side, we allow up to 3 visits before that diagnosis has to be attached, where then on the 4th visit, if there's no diagnosis, you then might run into an issue on payment. So I don't know if that provides additional clarity, but we've really tried to give as much bandwidth based upon the information that we have. What's the time frame using evidence-based tools to assess before a provider would recommend a diagnosis in order to form that very critical treatment plan?
Yes. Thank you. So it just came to me, and maybe you can help me. So for example, when I think about the therapeutic side, I think of like DSM-5, right? But then there's the ICD-10 codes, which are much broader. And I'm wondering, could you not find something that would be more appropriate rather than having to actually give a psychiatric diagnosis, if you will?
Well, this is the challenge that I think Deputy Secretary Moran was referring to, in that we have this bifurcated system, right? So we have, on one hand, we have Medicaid managed care organizations that are paying for our somatic care, which is disconnected from our behavioral health system. Ryan, I don't know if there's anything you want to add.
No. Delegate Kaiser.
Thank you, Madam Chair. I had a question. I was looking at the fiscal note. Couldn't completely make heads or tails of it in the paragraph about the state fiscal note, about the money that's spent, and then the 20% increase you expect in substantial administrative costs, and then the part on the illustrative purposes only. I'm just trying to understand if you're expecting 20% more. I understand that there's about 140,000 children in CHIP. By the math of putting all these things together, it looks like you're saying this would cost about 40,000 per child. So I was just trying to understand what inputs that you all offer the fiscal note writers to get them to these high numbers.
So I'm happy to have a conversation about fiscal notes all day. So a couple of things. I will admit that these models that we look towards to other states and other state experiences are very new. So California, in terms of the site that's modeled as January 2023, there's not necessarily, if you will, claims runout data or a significant founding of what we can look on when we looked at this fiscal note, Delegate Kaiser. So there's a basis and there's assumption that we made that if you were allowing children to be seen without a diagnosis, that would hypothetically, we would presume, open up access for more visits, right, with that particular individual. So, we cited in the fiscal note that the lower level mental health services that's provided in the particular state for kids under 18 is about $500 million a year. And we made our best determination in thinking about, okay, what would happen if we went from, the 3 visits and we played with some numbers, but we put in an estimate of about 20% of an increase of utilization by opening it up. I will tell you that, again, I will go back to, there's not a hard science based on that particular estimation based on other models that are not mature in this regard.
Yes, sure. Thank you, Madam Chair. I just want to confirm that the amount, how many visits you would be imagining if those 20% and greater utilization and how many visits would it take to reach that high number that you're predicting of cost wise?
I'll have to go back and look in terms of the record of the folks that put together the details of that. But again, we assumed about a 20% increase overall of kids under 18.
Okay. Any other questions? Delegate Alston?
Thank you. I'm just wondering, when you have children that are detained in the juvenile detention centers, are you all providing services to them there?
So we're happy to take that offline with you, Delegate Alston, and coordinate a response with our colleagues in the Department of Juvenile Services.
Okay.
Yeah, what I will also say there, Delegate Alston, in passed as part of the Consolidated Appropriations Act at the federal level, for all state Medicaid programs is to begin offering services to justice-involved youth January 1, 2025. So we are partnering, and I'm happy to send you the specific set of services that all state Medicaid agencies have to comply with pre-release, but there are a specific work group that we have with DJS that we're working on meeting those requirements by January 1, 2025. That obviously complements our work in some of the other justice-involved populations and Medicaid coverage that we're working on in terms of 1115 waivers.
Okay. So, so I'm not sure that I have a question or just something to start some thinking. You know, part of the rationale and the success of the ACA is its focus on preventive care. And I think what we're talking about here is preventive care. And in terms of mental health services, as wonderful as my primary care doctor is, she is not a mental health specialist. So I guess I'm wondering if we could be thoughtful and creative in a way to look at how could we, maybe it's not fee for service, maybe it's, you know, another way to address having up to 6, I hear 6 is California, sessions with a behavioral specialist, whether it be a social worker, psychologist, psychiatrist, whoever might be appropriate, so that we're going to be having the discussion around the bifurcation. So, but there won't be any resolution around that, I don't think, for at least 2 to 3 years, just because of its history. And so if we want to start helping young children now, I feel like we need to look at a workaround. So I would ask, maybe you'd work, Delegate Woods, with them to see if there's a way around this bifurcation, which is literally standing in the way of these students I'm a teacher, these children, you know, getting help early. And as Delegate Alston is reminding us, if they don't get help early, they get into trouble later. So just something to think about.
Thank you.
Thank you.
Any other questions? Seeing none, thank you all very much. And that concludes the hearing, let me make sure, on House Bill 1040. And we are going to House Bill 986, Delegate Lewis. You looked surprised. Yes, please. You.
Serena Ogunwole and Michelle Rouse, come up, please, if you're here.
It looks like they're here, Delegate.
Okay, great, wonderful. Okay, thank you so much. I'm Delegate Robin Lewis. Hi, ladies. Thank you for being here and waiting. Delegate Robin Lewis here on behalf of House Bill 986, the Maryland Medical Assistance Program coverage for the treatment of obesity. Thank you very much, Madam Chair and my colleagues. This is a bill. This is kind of a new idea. It was an old idea in new clothing. Let me put it that way. This bill proposes to make obesity treatment medications available under Medicaid reimbursement. This bill requires the state medical assistance program to provide comprehensive coverage for the treatment of obesity. And this includes approaches you're familiar with, like behavioral therapy, bariatric surgery, as well as new treatments, including FDA-approved anti-obesity medications. I don't have to tell this crowd about the significance of obesity as a public health problem and how it is an important matter for health outcomes. In Maryland, about 34% of people meet the criteria for obesity, and we know that some groups are more susceptible to conditions that drive overweight and obesity. There's social determinants that contribute. There's no racial or biological necessarily forces, but still there are treatments that can work. Obesity is defined as a serious chronic illness. It's associated with many comorbidities, and we have more ways to tackle it. Now, the other unique thing about this bill is it has, I believe, the largest fiscal note ever seen in the history of the Maryland General Assembly. I draw your attention to my amazing fiscal note. Now, states like Delaware and Pennsylvania have passed similar legislation. I believe they've found ways to minimize the fiscal impact. And part of the question here in estimating a fiscal impact, it really depends on the utilization of these additional obesity treatments, the FDA-approved medications. It depends on how broadly and extensively those would be used. That's what would define the impact on our budget. But that said, worth taking a look at. So I thank you for your consideration and ask for a favorable report. I'd like to turn the mic over to my panelists, and we'll start with Dr. Serena Michelle Ogunwole for her testimony.
Good evening.
And I hope I pronounced your name right.
Yes. Thank you, Madam Chair and members of the committee for the opportunity to present today. I first have to say that this testimony represents my own opinions and not those of my employer, Johns Hopkins. My name is Michelle Ogunwole. I am an assistant professor of medicine at Johns Hopkins University School of Medicine. I'm board certified in internal medicine, obesity medicine, and lifestyle medicine. I'm also a clinical researcher, and I focus and have expertise in obesity-related disparities in women's health. Obesity is a growing epidemic. It has staggering implications for health and mortality. It also is strongly associated with socioeconomic disenfranchisement, which is much more common among people of color. And what that means is racial and ethnic minorities, people with lower socioeconomic status, tend to have higher rates of obesity than other groups. Of course, the remedy for all of these challenges with obesity is weight loss. But what some people fail to recognize is that weight loss is not a question of willpower, but rather reflects a very complex biologic process. And what the science shows is that anti-obesity medications really hit this biological process head on. These medications have really been extraordinary. It's a breakthrough for us as clinicians, for our patients who really struggle with obesity, this very challenging disease. And it really, treating this condition really helps us address a very urgent public health crisis. The challenge, of course, is that these medications are very high cost, and people with inadequate insurance are unable to access these medications. And that includes people at the highest risk for this condition, which are the people who experience these disparities. House Bill 986 proposes the comprehensive coverage of obesity treatment, including medication. I'll wrap up. I said before that losing weight is not an issue of willpower, but it should be an issue of choice. What I know to be true is that in order to make a good choice, you have to have a good choice. And that's what this bill represents. So I ask for a favorable response. Thank you.
Thank you. Ms. Rouse?
Doctor.
Oh, excuse me, Dr. Rouse.
Oh, you're not? Okay. Stand corrected. Please go ahead.
We
Thank
can
you,
still
Madam Chair.
say that.
Yeah, I think I will.
Honor of you, yes.
A lot of doctors come through here.
Good afternoon, Madam Chair and committee members. My name is Michelle Rouse. I am currently the program coordinator for the Hopkins Healthful Eating Activity and Weight Program. The views expressed in this testimony do not necessarily reflect the views of Johns Hopkins. These opinions are my own. I'm here today to speak.
Ms.
for
Rouse,
the-
if you would put the mic a little bit closer to you.
Yeah.
I'm having a little hard time hearing.
Okay.
Thanks.
I'm here today to speak from the patient's perspective of living with obesity and being treated with anti-obesity medications. I have been struggling with obesity for over 30 years. What started with the freshman 10 that you gain in college was multiplied by life and having children. My actual diagnosis of morbid obesity was something that I've always felt somewhat ashamed about. I've been told the standard, eat less and move more by doctors over the years. I've tried Weight Watchers and every fad diet under the sun. In addition, high blood pressure was my constant friend. At my physical last year, my primary care increased my blood pressure medication for the second time in 9 months. I also was officially diagnosed as pre-diabetic. This was a complete wake-up call, and at 58, I was in full-blown panic mode. This added another layer of shame and embarrassment. I started on Wegovy, which is the anti-obesity drug medication, in August of 2023, and to date, I have lost 41 pounds. It's been a slow, steady, and healthy weight loss and has been the most weight I've lost in my entire life. My blood pressure is now within the normal range, so much so that I panicked thinking that something was wrong because it was so low. Because of my journey, I can relate to the frustrations of our patients who have tried everything to lose weight. While I'm fortunate to have a health plan that covers the cost of anti-obesity medications, Medicaid not covering them is yet another brick wall for patients. The messaging is that they aren't worthy of all the tools to help them achieve a healthy weight. The out-of-pocket costs are completely out of reach for many of them.
Go ahead and finish your thought.
Oh, thanks. All they want are the tools to achieve a healthy weight and live a healthy life. The ripple effect is true. As we lose weight, it has positive effects on other aspects of our health, blood pressure and joint pain, for example. I used to resign myself to being chubby and happy, but now I see that healthy and happy is possible. Please reconsider the coverage for these medications. Thank you.
Great, thank you very much. Questions for the delegate or her panel? Okay, seeing none, thank you. I guess you gave us enough information.
Thank you. Thank you, Madam Chair.
But
Thank
we have a number of folks who are going to supplement that information. And that is Stephanie Green, Scott Cahan, Anna Lunsford, Yolanda Hancock, and Kimberly Goodzone. If any one of those or all of those who are here, please come forward. Oh. Now, is the little one sleeping? Been very well behaved.
Yes, only had to leave the room once. That was great.
Who would ever like to go first?
Go ahead, just in case.
Just in case you go.
Yep. Thank you, Madam Chair, members of the Health and Government Committee, for the opportunity to speak on support of HB 986. I'm Stephanie Green. I'm a physician board certified in pediatric endocrinology and obesity medicine, and I treat children with severe obesity at Johns Hopkins Hospital, as well as Kennedy Krieger Institute, where I direct a clinic for weight management for kids with disabilities and obesity there. Many of the children I see have been suffering from excess weight gain since at the age of 5 years old or younger, some as young as 6 months. This is a chronic medical condition that is an interplay of environment and biologically dysregulated metabolism in these individuals. And without effective treatment, the causes lifelong progressive morbidity and mortality from the over 200 comorbidities associated with obesity, like type 2 diabetes, which can occur in kids younger than 10 years old. Studies show that lifestyle therapy alone in children only is effective in 10 to 20%, which is why offering FDA-approved medications currently prohibited under Medicaid and bariatric surgery in addition to lifestyle therapy represent the standard of care for these children that need it. And the younger we start effective treatment, the better the outcomes, lowering the risk of diabetes and increasing likelihood of reversing it if they already have it, which studies show is less likely to be achieved once they reach adulthood. Prohibiting the use of medications or surgery for low-income families leads to insurmountable health disparities and inequities.
One of the stated roadblocks I've heard to removing regulation against anti-obesity medications in Maryland is that it would be difficult to ensure lifestyle adherence. But many of my patients I treat, once they're on medications, they say that was the only thing that helped the lifestyle therapy be sustainable and actually impactful for their weight for the very first time in their lives. Furthermore, we don't prohibit the use of medications for asthma because you can't ensure allergens are removed from the home, or prohibit the use of antihypertensive medications because you can't ensure low sodium diet adherence. If we don't approve this law to ensure our vulnerable population receives the standard of care for an underlying medical condition, we leave over 80% of these children at risk for progressive disease or early mortality, in addition to the significant lifelong healthcare costs. So I would appreciate your support to pass HB 986. Thank you.
Thank you. Go next, please.
Good afternoon, everyone. Thank you to Delegate Robin Lewis for sponsoring HB 986 and to Madam Chair and the committee for allowing testimony. My name is Dr. Yolandra Hancock. I'm a double board certified pediatrician and obesity medicine specialist in support of this legislation. For nearly 20 years, I felt the frustration of adults and wiped away the tears of children when the numbers on the scale do not reflect their hard work in making lifestyle changes to lose weight. When it comes to obesity, there's often judgment placed on those dealing with the disease that their weight will improve if they just eat less and exercise more. For the over 1 million Marylanders dealing with obesity, I'm sure they wish that it was that simple, but it isn't. Obesity results from a confluence of behavioral, societal, and biological factors. Let's take my 14-year-old patient who has battled obesity all of his life. Statistically, the odds are stacked against him. He was born to parents with obesity, which puts him at an 80% higher risk of having the disease. As a Black adolescent, he is at even higher risk, as 35% of Black children in the state of Maryland are either overweight or dealing with obesity. If he's not successful in losing weight as an adult, he has an 80% higher chance of having obesity as he grows up. Thankfully, he's not aware of these risks. He's just committed to cutting back on his calories and exercising more, as many pediatricians have previously told him. He's doing all of the right things. While he's fighting the good fight, his body is literally fighting to maintain his weight. And it's incredibly disappointing every time he gets on the scale. Like my patient, others working hard to lose weight don't struggle because their willpower is weak, but because the body's drive to remain obese is strong, requiring the use of anti-obesity medications as a key tool to treat the disease. But without Medicaid coverage, a majority of those dealing with obesity don't have access. We wouldn't expect someone with asthma to work harder to stop wheezing. Instead, I, as a pediatrician, write covered medications in order for that child to be treated. Why should obesity be any different, especially when we know that it increases risk of chronic diseases like diabetes and hypertension? My patient and others like him are doing the work. Please support them by voting favorably for Medicaid to cover this medication.
Thank you very much. I just want to check, is Scott Cahan here? Anna Lunsford? Kimberly Goodson. Okay, let the record reflect that we called and they weren't here. Questions for this panel? Delegate Rosenberg.
Dr. Green, what's the long-term effect on someone's general health by dealing with by dealing with obesity at a earlier stage of life?
Yeah, it's interesting because the kids I see do develop disease younger, and the younger they develop obesity typically is when I see earlier disease status develop, like type 2 diabetes. What's also interesting is that kids that develop type 2 diabetes, for instance, which is what I know the most about being an endocrinologist, they have worse outcomes. So if you develop diabetes at 15, you're more likely to present at the time of diagnosis with already having eye disease, kidney disease, effects on your cardiovascular system. And those effects are not replicated in adults. So earlier treatment of obesity leads to prevention of earlier morbidity in that regard, and as well as mortality. The younger you are that you develop diabetes, the younger you are that more likely you have complications and earlier death and mortality.
Okay, thank you. Delegate Salega.
Thank you very much. So I was reading the bill. It looks like it's only for medication. Is that right? It's not for bariatric surgery?
It adds a Medicaid already.
Oh, it does. Okay, so it's adding just medication because it says that Medicaid currently covers it only for type 2 diabetes.
Actually, if I can find you.
But those are good questions. I actually would feel more comfortable to get someone from the Medicaid program to weigh in on that.
Okay.
That's my understanding.
Yeah, we'll talk offline.
Offline, but yes,
I'm
so
also happy to answer that question a little bit, just from the
Yes.
type 2 diabetes perspective. So I actually am waiting for many of my patients with obesity to develop type 2 diabetes because Medicaid covers Ozempic, which is semaglutide, which is the same medication as Wegovy. So type 2 diabetes medications that treat weight management are covered under Medicaid. But unfortunately, the patients have to develop type 2 diabetes before they can get them, which is unfortunate because, like I said, in teenagers specifically who develop diabetes, they may have already presented with a complication of it. It's a little bit too late at that point. And many of them can be reversed, which is why we should treat early, because we're looking at reversal, not just treatment, but reversal the younger we start anti-obesity medications.
And you're not finding any medical complications with giving those, I mean, they're fairly new.
So
For
then-
weight loss for children, I know in adults, it's becoming quite widely used.
Yeah, so there are complications of the medications. There's 5 or 6 that are FDA approved for weight management. One of them is basically never used. But of those medications, there's a few that are injectables. Those are the GLP-1s. Those are associated with some low risk of complications, including GI illnesses like gallbladder disease, which can also occur if you have significant weight loss quickly. But that's very, very few and far between. And that's the major complication we worry about is the GI side effects. The other medications, which are oral medications, actually don't have that many side effects when used together because they kind of balance each other out in terms of side effects. I'm specifically referring to glucemia, which is phentermine and Topamax combined. But even when you use those medications separately, they do have a list of side effects, just like all other medications you use. But in the kids that I use them in, I don't really see it. The only one I
Probably-
see with phentermine is insomnia.
Probably
maybe.
fewer side effects than the side effects of diabetes and
Exactly.
all the, obesity side effects. Thank you.
Exactly.
Thank you, Delegate. I'm going to go to Delegate Taveras and then to Delegate Alston.
Hello, Dr. Yola. It's good to
Hello.
see you again.
too.
Just for the record, where do you live?
I live in Prince George's County.
Okay. Let's check. Just a quick question on, I know that when we were working together over in Prince George's County, we were trying to work on implementing a health and all policies approach. Has there ever been a measurement of that level of impact in terms of overall obesity reduction in the county? Do you know?
It's an excellent question. We haven't. We've looked at various aspects of the walkability of the county, as an example, the concentration of fast food establishments, all of what we identify as the social determinants that influence risk of obesity, particularly in explaining why for Prince George's County, the obesity rates are as significant as they are. We usually associate obesity with lack of access to healthy food options, usually lower socioeconomic status. But as you know, that's not necessarily the case in our county, particularly related to socioeconomic status, but it is the case when it comes to food accessibility. And one of the reasons why this bill is so important is that particularly for patients who receive Medicaid, when you sort of overlay social determinants in terms of healthy access to foods, they usually are dealing with an environment that does not optimize healthy options. And so whatever additional tool we have available as we're working with them to navigate healthy food choices, it further strengthens our ability to reverse what I consider to be truly a pandemic when you look across the globe as it relates to obesity, but particularly in the state of Maryland. This is one of the key aspects. No matter where you live and what your socioeconomic status is, there's an additional tool that we can use to help you achieve weight loss.
You could join the Veterans Caucus to do the push-ups.
Right. Thank you, Delegate. Delegate Alston.
Thank you. I think we just like looking at the baby, which is why we keep asking
Right.
questions. It's
know
late,
I'm
but we
liking
really
it.
probably.
Happy to come back anytime.
Yes. I was just curious, one, what the cost of the medication is, like market rate, and if these medications are covered by private insurance.
Yeah, that's an excellent question. I'm sure either of us could answer that, but so the injectables are in the 1,000 to 1,500 range, out of pocket without insurance. There are some coupons that you can get out of pocket, but they're still close to about $1,000 even with coupons. The oral medications are more in the hundreds, and one of the oral medications, Phentermine, is about $20 out of pocket. So some of these are actually pretty affordable if you have the money to do so, and you have to pay out of pocket. The only one is Phentermine that's affordable out of pocket, really. But what I was going to say in terms of the cost is it was made in the fiscal note that this might cost about 1.1 billion per year to cover these medications if there's about a 20% utilization rate, which is probably an overestimate based on what we see in our practice in terms of utilization, as well as supply, right? I have patients that were approved for Wegovy in the fall and still haven't received it because it's not available. But what I wanted to say is that just looking at one of the over 200 comorbidities that add up in healthcare costs, let's look at diabetes. That's one of the ones that's most tightly linked with obesity. 90% of patients with diabetes are either overweight or obese. So it's a tight link there. So the cost in Maryland under Medicaid for type 2 diabetes treatment is 4.9 billion direct costs. Indirect costs is 2.1 billion according to the CDC. So a medication cost of 1.1 billion, you could see, is far below what we're paying for one obesity comorbidity that's most tightly linked. In addition, we're already paying for obesity treatment once you get to type 2 diabetes for Medicaid. So it doesn't make sense to wait until you have multiple comorbidities and other disease courses and hospitalizations, healthcare visits to pay for. Yes.
Where have I heard that before? Delegate Hutchinson.
Thank you, Madam Chair. I had somebody once tell me that if you get started on an anti-obesity drug, that you needed to stay on that your entire life, or if you stop, it just reverts back. Is that correct?
From the studies, that's what we see. And from clinical practice, that's what we see as well. There are some patients that we are able to wean down the dosage of the medication, and some that maybe come off with success. But for the vast majority, you can see in any anti-obesity medication study that once the medication is stopped, the weight gain comes back because we're treating an underlying condition. So if you stop treatment of hypertension, same thing happens with hypertension. If you stop treatment, asthma is not a good one because sometimes you get better with age, but hypertension is a great example of that. But the comorbidities are lifelong. So even though we're treating somebody lifelong for obesity, if we don't, we're treating the lifelong comorbidities that only become progressive and lead to more hospitalizations, more surgeries, including kidney transplants, liver transplants, amputations. So yes, they are lifelong medications, but it's possible that 1 or 2 anti-obesity medications prevents the use of 5 others, plus surgeries, hospitalizations, missed work, healthcare costs, et cetera.
Thank you. Delegate Morgan.
Yeah, thank you, Madam Chair. Just a quick question, because if we pass this, isn't that really signaling to the person that they really don't have any repercussions from controlling their own diet? Because they can control their own diet. Are we signaling to the people that, they can really eat anything they want? They can kind of continue with a bad lifestyle of dieting, but they can control it with medication?
I think it's important to understand that treating obesity isn't a singular thing. It isn't simply just giving them medication. As a provider who's done this for nearly 2 decades, I've not ever just written a prescription and sent them on their way. There's a treatment plan, and this is part of it. There are patients that eat probably less than any of us in this room, and their BMI does not budge because physiologically the body releases chemicals to bring your BMI down. The Biggest Loser is a perfect example. They're on the ranch, they lose weight, they go back home. They're eating very similarly to how they ate on the ranch, but instead of a metabolic rate of 1,800, because they've lost so much weight, now their metabolic rate is 800. I would like to see anyone in this room survive on 800 calories without some form of medication to assist. So it isn't just pop a pill, eat whatever you want. It's a combination of things. And I think for a lot of people who don't necessarily haven't been on a weight management journey, the assumption of the rest of us is we're like, oh, they're just going to eat what they want. No, all of my patients who come to see me have tried their hardest to eat right, to exercise, and they still haven't been successful. And it isn't because they're just doing what they want. It literally is their physiology fighting against them. The body is brilliant, and it will do everything that it can to stay where it is despite our best efforts. And that's where medications come in.
Question. Thank you for answering that. Just from own personal knowledge, I mean, we've seen the ads on the TV, especially with those Ozempics. It talks about the risk of medullary thyroid cancer. Do you want to touch on any of that? And just
Yeah, sure. So medullary thyroid cancer has only occurred in mice models. Not a single human case has been attributed to any of the GLP-1s or GIPs that are now on the market. And also, of those who study the thyroid, which is not myself, but my colleagues, they have said that the mouse thyroid is incredibly different than the human thyroid. So the fact that that will happen is pretty unlikely. We still screen for it, by the way, and don't, give it, there's a high risk. But.
Good to know. Seeing no further questions, thank you both very much for sticking with us and being patient and contributing to this conversation. That concludes the hearing on House Bill 986, and we will proceed to the last bill of the day, which is House Bill 1006, Delegate Gazzoni, Hospitals and Ambulatory Surgical Facilities, Surgical Technologist. And Delegate Gazzoni, you have Barbara Bricado, Dan Shattuck, Pierre Hargis, Charmaine Miller, Laura Embleton. Or any combination of those still here. And whenever you're ready.
Well, good afternoon, Madam Chair, members of the illustrious Health and Government Operations Committee. I realize that I am sitting here standing between you and dinner. And I'm also going to point out that we have a wide array of unfavorables that are between all of us. So, and dinner. So let's just dive in here. I'm Delegate Pam Gazzoni. I represent Howard County's District 13, and I'm here in support of House Bill 1006, which establishes guidelines for surgical technologist certification. Just a note, we do have sponsor amendments, which was provided to the committee earlier today. It essentially changes some of the timelines. Surgical technologists are the member of the surgical team that maintains the sterile surgical field to prevent surgical site infections. They are also integral to the prevention of never events, including medication errors, surgical implant errors, and surgical site errors, as well as unintended retained surgical items, like getting left inside of you, and patient burns. Currently, there are about 2,000 surgical technologists in Maryland, and it unfortunately is a medical position with one of the highest vacancy rates in the state. This bill would establish certification requirements for the position, including that surgical technicians must graduate from an accredited educational program and pass the certified surgical tech exam. It is certainly a priority to address the shortage of surgical technologists, but it is also important to ensure that these folks are properly trained. This bill, as currently drafted, includes exceptions for currently employed surgical techs who do not have the education background, and gives them a window in order to complete that, as well as military trained techs. This is not a new licensing regime. Healthcare facilities will verify the surgical technologists, and apprenticeship experience can be used as the clinical experience in the credentialing program. Thank you for your attention, and I request a favorable report on HB 1006.
Okay, thank you, Delegate. Who would you like to go next?
Let's start with Dan.
Okay.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Association of Surgical Technologists in support of House Bill 1006. I want to thank the delegate for introducing the bill and also for the great overview. This is a profession that plays an important role in the healthcare system of Maryland. They're the folks that are in the room when you're in the room asleep, getting your surgical needs taken care of. And as the good delegate said, they're the ones making sure that everything is prepared and ready to go. And they work in concert with the surgeons and the other technicians in the operatory to make sure that everything flows well, that materials are there that are needed by the surgeon, and that, things that are used are not left in the body when things close up. So in this space, we are working to make some changes to the bill. We put in some amendments already to extend the time frame that would allow that the surgical techs that are already employed in the state of Maryland can continue in that if they don't have the certification. The amendments also seek to extend the amount of time an individual has to get certified, once the bill passes. But we have had some conversations with the Hospital Association and others. We understand there's concerns about the hiring requirements. We're pledging to work with them over the interim to see if we can find the right path forward on this issue, because it is important. This is an important workforce that we want to make sure has the highest level of training. It's to the benefit of the patients, it's to the benefit of the hospitals and the surgeons that they're working with. So I'll stop there. We have, in addition to Barbara, someone virtual who can answer more questions about the history and so forth of the profession, but thank you.
Great, thank you.
Thank you, Madam Chairman, members of the committee, and Barbara Brocato here on behalf of the Surgical Technologists Association and in support of 10006. I do just want to say, because I'm saying this for Dan, we have the privilege, Dan has the privilege of us being here with you to the last bill for yesterday and today. So, hey, okay, I'm using up my time. We're talking about safety. We're talking about workforce issues. I want to thank Delegate Gazone. I want to thank the committee. I also want to thank Pegeen for spending the time that she spent with us discussing the hospital's concerns here. We need some standard that applies across the board. Hospitals around the state are all doing different things. What this would do would be grandfather in everybody that's working, that is part of whatever training program a hospital chooses to use. And in many instances, it's their own, and it can be a weekend program. We do have 7 programs, community college programs across the state that do work with the standards that are embodied in this legislation. And we would just say, you may recall the stresses on the system right now, healthcare system, I guess in my sense, and I've been working healthcare issues here for maybe 30 years, that the stresses are as intense as ever. And you might remember during COVID or right after COVID, the error rates in the hospitals skyrocketed. It's stress. They're stressed in the system. So we're trying to develop a uniform system. We want to work with the hospitals on this issue and with you. So thank you very much for your time and consideration.
Thank you. Perfect timing. I'm going to go to Laura Embleton, who's virtual.
Madam Vice Chair and members of the committee, my name is Laura Embleton, and I am the Senior Government Affairs Manager for the Association of Surgical Technologists, and I'm testifying in support of House Bill 1006. I know this has been a long hearing, and I appreciate your consideration of the bill. I'll try to keep my testimony brief. AST has nearly 55,000 members nationwide and 626 members in Maryland. According to the Bureau of Labor Statistics, there were 1,930 surgical technologists in Maryland as of 2022. Surgical technologists are the surgeon's co-pilot in the operating room. The surgeon focuses on the surgical site. Prior to surgery, the surgical technologist gathers the instruments to be used in surgery, knowing what is needed. During surgery, the surgical technologist is by the surgeon's side and hands those instruments to the surgeon. They watch for surgical smoke and fire and keep track of instruments used during surgery to ensure none are left in the patient. In addition, they maintain a sterile field in the operating room to cut down on the risk of infection. Trained surgical technologists complete accredited surgical technology programs that are associate degrees. These programs are comprised of a didactic education that trains surgical technologists not only in anatomy and physiology, but also help develop critical thinking skills needed in the fast-paced operating room. There are over 400 accredited surgical technology programs nationwide and 7 geographically distributed programs in Maryland. 13 other states have similar statutes, including Connecticut, Virginia, New York, New Jersey, Massachusetts, Pennsylvania, Idaho, Indiana, Nevada, Texas, Oregon, Tennessee, and South Carolina. House Bill 1006 would require educated, informed, and prepared professionals working in operating rooms in the name of patient safety and risk management. Thank you for the opportunity to support House Bill 1006.
Great, thank you. Okay, let me open it up to the committee for questions. I was looking, Delegate Hill. It was like, that's where my eyes went, Delegate Hill.
Thank you, Madam Chair, Madam Vice Chair. Thank you, Delegate. I'm just wondering, I don't really understand what the problem is and who initiated this legislation. What is the problem we're trying to solve here? I've spent a lot of time in operating rooms and have seen OR techs be real opportunity for people to advance from working in other positions in the hospital to get into technically trained things and do good jobs at it. So what's the problem we're trying to solve here?
I think the issue is to, as Barbara said, standardize the training and the profession. There is every hospital has their own process. Some hire certified technologists, some have on-the-job training programs. There's a myriad of ways out there, but this is a growing field. They play an important role in the patient safety aspect of surgical care. And by aligning standards to the certification process, we have 7 programs in the state of Maryland that produce students who have the didactic and clinical training to qualify and get their certification. And that provides some mobility to this workforce. So they can carry that with them across the state, regardless of, which hospital program they might have, if it's, strictly on the job training or some other program. It's a way to, we think, strengthen the profession and give it more value and emphasis.
Yes, thank you. So again, I'm trying to figure out where this came from. Are the technologists, the newly trained technologists complaining that they can't go work other places? Or are the people who came through other programs, med tech programs, and weren't being trained in the hospital? Who's complaining?
I don't know if there's a complaint as much as this is the growth of the profession. This is the evolution. I don't, and I could look to Laura on the screen. She's the national person. She might have more perspective on that.
I guess I have to ask a follow-up question.
Yeah.
Go ahead.
All right. Can you explain, we have a habit here on this committee of asking what's the problem we're trying to solve. I'm asking what is the problem we're trying to solve, particularly since, there are people who do only eye cases and they become experts at eye cases. There are people who only work in surgical centers and people who only do GI cases. And some people can do a whole brother, know all the instruments and they're used to doing. So I'm trying to get a sense of why are we going to put more training under this profession, which has been a gateway profession for many people.
Laura, that's
Oh,
you.
I'm sorry. I wasn't sure who that
Yes,
was addressed to. I apologize. So there are issues when hospitals go into on-the-job training. A lot of times what they're asking the already qualified surgical technologists to do is to actually train those individuals, which is taking them away from the job that they've been trained for. So certified surgical technologists, and like I said, there's 7 programs around the state that are producing students to come in and work, and they have the didactic education, and they have a skills lab before they even go in the hospital or the operating room for the clinical training. And this is all before they start getting their job and moving on from there. And so those people are really prepared once they step foot. It's a lot different than bringing somebody in from an on the job. I've heard across the country of hospitals in such need of surgical technologists that they'll go down to the cafeteria and say, hey, we got this job for you, let us train you. And that person's kind of like thrown in the deep end and trying to figure it all out. And so this bill would require people to have that kind of education before they get into the hospital room. And I've heard tell in Maryland that many surgeons prefer the certified surgical technologist over the on-the-job trained technologists, but they are worried about saying anything out loud for fear of reprisal and things like that. And so we'll have testimony tomorrow more on that from people that are in Maryland locally and can tell you anecdotally what's going on there. But so we wanted to bring this, we are the ones that brought this because of where we think the profession needs to be. It's not like we're asking for a bachelor's degree or a master's degree or anything like that. It's just making sure for patient safety issues that we have somebody who's trained and prepared to be in the hospital room from the second they get there, into the OR room from the second they get there, to be able to work with the surgeons and address all of these issues that go on in the fast-paced operating room.
Thank you. Thank you.
Sure.
Delegate Bagnell.
Thank you, Madam Chair. And I think I essentially have the same question as Delegate Hill, but maybe from a different approach. Because I heard that we were trying to do standardization, but also address the workforce shortage because people are overworked, but this is actually going to reduce the workforce immediately available, and the technologists may have to be training other surgical techs. So again, I'm trying to figure out what problem it is we're trying to solve. And is this a bill for standardization, or is this a hospital regulatory issue?
Well, Delegate Bagnell, let me try and answer that a bit. So it's, your last question, is it a bill it's not to try and regulate hospitals. And it is a bill that is intended to, as was said earlier, have a professional track that when somebody is in that OR working with that surgeon, they have had some basic experience in training and education. And I think, and I'll have to, look to my client, we think that that is an incentive to have a professional track so that will attract, and it's been passed in 13 other states. I think we're still in the early stages of seeing the impact in terms of how that affects the workforce. But I will try to find that out for you, because what our hope is that it's not going to diminish the workforce. It's going to enhance the workforce. And we are also saying we are not going to push anybody that is currently working in the system out, that we are going to grandfather in. And I think even in the amendments that are being offered, there's a delay in the implementation of this. So it would be a delay of a year plus grandfathering everyone that's currently working in the system. You have situations, as I understand, as I'm learning from the surgical technologists, you have system in hospitals that it's like a mishmash or a difference. There's some that are certified and some that are in a weekend training program. There's a whole array of different standards that are applied. So we're always striving to have the safest care possible. We see this as an effort to work collaboratively with the hospitals. They've been, very open in their willingness to discuss this. And what I would say is that I would work to, in the states where they have passed this, try and get some information on what this has done in terms of workforce.
Have another follow-up? Okay. And so I just wanted to confirm you are working with the hospital association, because we do have an association that works with the entire hospital system. Because it sounds like the standardization is more in like real time than necessarily in the training, because we do already have these multiple pathways of surgical technicians already, or surgical technologists already working in the hospitals. So you are working with the hospitals, to the hospital association?
We're not working with them. We met with them to go through the bill, and they expressed their concerns, which they will express, I'm sure, when they get up and testify. And we just have expressed our willingness to work with them in terms of the goals that we have in terms of having a qualified workforce and how that fits within their system. So we're not working with them. We've met with them and talked about the issues.
Delegate Johnson, then Hutchinson.
Thank you, Madam Chair. What additional education, if they're certified, what additional education are you asking them to receive?
We're asking them to reach the point of certification. Yeah.
Thank you. Thank you, Madam.
Delegate Hutchinson.
Thank you, Madam Chair. I'm going to direct my question to Ms. Embleton. In Barbara's opening comments, she said that this is going to solve a workforce shortage issue, and I'm not seeing that clearly at all, how this is going to help with the workforce shortage. Could you elaborate on that?
Sure. We think that there's probably somewhere between 10 and 15 people going through each cohort a year. And so that puts qualified people into the workforce. Another way that we can address the workforce shortage is to work with the hospital systems on apprenticeships to move the people while they're still in school and doing their clinicals, to having them work with the hospital in more of an apprenticeship kind of position. So they're getting trained in the hospitals and then they get hired by the hospitals at the end of the training, at this the clinical training. It's not gonna frankly address all of it because there's so many hospitals and there's so many ambulatory surgical centers in the state. And that's why we have such a generous grandfathering clause in there and push that out so that we've got a couple years to really beef up the workforce.
Thank you.
Sure.
Any other questions? Seeing none, thank you very much for your testimony and for being here. Next, we have a panel of unfavorable, and that is Grayson Wiggins, Pegeen Townsend, Thomas Young, Richie Kundi, Eric Candia, Dina DiMarino, Kristen Bryce. And if you can just pull some chairs, that would be great. Good afternoon. Will you please get started?
Thank you, Madam Chairman. Peggy Townsend on behalf of the Maryland Hospital Association in opposition to this bill. Surgical techs have the highest vacancy rate amongst our job categories in hospitals. It's at about 18%, very high. So hospitals have struggled to find other ways to get folks trained up. And there are a variety of ways. And let me emphasize, this is a pretty much an entry-level job, and it leads oftentimes a pathway to higher level jobs. So I want to make sure you understand that. But the multiple ways people can enter the profession include community colleges, vocational schools, universities, hospital grow your own programs, workforce intermediaries, such as the programs, the EARN program funds, high schools. I think you're going to hear about a high school program, the military, and apprenticeships. So there are all of these ways to enter the profession, and we need every single one of them. We need to meet people where they are, try to upskill once they get in, and really try to garner a professional workforce beginning at the entry level. So for those reasons, we would ask for an unfavorable.
Next, please.
Good evening. Oh, is it evening now? Good evening, Madam Chair.
It is indeed
committee members.
6:11.
My name is Thomas Young, and I am one of two nursing directors at the University of Maryland Medical Center Midtown campus. Prior to that, I was the manager of the operating room at the University of Maryland downtown campus that included 37 operating rooms to include the shock trauma operating rooms. I'm a CNO certified nurse in the operating room with a master's degree in healthcare leadership. This is my current reality, but let me tell you where my healthcare career started. 25 years ago, I was working in different warehouses until an opportunity presented itself. That opportunity came by way of a federal empowerment zone grant. That grant funded a certificate program for surgical technology. This program did not grant a national certification. I enrolled and was a member of the second graduating class. I graduated valedictorian and was presented an award by the late Congressman Elijah Cummings. It is not my desire today to come here to discuss my accomplishments. However, it is my desire to speak to how the certificate program has changed the course of my life and my family's life. Delegate Hill, this was an entry portal for me into the healthcare field. Without this certificate program, none of the aforementioned achievements is possible. None of this happens. And there are many stories like this, including my wife, who manages the Central Sterile Department at Roy Hospital. More than anything, these programs offer exposure that a young man from West Baltimore wouldn't otherwise get. I believe House Bill 1006 will limit that exposure. Thank you.
Next, please. And it's great to hear your testimony. All right, and to see you in that role. Thank you for being here. Next, please.
Thank you. My name is Rishi Kutty. I am a surgeon at the Artemis Colley Shock Trauma Center, and I felt obliged to come before you and explain why passage of this bill would not only harm our ability to take care of Marylanders, but would hurt our current staff as well as our relationships with the people of Baltimore. Obviously, it's been mentioned since the pandemic, the hospitals have suffered staff shortages across the board. Surgical techs have not been spared. At Maryland, we currently only have 59% of the techs that we need to operate at normal pre-pandemic capacity. We have enough trainees in our apprenticeship programs to bring that number up to 3/4 of normal by the summer. A surgical tech is an absolute requirement for surgery. I don't have a tech, I simply cannot do a case. I can't take their place. You would think that I could. According to the bill, a degree is what matters and certifications, and I have plenty of those to spare. The fact is that it's experience, training through apprenticeship that makes a surgical tech. To that end, the University of Maryland maintains joint training programs with Edmondson Westside High School, community colleges in Howard County, Baltimore County, and in-house and city programs. Surgical technology, as we heard, is a fast and effective way for people in Baltimore to join our healthcare system and take care of people in Baltimore. It's a way for any employee of the University of Maryland to join the surgical team, no matter where they started. It's a way in and a way up. Most of our existing apprenticeship training programs are supported by grants and hospital funds. When the university found out that some of our high school trainees were working part-time jobs in addition to their apprenticeships in school, we started paying them for their time so they could focus on their apprenticeship. To put it directly, the proposed bill would seriously impede our ability to take care of patients. It would close off a path for people in and around Baltimore to start a career in healthcare. And it would do all of these things by demanding, among other things, a degree that is completely unnecessary, that would serve no practical function, and that would be a waste of considerable cost of tuition. I would like to add that the American College of Surgeons, with whom the AST certifies techs, actually does not support universal certification for surgical techs. That's the organization that represents me, and it's the organization that goes towards the certification programs that we're talking about. They don't recommend it across the board as universal.
Thank you for your testimony and for being here today. Next, please.
Good evening, Madam Chair, members of the committee. Grayson Wiggins here on behalf of my client, Employee Prince George's, which is the fiscal and operational agent for the local Workforce Development Board in Prince George's County. My client provides workforce development services to more than 25,000 people a year, and we work with hospitals and the Maryland Hospital Association to provide training services to individuals to get them connected with career pathways, to Delegate Hill's point. And we are supportive of non-traditional career pathways, and given the state's emphasis recently on apprenticeships with the 2030 Apprenticeship Commission and again, non-traditional career pathways, my client is concerned with the bill is attempting to remove pathways to careers. And so for that reason, we are unfavorable. Thank you.
Thank you for your testimony. Next, please.
Good evening, Madam Chair, Madam Vice Chair, members of the committee. Thank you for hanging in there this long. I was going to say that I don't think I could say better what Mr. Young said himself or what Dr. Kundi testified to. Where I'm coughing, I'm not sure I'm going to be able to say it at all. But what I do want to say is that, University of Maryland Medical System, we say all the time that entry-level healthcare careers are a pathway to the middle class. They're a way for families to pull themselves out of poverty. And I just think this would be a real mistake to take this bridge away from the communities that we serve, from people who want to join our workforce and have so much to offer. And I just, again, don't think there's a better example of that than Mr. Young, and I appreciate him being here for so very long today. So thank you.
Thank you. And thank you for being patient as you're the last bill, right? You also waited, so we're grateful. Next, please.
Thank you. My name is Tina DiMarino, and I'm here on behalf of the Maryland Ambulatory Surgery Association. I'm a board member. I'm also a certified OR nurse. I've been in the business for 23 years. I've also worked with a consulting company, management company. So we work with ambulatory surgery centers in Maryland and also nationwide. We oppose this bill. We're concerned for everything that everybody has said here, but that it's taking away the multiple pathways to become a surgical technician. I myself have trained several receptionists up through and becoming the #1 tech that the surgeon wishes to utilize. And then they've went on to higher levels in healthcare themselves. So again, echoing what we've already heard here, ASCs are experiencing a vacancy rate of 16% higher than that of the licensed nurses' vacancy rates. So it's limited. We fear that this bill will limit the options for entering the surgical tech profession, that this will exacerbate this situation and also limit opportunities for individuals wanting to enter the healthcare workforce. We are also concerned that for those who are acting as surgical technicians right now in the latter part of their careers, they're not going to want to go back and have to do certification. Those who have been already working in the industry for 20 years. This bill is being promoted to protect patient safety, despite the fact that there are no safety concerns or reports from the ambulatory surgery center perspective for patient safety issues. Again, I've worked in the industry for 23 years. I've seen techs who have went through our ASC's apprenticeship program be #1 in the doctor's eyes. Some have went on to become certified, but most have not. So if we're going to address the healthcare workforce shortages, we need to consider creative solutions. And for those reasons, we're asking for an unfavorable report.
Thank you for being with us today. We appreciate it. I'm going to open it up for questions now, okay? Are there questions for this panel? Well, you were really good. Anyway, we thank you for providing your testimony, and we also got a lot of your written testimony that we read as well, okay, that we will consider. So thank you for being with us. I really appreciate your time. I hope you have a safe travel going home. We have one more person, actually two virtual and one person named Eric Candia. Is Eric here? Eric Candia? No? How about the 2 virtual witnesses? They are here? Thank you. And we're almost done to the committee. Good evening, ma'am. Is there Laura Embleton? Is that the person? She was favorable. All right, how about Dana Van Lees? Is that it? Dana Van Lees, will you be so kind and unmute yourself, please?
Yes, I'm.
Please.
Hello. Hello, can you hear me now?
You just don't want us to leave, right? You're standing, you're our last witness.
Hi, can you hear me?
Yes, we can. You can get started. And thank you for being patient as you waited. Go ahead.
Okay, you can hear me. All right. Hello, and thank you, Madam Chair. I appreciate it. I know it's been a long day. Thanks for the opportunity. Delegate Gazzoni. Delegate Gazzoni, thank you. All right.
You can go ahead.
Delegate Gazzoni, thank you for meeting with me to hear our concerns and explanations about this bill. And for the record, I'm Dana Van Lees, Senior Vice President of Government Affairs for the National Center for Competency Testing, and we oppose House Bill 1006. You've already heard from several that it's not good to compound existing staffing shortages by creating more roadblocks for employers to recruit and adequately staff their operating rooms, especially in this climate. The language in this bill creates barriers to entry by forcing this associate's degree level when it's not necessary or required to do the jobs, which these people beautifully said. There are several surgical techs in the workforce that are successfully, safely, and competently performing their duties without a dictated path to how they learned their skills. So I want to clarify a couple things. Standalone U.S. Department of Labor apprenticeship programs and the hospital-based programs won't be able to earn accreditation through these accreditors because they'd have to partner with someone that offers an associate's degree and use AST's specific curriculum, which this is also barriers. There are also DEI obstacles to providing care in rural and underserved communities. If you look at Oregon, Oregon needed to pass an emergency apprenticeship bill to fix their policy mistake that they had made because these training programs were not able to keep up with the numbers needed in that state. Virginia just fixed it last year too. There are other states that have put together information to have to fix their policies that they've passed in the past. So with that, there's no evidence supporting these, and I think Maryland's surgical facilities would be best served by leaving employment decisions in their hands instead of legislating who they can and cannot employ in this role. So thank you so much. And I'm happy to answer any questions.
Are there any questions for Ms. Van Lace? Seeing none, thank you for being with us today and thank you for being patient, okay?
Well, thanks for your time. I'm sorry it was hodgepodge. My feed is delayed from you, so sorry about that.
Don't worry about it. It happens and we're okay. Thank you for being here. This actually concludes the bill hearing on House Bill 1006 and the last bill of the evening, because it's evening now, almost 6:30. I hope you have a safe trip home. Thank you for being with us. We really